It is Silver Jubilee celebration of Sushrut Eye Foundation and Research Hospital. So to start the proceedings, I like to invite Dr. R.C. Paul for the welcome address. Sir, please.
Good morning. I do welcome all of you in this August meeting, Oculoplasty update. It is a part of our 25-year celebrations. Every month we are doing 2-3 programs. So one of the program is the clinical updates in the CME. So I convey my best regards for coming today in Sunday morning here in the auditorium. I also convey my gratitude to two young faculty coming outside of this state, especially Dr. Surjosnato Rath and Dr. Nandini Botra has taken the pain leaving their job. They have joined us. Sir and ma'am, please take our best gratitude. We are very happy and we are humbled and we are honored. And definitely our speakers of the state, I must congratulate Anirban Baduri and his team for organizing this beautiful one. So now I request Dr. Shahid Alam and Dr. Kumkum Ghosh for moderation of the first session. Thank you.
Sure. Thanks, sir. Thanks a lot. So we'll be starting the first session, which will be focusing on eyelids. So to start the session, I'd like to welcome our chairperson, Professor Prag Mukhopadhyay, former president of Ophthalmic Society of West Bengal. Sir is there. Then our panelists for today, let me introduce you to them. Professor Salil Mandal is a professor, Department of Oculoplasty, RIU Kolkata. Professor P.K. Jash, Professor, Department of Plastic Surgery, Calcutta Medical College. Dr. Nandini Bothra is a consultant at Govind Ram Saxena Institute of Dacryology, LV Prasad, Hyderabad. And Dr. Sureshant Rath, consultant and head of Department of Oculoplasty, LV Prasad, Bhubaneswar. Myself, I am Dr. Shahid Alam. I am Oculoplasty consultant at Shankar Netralaya, Kolkata. And me, along with Dr. Kumkum Ghosh, senior ophthalmologist at Sushrut Eye Hospital, will be moderating the session. So to start the session, before starting, I'll just like to give a small reminder. I like you all to kindly stick to a time so that we can finish on time. Finishing on time is a great thing. So, and the questions will be taken at the end of each session. So if you have any questions regarding any speaker, kindly write them down so that we can take them at the end of the session. So Dr. Shreyasi Sarkar, who is a fellow Department of Oculoplasty at Sushrut Eye Hospital, will start the session with her talk on lid margin and malposition, mostly in tropion and ectropion. Dr. Shreyasi.
A very good morning, everyone, and warm welcome to Sushrut Eye Foundation and Research Center. So I would like to start with lid margin malpositions. So basically, this is a revision of a brief anatomy of the lid margin. This is the pre-septal orbicularis, and this is the pre-tarsal orbicularis. So we can see here the upper eyelid retractor, that is LPS aponeurosis, and here the capsulopalpebral fascia. These two will have a major role in the pathophysiology of entropion and ectropion. So the factors which maintain the normal eyelid position are the lower lid retractor's downward and posterior pull on the tarsal plate, the canthal tendons, and there is an interplay between the anterior and the posterior lamellae of the eyelid. So basically, entropion is inward rotation of the eyelid margin. It is divided as congenital involutional, acute spastic, and cicatricial. Involutional is most common. So here we see there is laxity or dehiscence of the lower lid retractors. Here we can see a bump, which is mainly the overriding of the preseptal over the pretarsal orbicularis. And there is horizontal lid laxity, that is of the canthal plate and the tarsal plate. So we do a pinch test for testing entropion. We do a eyelid distraction test to diagnose the condition. So basically there are a plethora of techniques for correction of the entropion, and among them the most important ones which will serve the purpose are the lid everting sutures, which are very basic and even we can do on the bedside in case of emergency purposes, and Jones procedure where we reattach the capsulopalpebral fascia, and the lateral tarsal strip, which is a very useful procedure for correcting the laxity horizontal. So a brief video of the Jones procedure with LTS. Here, after giving the traction sutures, we are putting a lid plate. We are giving a skin incision 4 mm from the lid margin. Then we are dissecting with a monopolar. We are dissecting the orbicularis. After that, we will go for the suborbicularis dissection. Basically, beneath the orbital septum, we have to find the pad of fat, and beneath it, we will see we have to identify the LPS. So this is the white thing beneath the pad of fat. We have to identify the LPS. We will confirm it with asking the patient to move his eye up and down. We can feel a strong tug. Yeah. So now we are moving to the lateral tarsal strip. That was the part of the Jones. Lateral tarsal strip, we do a canthotomy, cantholysis. Now we are fashioning, dividing the anterior and the posterior lamellae, and we are fashioning a tarsal strip of adequate size. So conjunctival side we will cauterize, and now we are dissecting. We need the periosteum. We need to see the periosteum at the lateral canthoid orbital rim, and we are excising the excess strip. Now we'll fix that part of the tarsal strip to the periosteum with polyester 50. So the lid becomes shortened. We will redundant skin we can excise. Now we are coming back to the Jones. We are fixing this capsulopalpebral fascia. Yeah. So this is it. I'll go to the next slide. So this is the pre-op and the post-op pictures. Now coming to cicatricial entropion, here we can see the cicatrization. There is scarring of the posterior lamellae. So for these cases, we do a tarsal fracture with lid margin rotation. Also, we can put a mucous membrane graft in case of severe cases. This is a small video of this tarsal fracture. So we're giving a full thickness incision through the line of scar, the tarsal plate, giving 2 relaxing incisions. Now giving mattress sutures to the tarsal plate and everting it. Another entity is congenital entropion. Mainly epiblephron and true congenital entropion has to be differentiated. In case of epiblephron, if we ask the patient to look down, the eyelids will start touching the cornea. We do a HOTS procedure. We excise a part of a spindle of the skin and the muscle in this case. Now coming to ectropion. Ectropion is outward rotation or reversion of the eyelid margin. It is classified as congenitally, involutional, cicatricial, paralytic. So there can be punctal eversion or complete ectropion. So for surgical correction of the punctal eversion, we do a medial conjunctivoplasty and ectropion of the lower lid. We have to do the horizontal lid lightening, reattachment, the same. We do a LTS, we do a Jones. There can be tarsal ectropion where there is complete eversion of the tarsal plate. So here we do all this, Jones, LTS plus inverting sutures. This is a patient of facial palsy, paralytic ectropion. It will be covered in details in the next talks. So this is a patient of cicatricial entropion where a full thickness skin graft was done and also a secondary orbital implant was given to the patient. Afterwards, with artificial eye, we can see the nice post-op result. So basically, learning a few surgical techniques will tackle most of the cases in case of this lid malpositions. Thank you.
Okay, thanks, Shreyashi. So we'll take the questions in the last.
Okay.
So yeah, just to summarize it, lateral tarsal strip actually is a workhorse procedure for both involutional and involution, entropion and ectropion. We used to do a lot of tarsal fracture when trachoma was quite prevalent for cicatricial entropion, but yeah, it's still very useful in cases of SJS syndromes. So we'll move on to the next talk, that is on ptosis management, and it will be given by Dr. Sri Purna Ghosh, and by that time I'll request Professor Parag Mukhopadhyay to kindly hand over the momentum to Dr. Shreyashi. Dr. Sri Purna Ghosh is a consultant in Department of Oculoplasty, NRS Medical College, Kolkata. Please.
A very good morning to the august gathering here. I would like to thank Dr. Anirban Bahaduri sir and Shushruth Eye Foundation for providing me this platform. And I would like to thank my mentor, Dr. Kasturi Bhattacharjee, who has taught me the ABC of oculoplasty. I will be talking about ptosis management today. So we have classified ptosis into congenital, acquired, and pseudotosis, which again may be subclassified into various types. We'll be coming to each type separately. Now, for the management, the history must be noted carefully. The onset, the progression, and the duration of the disease is a must-know. Serial photographs, if possible, must be taken in each case. Any family history, if relevant, recent history of trauma, and history of OP poisoning must be ruled out. The severity of the disease, the diurnal variation if present, any precipitating factor like any drugs or pregnancy, and any associated factors must be taken note of. Now coming to the examination proper, the head posture, the ocular motility, and the frontalis overaction must be checked. This is the ocular motility in the 9 cardinal gazes. Now coming to examination of the periorbital skin, proper examination of the skin must be done. And in case of strabismus, strabismus must be measured with PBCT. Telecanthus must be examined. Lid position in down gaze must be examined. The Bell's phenomena is a must before undertaking any surgical procedure. Synkinesis must be ruled out. The best corrected visual acuity. The fundus examination, especially in case of Kearns-Sayre syndrome. The pupillary reaction is relevant in case of ptosis due to Horner syndrome or due to third nerve palsy. Now coming to the measurements proper, the amount of ptosis is based on the palpable fissure height, the MRD1 and the MRD2. Other than this, we have the margin crease distance and the margin limbal distance which needs to be measured. The LPS excursion gives us an idea about the type of surgical intervention we are planning for. Now this is the palpebral fissure height, the MRD1, and the margin crease distance. A normal LPS excursion from extreme down gaze to extreme up gaze after negating the frontalis action varies from 11 to 15 millimeter. Anything less than 4 millimeter is a poor levator function. Now coming to the tests per se, the fatigue test, the ice pack test, and the test is a must do. For ruling out this, we need to go for anti-acetylcholinesterase antibodies and repeated nerve stimulation test. Phenylephrine test is a must do for Horner syndrome. Schirmer test, T-BUT, and corneal sensation must be checked for each and every patient before we plan any surgery. Now a young patient comes to us with ptosis since childhood, with an absent lid crease, poor levator function, and a lid lag on down gaze. We know it is a case of congenital ptosis. This lady comes to us with a ptosis in the left eye, and we see on movement of the jaw there is lid hopping in the ptotic eyelid. So it is a case of synkinetic ptosis. This lady has a family history of bilateral ptosis and and telecanthus. Though epicanthus inversus is absent in this case, it is a case of BPES syndrome. Now, an old patient comes to us with thin, papery skin, long-standing ptosis, and a good LPS function, and raised lid crease. We know it is a case of aponeurotic ptosis. Now, this lady had a sudden onset ptosis. She is a 72-year-old diabetic patient. On lifting the lid, we see there is extreme restriction of extraocular movement except in the lateral gaze. So, it is a case of neurogenic ptosis. The other variety of neurogenic ptosis is Horner syndrome, which can be remembered with this small mnemonic: anhidrosis, meiosis, ptosis, absence of ciliospinal reflex, and enophthalmos. This man comes to us with a ptosis in the left eyelid. We lift the lid and we can feel the baggy worm's appearance. It is a case of neurofibromatosis causing ptosis. Similarly, S-shaped upper lid in case of this young lady. We evert the lid. We had sent this for biopsy. It is a case of neurofibromatosis. Pseudotosis is when there is no eyeball in the socket, anophthalmic socket, or there is any phthisis bulbi. This lady comes to us with a ptosis in the left eye and an extra fold of skin in the right eye. On corroborating other findings, she had a double lip deformity and non-toxic goiter. So this is a case of Asker's syndrome. This man comes to us with a variable ptosis in the right eye. We ask him to do a Valsalva maneuver. So this is a case of vascular malformation. Now coming to the management per se, non-surgical clutch glasses often may be cumbersome. So when we decide about surgical intervention, there comes the decisions. We need to weigh regarding the risk of amblyopia, and if there is risk of amblyopia, we go for an early surgery. If there is no risk, we can wait for an appropriate age. Now, depending upon the LPS function and the amount of ptosis, various surgical procedures have been propagated. Like Fasanala Servat or MMCR can be done for a mild ptosis with a good levator function. For a moderate amount of ptosis, we can go for levator resection or aponeurotic surgery. For anything less than 4 millimeter, we go for a frontalis flap or a frontalis sling. Sling materials again can be autogenous and non-autogenous. So for a mild ptosis, a Fasanala Servat procedure is a good option, or a MMCR may be done, for which various authors have proposed various protocols. Dresner says for each millimeter of ptosis, 4 millimeter of Muller's muscle and conjunctiva must be resected. Now, Beard has proposed this protocol for the amount of levator resection based on the degree of ptosis and levator function. But I think so for many surgeons like me, it is easier to assess the intraoperative lid height. I always assess the intraoperative lid height, if possible, in sitting position after putting the adjustable suture. So we put a lid crease incision or a blepharoplasty incision. We expose the orbicularis, the tarsal plate, and the orbital septum. After retracting the septum, we find the fat. After retracting it, there is the LPS aponeurosis. This is a post-op day 1, and post-op 1 month, she has a good amount of lift after LPS resection. This is a congenital ptosis with a LPS function of 5 to 6 millimeters. So we went for a LPS resection. This is post-op day 20. For frontalis sling procedure, various designs have been proposed. This is the lady with congenital ptosis and an LPS function of 3 millimeter. So we do a sling procedure, and at 3 months, this is the lift she has acquired. This is a lady with sling surgery done 3 years ago, she has come to us for readjustment of the sling. Now for frontalis flap, we expose the orbicularis, the tarsal plate, and the orbital septum. Then through the same incision, we go up to the orbital rim and undermine the frontalis flap, frontalis muscle, and then we fashion a flap from it. This is a short video. We put a lid crease incision, we expose all the tissues, we undermine the frontalis muscle, and we fashion the flap from the frontalis muscle, and then we attach it to the upper 1/3 of the tarsal plate. The complications of ptosis surgery, the edema subsides within a few days. For certain cases of exposure keratopathy, we might require a frost suture. For undercorrection, we must assess what went wrong. Was there any slip suture? Was the LPS function too poor? Was there any missed myasthenia gravis? In case of LPS surgery, 3 non-absorbable sutures, cardinal sutures, is a must. And if there is any undercorrection, we check for the undercorrection after the edema subsides. If there is any risk for amblyopia, we go for immediate surgery within 1 week, or else we can wait for 4 to 6 months. Overcorrection, in certain cases, may be the problem. It's not playing. It may be the problem. In such cases, we look for any recent onset thyroid eye disease, or if there is any floppy eyelid. It has been said that correction of floppy eyelid itself gives a lift of 1.3 millimeter for ptotic eyelids. Now, contour abnormalities may be it's not playing. The slide's not playing. Okay. For overcorrection, we might require a Putterman's massage for mild overcorrection and redoing or hangback sutures for severe overcorrection. For contour abnormalities, the main problem is poor technique, so we may require a readjustment if there is severe amount of contour abnormality. For lid crease abnormalities, again, there may be absent lid crease, or there may be an overhanging skin which may require a blepharoplasty again. Too anterior lamella or too short anterior lamella may cause an entropion or a rectropion, so we might require to do the lid crease sutures again. Wound infection may require antibiotic, or scar may require a revision. Conjunctival prolapse generally improves spontaneously, or in certain cases, fornix forming sutures may be required. Lacrimal gland fistula, in case we have gone too laterally and gone up to the lacrimal gland, a fistula has formed, we may require a sinoacrylate groove or suture to close the fistula. Now, we all know ptosis means fall, but in case of ptosis, early diagnosis, proper planning, and the right choice of surgery, and the life of the patient will be in full bloom again. Thank you.
Thanks, Dr. Sripurna. That was a very concise presentation on different causes and surgical techniques of ptosis management. So next, I'd like to call upon Dr. Joyita Das, consultant oculoplasty, Disha Groups of Hospital. She'll be talking on management of lag ophthalmos. I'll request Dr. Parag Mukhopadhyay sir to kindly hand over the memento to Dr. Sripurna.
Yes, sir. Very good morning to all of you. Thank you, Dr. Anirban Bhaduri, sir, for the kind invitation. My topic is management of lag ophthalmos. I have no financial interest. Lag ophthalmos is incomplete or abnormal closure of the eyelids. The term coined by famous Roman encyclopedist A.C. Celsus, and the term derived from 2 Greek words, lagos mean hare or rabbit, and ophthalmos mean eye. It was believed that the hare or the rabbit, they sleeps with their eye open. The causes are mainly paralytic, that is facial nerve palsy. It could be a cicatricial of various region. Myopathic, where there is incomplete blink due to muscle dystrophy or myopathic, and nocturnal lag of thalamus. The main or the primary cause of lag of thalamus are the facial palsy, and this facial palsy causes significant vision and psychological disabilities in patient, and the ophthalmologist, plays a pivotal role in management of this sight-threatening and psychological management. The mechanism of ocular surface damage is facial palsy are: here, there is orbicularis oculi function was reduced, that causes poor blink reflex, inadequate distribution of tear. There are reduced tear production, poor corneal sensation, and poor Bell's phenomenon added to this complication, and which leads to corneal exposure keratopathy, non-healing epithelial defect, which leads to corneal ulcer, opacity, and on conjunctiva there is dry eye and conjunctival injection. So the management of facial palsy, basically the priority is, the aim is to protect the surface. Ocular surface preservation is the foremost priority. Along with that, brow ptosis management, lower lid and punctal ectropion, excessive tearing, and management of cosmetic disfigurement is also an important part of the care. The management classically divided as an acute stage management and management of the chronic stage or the sequelae by surgical treatment, chemodenervation, or rehabilitation technique and reanimation. In this management, they start with evaluation. First, start with the history, because it's very important to know the duration and progression of the disease. And on examination, the best corrected visual acuity, examination of the corneal reflex, amount of lag of thalamus, Bell's phenomenon, lid and punctal malposition, and the brow ptosis is very important. And severity of any of the ocular findings mediates the urgency of medical or surgical intervention. In acute stage management, the aim is to protect the ocular surface from exposure and improvement of patient comfort and also vision. The treatment option depends on the predicted prognosis of return of nerve function. If we feel that there is idiopathic or Bell's palsy, in those cases we can do only conservative or medical management. In the cases where there is traumatic or post-surgical optic nerve resection, where there is no chances of getting back the function, in those cases we can take this surgical intervention. The degree of risk to the cornea depends on amount of lag of thalamus, quality of Bell's phenomenon, and presence of ectropion. The mainstay of medical therapy based on tear substitute in the form of artificial tear, which ranges from CMC to PEG, and artificial tear gel like petroleum jelly-based ointment, which are usually used at bedtime if there is significant lag of thalamus. There are some devices which are there to prevent evaporation, like moisture chamber bubbles and moisture chamber goggles. Unfortunately, these are not readily available in our country. So here I use this indigenous method of moisture chamber while patient is sleeping. This is just a moisture chamber made up of cellophane paper. Eyelid taping or patch, this is actually not recommended by oculoplastic surgeon, because there is always a risk of corneal abrasion by the patch itself due to the unopposed action of LPS during sleeping, and that patch can cause iatrogenic erosion or to the cornea. Scleral contact lens is another good option that causes a liquid bandage-like thing to the cornea, and this protects the cornea from drying. And when these all is not sufficient to make the management sufficient, in those cases we use silicone plugs, which is reversible, or simply punctal cautery also helps to keep the tear in the surface. There is another new things, that is a botulinum toxin, temporary ptosis, iatrogenic ptosis in facial palsy. This around 7.5 to 10 international unit transcutaneous botulinum toxin injected in the anterior orbital loop in the superior orbital rim in the mid-pupillary plane, and this causes iatrogenic ptosis, and it helps to mitigate the lag of thalamus problem around for 6 weeks to 3 months. The problem is, adverse effect is, it may cause superior rectal palsy. Now come to the surgical treatment. the aim of surgical treatment is to narrow the palpebral aperture, either by upper lid drooping procedure or lower lid lifting procedure. There are other procedures like medial and lateral canthal shortening and temporalis muscle transfer and nerve grafting. My next speaker will speak on this. Tarsorrhaphy is a simple static lid closure procedure which is reserved for some limited condition like significant lag ophthalmos leading to exposure keratopathy, where there is advanced method where is not available. If you are working in a peripheral center where advanced methods are not available, there you can do a simple tarsorrhaphy. When there is diminished corneal reflex which is causing impending perforation to the cornea, poor Bell's phenomenon, and in post-craniotomy patient, and the patient are scheduled for radiotherapy. In those cases, a simple tarsorrhaphy is a game changer. This is a short video clipping of the technique. There are many techniques of doing tarsorrhaphy, but this is the technique I like. This is a tongue and groove technique. In this case, there is an upper lid tarsoconjunctival flap is made, and this flap has been sutured to the corresponding gap in the lower lid. Actually, this gives very stable closure without damaging the lid margin structures. Okay, next. The advantage of tarsorrhaphy are it is a very technically simple procedure which accelerates corneal healing. However, the disadvantage is it is cosmetically not acceptable, and every patient after doing the procedure will ask you invariably whether, whatever the reason, they will ask you when you will remove my tarsorrhaphy. That is the main problem. And there is also visual field obstruction, lid notch and trichiasis after the release of tarsorrhaphy. Next come to upper lid drooping procedure. The indication of this procedure are lag ophthalmos mainly due to upper lid retraction and lid lag. Here the most preferred techniques are lid loading procedure in the form of gold or platinum implant, dermis fat graft or donor sclera. Where these are not available, then upper lid retractor recession like Muller's or LPS recession, Muller's recession with a scleral graft and graded LPS hinge is a good option. There are options like palpebral spring. However, I have no personal experience on this technique. This is a video of lid loading technique. This is a patient with 60 years old patient with a facial palsy after craniotomy. First lid crease incision was given. Pre-tarsal orbicular is exposed. This is a tarsal plate. This is the customized gold plate. This has been sutured with interrupted suture by Prolene, 6O Prolene. And all 4 sutures have been given. Orbicularis and the skin is sutured in separate layers. For putting this gold weight, very much it should be placed towards the medial side. Okay. The advantage are these are very technically simple procedure having a long-lasting predictable result. However, there are chances of extrusion, and very rare cases there are cases with a gold allergy, and it's a quite pretty expensive procedure. In those cases where patient cannot afford or we don't have gold weight at hand, we can use these upper lid Muller's and LPS recession in such cases. This is the case with a element palsy post-surgery. This is the post-operative cases of the same case, I think very good closure. Now come to the lower lid lifting procedure. This is indicated in lower lid paralytic ectropion. The process which are commonly we do in our setting are lateral tarsal strip, augmented lateral tarsal strip. This is devised by Oliver et al. From Moorfield. Lower lid retractor recession with a spacer graft, and for the medial ectropion, medial canthoplasty is a very good option. This is one case with a facial palsy. This is augmented lateral tarsal strip with posteromedial canthoplasty has been done. This is the short video of this technique.
Dr. Joyita, 1 minute.
Yes, sir, I'm just closing. Here first lateral canthus skin marking was done, and after doing passing a punctal probe, the medial the tarsoconjunctiva, we made a thermal with the help of a radiofrequency cautery, making a triangular shaped conjunctival excision. Next, the 505 kil suture has been passing through holding the medial end of the tarsal plate, and it is passed behind the caruncle to exit through the medial canthus. Next, a lateral tarsal strip has been made. Intentionally, I made a long strip. This is a long strip, and anterior lamella of the upper lid margin also dissected, so that the long strip can be draped over that upper lid posterior lamella, and it is attached to the lateral tarsal wall, periosteum, in a slight upper level than the convention. And this is the final result after 3 days, the very good closure. Now come to the lower lid. When there is a lower lid ectropion with lot of tissue or muscle atrophy, in those cases we need some support. And here we use a post-auricular cartilage graft or spacer graft, or some scleral bank sclera also can be used. This is a video of this. This is the posterior surface of the pinna, and here I am harvesting a cartilage graft of around 15 into 20 millimeter. Next, the transconjunctival incision was given in the inferior edge of the lower lid tarsal plate. Then the retractor recession was done. Next, the cartilage was implanted here, and it is sutured with the lower end of the tarsal plate and the cut end of the lower lid retractor. And the conjunctiva is closed, and like conventional lateral tarsal strip, the lateral canthus was reformed. This is the result after 4 weeks. You can see very good closure with a stable lower lid. So to the tech clinic message are, ocular surface preservation is the primary aim of an ophthalmologist for management of facial nerve palsy. Pre-operative assessment plays a pivotal role in the management plan. Choice of procedure should be tailored according to the predominant anatomic changes. Gold weight implantation is a standard technique, and lower lid spacer and posteromedial canthoplasty is an effective procedure. Thank you.
Thanks, Dr. Joyita. So managing a facial nerve palsy is of course a challenge, and you very nicely covered all the different techniques. I just like to add a point that unlike involutional ectropion, where there is the primary pathology in the lateral canthal tendon, the facial nerve palsy primarily affects the medial canthal tendon, and we have to address the MCT more than the lateral canthal tendon. And even if you are doing a tarsorrhaphy, a paramedian tarsorrhaphy would be like much better than a lateral tarsorrhaphy.
Yes.
So I'd like to invite Dr. Parag to kindly hand over the memento to Dr. Joyita. And as Dr. Joyita talked about the animations, temporalis muscle transfer for the animation of eye. So we have read a lot, we have hardly any experience. So we have an oculoplasty surgeon amongst us, Professor Prabir Kumar Josh, who will be talking upon temporalis muscle transfer for animation of eye. So Professor P.K. Jash is Professor, Department of Plastic Surgery at Calcutta Medical College.
We must alert the technicians while doing perimetry to take care of it, otherwise it will give false perimetric results.
পেনড্রাইভ আছে, পেনড্রাইভটা দিয়ে দেবো ওখানে। দিতে পারো। পেনড্রাইভটা দিয়ে দেবো। পেনড্রাইভ ও আচ্ছা 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 আপনি
করে দিচ্ছি। হ্যাঁ ডুপ্লিকেট করে দিয়েছি তো ডুপ্লিকেট তুমি করা ছিল আমি করে দিলাম তো দেখ আসবে এবার কোনটা
Good morning, everyone. So, at the outset, I must thank the Sushruth Eye Hospital, especially Dr. Anirban Bhaduri, for giving me this opportunity to come here. Homagni Ghosh is now a junior colleague of mine in the department of, in my department actually in the medical college, has been the link actually between us. And well, this has been discussed by a previous speaker, Dr. Joita. So I'll just emphasize that basically it's a seventh nerve involvement if it's a paralytic, and the above photograph is the unilateral left-sided, the lower one is a bilateral. Again, the static procedures had all been described by Dr. Joita, and I'll be describing and I'll be focusing mainly on the dynamic procedure. Now, the main principle of this dynamic procedure is that the temporalis muscle, which is very much in the vicinity of the pathology, is being supplied by the fifth nerve, the trigeminal nerve, and is not affected by the seventh nerve involvement. Now we take usually a very small segment of the temporalis muscle, and hence it's also called segmental or mini temporalis transfer. Now for any of these types of muscle transfer, the basic aim is to strengthen the donor muscle. Now the temporalis muscle is a masticatory muscle of mastication. So what you do is you tell them to chew on a piece of gum, do chewing exercises. And secondly, the muscle has to be trained to the new function. So what he does, he or she, he clenches the jaw voluntarily and closes the eyes, and he practices this in front of the mirror to get a visual feedback. So these are the two things he has to keep on doing before the surgery. Usually it doesn't need much of training. And now there are two approaches, Gillies and Johnson. The Gillies has been described earlier and still practiced in quite a few centers. So I'll be describing that in brief before going on to the Johnson, which we practice now. Now what are they? In the Gillies temporalis transfer, basically the muscle, the temporalis muscle has been lifted from the superior end, reflected inferiorly. It has been lengthened by the strips of deep temporal fossa, which is present over the muscle, and passed through the upper and lower eyelids to the medial palpebral ligament. We give a curvilinear or S-shaped incision just in front of the ear, starting right up from the zygomatic arch, going superiorly up to the superior temporal line. The incision is deepened right up to the deep temporal fossa. Here you can see in the photograph the deep temporal fossa, and there we give 3 parallel incisions, about 4 to 5 millimeter apart. The lower end is cut. So what we have achieved is basically a temporal fossa flap has been raised, based superiorly, attached to the muscle. So that is the first step. The temporal fossa strip or the flap has been raised superiorly, and it has an attachment to the superior part of the muscle. And now we give an incision superiorly over the periosteum and go beneath the muscle. Now, since we don't do this procedure now for the isolated eye animation, so I have given the photographs for the combined eye and the facial animation. The same thing has been done here. Here the facial strips have been raised. These facial strips are raised superiorly and they are still attached to the muscle. We can see a fill of the pericranium too. And then the muscle has been reflected inferiorly. Now, for the eye animation, basically we won't be taking this part of the muscle. This part of the muscle has been raised mainly for the facial animation. So only this part of the muscle goes to the eye. Now, how does it, these strips, how do they go to the medial palpebral ligament? We give 1 centimeter transverse incision here, and we pull the strips through that. Then we give 2 small 1 centimeter incision in the middle of the upper and the lower eyelid, parallel and as near and possible to the lid margins. And I'll be showing it in the next procedure that the strips are then brought to the medial palpebral ligament, and one goes above, one goes below, and then we tighten it over there. Basically, lower lip is sutured first, and then we suture the upper strip so that there is a slight overlapping of the upper eyelid over the lower eyelid. Now we have shifted over from the Gillies approach to the Johnson's one. Why? Firstly, it's a very simpler procedure. It can be very easily can be reproduced by most of us with good results. It needs a smaller incision. It's only a 3 centimeter incision just in front and above the ear. Secondly, as we saw in the previous one, there was a muscle bulge over the zygoma, which the patient complains of. Each time he contracts, the bulge of the muscle is seen. So there is no visible bulge of the muscle belly over the temple. And secondly, there is a direct line of action. The posterior part of the temporalis muscle, if we see the posterior part of the temporalis muscle, if that is extended and goes straight, it is more or less the direct line of muscle action onto that. So we give a skin incision in a slight curve, as I said, 3 centimeter incision in front of the ear going backward. We cut the temporal fascia too, and what we get is that tendinous part of the lower part of the tendon. We take the posterior third of the tendon, mainly for the eye. If we want to do only the eye, we take the posterior third of the tendon because the posterior fibers are in direct line. After we cut the tendinous part, at the same time, the other team will be harvesting a tendon. A palmaris longus is usually taken from the forearm. Now, this is also a very simple procedure. This is just to show you, if the person opposes the thumb and the little finger and flexes, you can see the 2 tendons nicely becoming prominent. One is the flexor carpi radialis, and to the ulnar side is the palmaris longus. We can see that. We can give just a small transverse incision 5 millimeter at the proximal wrist crease. Get the tendon retracted. Once you retract the tendon, this becomes taut here. Give one more incision here, 15 to 20 centimeter of palmaris longus can be easily harvested. Well, the same thing again emphasized. This is the temporalis tendon, the posterior third cut, the palmaris longus tendon has been sutured to it, and we have given a 1 centimeter transverse incision here, and we have got the tendon through the subcutaneous tunnel. Now, once we have got here, we got it into 2 strips. We have split it into 2 strips here. One goes over the upper eyelid, one through the lower eyelid. Again, 2 small incisions here, middle of the upper and the lower eyelid, close to the palpebral margin. Now, this is the one instrument that we have, is a tendon tunneler, which helps. This is very slender end. It helps in getting those tendons very atraumatically to the middle of it. We have got the tendon to the middle of it, and then from here to the, again, a curved incision at the medial palpebral ligament, we have got the tendon. The suturing here, as is described, the upper tendon goes either below the medial canthal ligament, the lower one goes above the medial canthal ligament, and we suture it. We always suture the lower end first, make it taut, and followed by the upper one. When you do the upper and tightening the upper one, usually the upper one overlaps the lower one, and there is a slight initially over tightening. Post-op regime is we usually give a liquid diet for 3 weeks. This is mainly because we want to give a rest to the masticatory muscle, that is the temporalis muscle, till the suture heals or till the sutured area heals. 21st post-op day onwards, basically again for the muscle training purpose, the patient looking at the mirror, the patient bites, it causes gentle complete eye closure. He releases the bite and opens the eye. Thus, by acquiring a mannerism of chewing, he closes the eye frequently. Now, this is, I think, is very theoretical because we have seen that this is not required. I'll show you in the photographs. And actually, the neural adaptation is very easier and commonly done here. So, re-education doesn't usually present a problem. Well, advantages, the chewing is not impaired. We have enough masticatory muscle. Even we have taken up small part of the temporalis. Closure of the eye can be performed independently from the chewing.
So 1 minute left, sir.
This is a pre-op and the post-op photograph. Now, we get quite a high volume of cases because we do the reconstructive surgery in leprosy. We do the outreach programs in the different districts like Bankura and Malda at least twice a year. And that's how we get the cases. And there actually, this is the post-op day 1. We have operated the next day actually in the rounds. We have opened the wound. And even there, you can see he can close and open the eye. Oh, this was the video, but somehow I think it's a different laptop, so it's not supporting that. Anyway, this is the video showing, this is again the post-op day 1. In the post-op day 1 only, I could show the closure of the eye. But anyway, to conclude, this procedure gives an excellent cosmetic closure, and it can be done even in a small peripheral surgical camps as a day case procedure. Thank you.
Thank you, Professor Josh, for your brilliant presentation. It's really amazing to see how you transform faces. Now I request Professor Mukhopadhyay, sir, to hand over the memento.
Do take the tendon. You are taking the tendon from which hand? Left eye, okay? Left hand, left forearm. You can take also from fascia lata.
So fascia lata is again a common.
Josh, thank you very much. The entire idea of having people from other fields of medicine beyond ophthalmology is what is the key to this particular program. And we have so much to learn from other specialists. And now we know that we can actually remove the tarsography and send the patient across to you. That would be ideal.
Thanks for that. But I think even you can practice with such a simple procedure, and this can be imbibed by the oculoplastic surgeons too.
Do under GA.
Well, these procedures in the reconstructive surgery, leprosy, yes, we have done it under GA for the 2 main reasons. First is we are doing it as a high volume cases because we are doing it along with the claw hands or the foot drops and all that. And secondly, our CTs, like our trainees also go along with that. So it's good to demonstrate when the patient is on the field. But this can be done as a day case procedures under local infiltrations.
So very well demonstrated surgery and nicely explained every steps. Thank you very much, Dr.
Thank
Josh.
You. Thank you.
Our next speaker is Dr. Mohammad Shahid Alam, who is head of the Department of Oculoplasty of Shankar Netraloy, Kolkata. He will speak on myogenic ptosis. That is another very interesting topic.
Good morning, everyone. So at the outset, I'd like to thank Sushruth Eye Hospital and Dr. Anirban Bahaduri sir for giving me this opportunity. I'll be talking upon dilemmas in management of myogenic ptosis. So I'll start with a case. So she is a young girl, approximately 15 years of age, who presented with this gradual drooping of her left eye over the past, say, few years. And along with that, she had complained of, wasting of muscles and getting tired on walking a few steps. She has stopped playing because she cannot run that much anymore. So on examinations, this where her motility or LPS function was fair, and you can see there is moderate ptosis. So we did other ancillary tests, like we did a fatigue and eyes test, which came out to be negative. So since it was a acquired ptosis, and patient also had these symptoms of muscle wasting, so we like to further evaluate her. So we'll continue the story later on. So just to start, so ptosis is, as you know, can be congenital and acquired, and acquired ptosis, among the acquired ptosis, myogenic ptosis is an important cause. So some of the common causes of acquired myogenic ptosis are mitochondrial myopathies, oculopharyngeal muscular dystrophies, ocular oromandibular dystrophies, myotonia dystrophica. So myasthenia, though it has been, it's a neuromuscular disorder, and many neurologists, they classify it under the category of neurogenic ptosis, but for the purpose of management, myasthenia and other myasthenic syndromes are also, classified by us amongst as a cause of myogenic ptosis. So to start with, history taking is very important whenever if you want to pinpoint a cause in cases of myogenic ptosis, and whenever you see that a young patient comes to you with a history of acquired ptosis. So mind you, acquired aponeurotic ptosis is not that much common in young population, and you should always think that no, it's not a routine aponeurotic ptosis, and you have to rule out a myogenic ptosis in those cases, and you should ask all these regarding all these symptoms. Most important is diurnal variation, which is a telltale sign of myasthenia, where patient will complain that the ptosis improves when they get up in the morning, and as the day progresses, the ptosis worsens. They will also complain of diplopia, and this diplopia also has a diurnal variation. So it improves in the morning, and as the day progresses, the diplopia also worsens. Then if patient has other systemic muscular dystrophies, they will also complain of dysphagia, breathing difficulty, and other forms of muscular disabilities. So while examining the patient, so in our routine practice, the two most common causes that we see of myogenic ptosis are mitochondrial myopathies, that is chronic progressive external ophthalmoplegia, and myasthenia. So other like oculopharyngeal muscular dystrophies and other causes of muscular dystrophies are not that common. So you have to primarily differentiate between these two causes, that is CPEO and myasthenia. So when the patient sits in front of you and you have concluded that it's a case of myogenic ptosis, so look over the frontalis overaction. So if frontalis overaction is present in that case, so you are little bit sure that it's not a case of myasthenia, because myasthenia will affect all the muscles uniformly. It will affect the facial muscles, it will affect the LPS, orbicularis, and frontalis muscles. While a CPO, since it's a mitochondrial thing, it mostly affects where the muscle where mitochondria is in abundance, and that is LPS. So frontalis will be spared in CPO. So there will be marked frontalis overaction in cases of CPO. Then variable marginal reflex distance. So this is a sign of myasthenia gravis, oculomyasthenia gravis. So when you are examining the patient, when the patient has come and sit in front of you, you will see that MRD is different. Then after a few seconds of examination, you will see that now MRD is quite different. So variable MRD, it's a sign of myasthenia gravis. Then there will be associated squint. This is also a sign of myasthenia gravis. Then there are other signs, special tests and signs like eyes test, fatigue test, that you can do in your OPD to find out the cause of this myogenic ptosis. Extraocular motility limitation, examining it is very important. So in late cases of CPO, and it is that stage where the patient presents to us, the globe will be almost frozen in chronic progressive external ophthalmoplegia. While in myasthenia gravis, the motility is, there is variable limitation of motility in different direction of gases. So this examination of motility is also very important if you want to differentiate a CPO from myasthenia gravis. Pupillary reaction, it will be normal in both myasthenia because the supply is through the nicotinic receptors, while the myasthenia affects the muscarinic receptors. And also in CPO also, the pupillary reaction will be normal. Rarely in cases of myasthenia, there can be involvement of pupil. Now examination of Bell's phenomena and corneal sensation, this is more important as far for management point of view, because in most of the cases, especially in CPO, the Bell's will be poor or absent, and examining it is very important if when you are going to plan your surgery. So I talked about ice test. So how do you do an ice test? You apply an ice pack over the eyelids, keep it there for 2 minutes, and a difference in MRD of 2 millimeter. So 2 minutes, 2 millimeter is a positive ice test, and you are quite sure that it's a case of myasthenia gravis. It has more than 80% sensitivity in diagnosing myasthenia gravis. So this was a case, he had presented as with history of acute ptosis, sudden drooping of eyelid, and it was diagnosed as a case of third nerve palsy elsewhere, but see the ice test is positive. So it was also a case of myasthenia gravis, acute myasthenic syndrome. So sometimes myasthenia can present as a masquerade, like in this child. It was a 2-year-old girl who had presented with bilateral ptosis, and the parents were quite sure that the ptosis was not present since birth. So that is these sort of cases. That's why it's important to look at the previous photographs. So whenever you are examining a case of ptosis, always make sure that always ask the patient to bring their previous photographs so that you can see like whether the ptosis was present there since birth or not. And this particular child, she was diagnosed as a case of bilateral congenital ptosis and was also advised a bilateral frontalis sling surgery. But since the parents were quite sure that no, it was not present there since birth, and there were symptoms of diurnal variation, so we did ice test, and see after ice test the ptosis has markedly improved. Both the lids have markedly lifted, and acetylcholine receptor antibody was positive. Patient was started on acetylcholine receptor esterase inhibitors, and this is on follow-up. So this was a case of juvenile myasthenia gravis. We also published this case. So this myasthenia, it can present as a masquerade of other forms of ptosis. Now there are different antibody assays that can be presented in myasthenia gravis. It's not just acetylcholine receptor antibodies. So which antibody you should prescribe, while you're trying to investigate a case of myasthenia gravis. So if you just write acetylcholine antibodies, so the lab won't give you the test results. So you have to specifically write acetylcholine receptor binding antibody, because there are blocking antibody also. So you have to write acetylcholine receptor binding antibody, because there are 50% chances that it will be positive in cases of ocular myasthenia gravis. And another set of antibody which is important is anti-musk antibody. And anti-musk antibody, they predict the severity of myasthenia, ocular myasthenia, and the chances that whether this patient will land into generalized myasthenia or not. And in cases where their acetylcholine receptor antibody is negative, and you have a strong doubt, strong suspicion of myasthenia gravis, you should order for this anti-musk antibody. So if acetylcholine receptor antibody is negative, this musk will be positive, and if this musk is positive, that will be negative. So this is vice versa. Then another test is nerve conduction test and EMG. So we routinely prescribe a repetitive nerve stimulation test, that is RNST, for myasthenia gravis, but nowadays the gold standard is SF-EMG, that is single fiber electromyography. So EMG is also a test to diagnose other forms of myopathies. So while examining these cases, we should also rule out other associations, ophthalmic associations. So one of the commonest is pigmentary retinopathy, which is seen in CPO, that is Kearns-Sarge syndrome. And if you have made a diagnosis of CPO, make sure that the patient consults a cardiologist to rule out cardiac conduction defects, because they are very commonly associated with mitochondrial myopathies. Now, what are the dilemmas while you are managing these sort of cases? So many of these patients will ask, like, what are the chances that my other children can have this disorder? So of course you're not sure. So you have to order genetic testing. Mitochondrial myopathies, there are chances that it can run into family lines. But other muscular dystrophies, it basically depends upon the inheritance pattern and the genetic test that the patient has undergone.
Dr. Shahid, 1 minute left.
Okay. So you have to order for electromyography also. Then muscle biopsy, which will show red ragged fiber. Then imaging, which will show a thinning of extraocular muscles, diplopia charting to rule out diplopia in all these cases. And then you have to decide whether you have to do a medical management or whether you have to observe the patient. So if you are planning a ptosis surgery in these cases, so you have to be sure that while you are lifting the lid, the ptosis doesn't worsen. Because when the ptosis is severe, patient is using only his one eye and he is uniocular. So once you have lifted the lid, the binocular diplopia can worsen. That's so that you have to make sure that diplopia doesn't worsen on lifting the lid. And if it is getting worsened, then you have to counsel the patient against surgery. Yeah. So medical management, so as I already told, so we have two most common disorders, that is myasthenia and mitochondrial myopathies. So the medical management for myasthenia is acetylcholinesterase inhibitors, steroids in acute cases, and immunosuppressants if the patient is not responding to that well to steroids and acetylcholinesterase inhibitors. Coenzyme Q, it is prescribed by neurologists in cases of mitochondrial myopathy, but the results are not that good, and it's a very costly medication, so it doesn't help that much. Steroids are contraindicated in mitochondrial myopathy, while there are a treatment of choice in case of myasthenia. And then, of course, you have to prescribe prism glasses if the diplopia is bothersome to the patient. So prism glasses, so they are very handy and very helpful for the patients in cases of intractable diplopias. These are crutch glasses for patients for these kinds of ptosis and where patient is not very motivated for surgery, and then where you have concerns regarding corneal exposure, getting corneal exposure keratopathies. So crutch glasses comes very handy in these cases. So it can lift the lid. Patient can use these glasses while while doing their near work, while reading, but then on a long-term basis, they can cause abrasions and thinning of upper lid skin. So that is a disadvantage of crutch glasses. So now coming upon surgical indications and what are the concerns. So of course you will go for surgery when all the options have been exhausted and patient is not responding to medical management that well. So then you have to think that okay, this patient needs surgery. And as I told, so one of the concern is diplopia. Diplopia can worsen if the globe is frozen. Then yeah, diplopia won't be there. But especially in case of myasthenia and if the ptosis is severe, it can worsen once you have lifted the lid. Poor bells and corneal exposure are a concern. Then of course choice of surgery. So in ptosis surgery, so as it was mentioned in case of management of ptosis talk, that we have two major options, that is LPS link suspension. So you have to decide. So I personally prefer a frontalis sling. The idea being that it's a muscular disorder. So if you do and a progressive disorder, if you do a muscle surgery, it can gradually fail over time. So a frontalis suspension has an edge over a muscle surgery, and you have to counsel the patients regarding the unpredictable surgical results. So there is a lot of literature on different techniques. So some authors have tried different techniques for management of ptosis by different surgical techniques. But this is a paper by Tim Sullivan group. So where they have nicely mentioned like when you should embark upon surgery in these cases. So they should only go ahead with surgery when the visual axis is completely obscured. And surgery in these cases is never cosmetic, it's always functional. So if the ptosis is visual axis is completely obscured, and that too bilaterally, that patient is visually debilitated, then you should think of surgery. And they say that if LPS action is more than 8 mm, try for a LPS, and if it is less than 8 mm, go for a frontalis sling. But as I say, I personally prefer a sling surgery, especially in cases of CPEO. So basically it's a balancing act. When you do a surgery, it's a balancing act, and you should be little bit tilted towards under correction with residual ptosis, because that prevents your cornea from exposure. So just few cases. So this is the case of bilateral severe ptosis. You can see that visual axis is completely obscured in these cases, and I cannot see, my daily life is hampered. So, and it's a frozen globe. Movement, complete limitation of movement in all direction of gazes. So, there won't be, you're sure that there won't be any diplopia when I lift the lid. So, this is a day 1 picture of bilateral frontalis sling. And this is a at follow-up of 3 months. And this is you see that there is no lag ophthalmos. So, on the initial, for the initial 1 week is very important in these cases. You have to keep the patient on close follow-up, call them daily, teach them orbicularis exercises, see what is the amount of lag ophthalmos, examine the cornea very closely if there are any signs of exposure keratopathy. And after that, when you are sure that, that the lag ophthalmos has improved and the cornea is clear, then you can call them after 2 weeks or 1 month. And before surgery, if you feel that the orbicularis is compromised, patient cannot do forceful eye closure, those patients are not good candidates for surgery, because lag ophthalmos can only improve if the orbicularis is functioning. So if you see that orbicularis is not functioning properly, that a patient doesn't have a good forceful eye closure, don't go for surgery in those cases. So you see this is another case. So I did a surgery, and on day 1 only patient has developed exposure keratopathy. So in this case, I had to reverse the sling, I had to bring the lid down. So this also you have to counsel the patient that if the cornea gets compromised, the surgery has to be redone, and the lid has to be brought down. And whenever you're doing surgery, don't do a bilateral surgery, do one eye at a time. This is a case of myasthenia. So I did a LPS for this patient, and you see that visual, the result is not that good, but visual axis is clear. So I did a LPS resection in this case of myasthenia. Another case of CPO, where I have done a unilateral surgery, and after one eye only, patient is happy with using with that eye and doesn't want surgery of the other eye. So that also is fine. So this is talking about the first case, the child that I discussed. So patient was sent to NIMHANS, and there whole this panel of genetic testing was done, and patient was then diagnosed as a case of muscular dystrophy with component of myasthenia, and was then started on medications, immunosuppressants and acetylcholinesterase inhibitors, and there was marginal improvement in her symptoms. Of course, ptosis is the same. So just to conclude, myogenic ptosis is a rare cause of acquired ptosis, and proper diagnosis is important. Of course, it will depend upon your history, clinical acumen. You should rule out other systemic associations. Role of medical management is there, and a neurologist should always be kept in the loop. And surgery, as I told, it's never for cosmesis, it's for functional purpose. If the patient is visually debilitated, there is bilateral complete obscuration of visual axis. Choice of surgery, I told, I personally prefer a frontalis sling. You can go for LPS surgery if you see that the LPS action is good. And patient counseling is very, very important. You have to counsel regarding each and every complication, especially corneal compromise in the post-operative period. Thank you.
Thank you, Dr. Shahid, for your very interesting and informative presentation. Now I request Professor Mukhopadhyay sir to please hand over the memento.
Dr. Shahid, yes, I used to do frontalis sling, and I used to take the fascia lata strips, and from there I used to do the surgery. So that is actually better than this silicone surgery, because it can cut out through, or it can get away in future. That is my opinion is that.
Yeah, fascia lata is good for other causes like congenital ptosis. It's okay, but sling, since it is reversible, so it is the management of choice for myogenic ptosis, because fascia lata you cannot reverse. If you have done it for a myogenic, for a CPO, then you cannot go and reverse, because it intermingles with the tissues. So that will be difficult. Yeah. But for congenital ptosis, yeah, fascia lata is good.
Dr. Shahid, thank you for your presentation. I would want you to come back and take over as moderator once the memento has been given to you. And we would want to keep all the questions till for the end, when all the speakers are done.
No,
Our next speaker is Professor Sholil Mondol. He is Professor, Department of Oculoplasty, Regional Institute of Ophthalmology, Kolkata. He will present on a novel method of managing lid retraction in Graves' orbitopathy. A very interesting topic. Please.
Hello. This is a study, and I will present this study as a video format. So I'm not given any statistics, but you just observe the cases, observe the procedure, then you comment it. The first part of the video is a little bit public awareness, and the second part of the video is the learning procedure. Mind that cigarette smoking is injurious to health. Is a great actor, innovator, creator. But mind that, stop smoking. Otherwise, there's a lots of problem. Particularly the female young age right now. Again, I say, stop smoking. Stop smoking, otherwise you may have a problem. What problem? If you have a borderline thyroid disease, it will have a Graves' orbitopathy. And the commonest clinical feature is the retraction of the upper eyelid. How to treat this retraction? It is a elongation procedure applicable? The spacer material applicable? What material to be used? It's a sclera? It's a facilata? It's a defect. Filamentous knitted polyester fabrics used in cartilage on reconstruction, tendon repair. So why not this material is not being used in ophthalmology? I have a dream to use this material in ophthalmology. The study started and beginning our journey. Lid crease incision made first, along the crease matching to the opposite side, dorsal plate and the orbital septum exposed, the same line. Here in Graves' orbitopathy, in a lid retraction, I say that the LPS is a little bit stronger and fibrotic. That I have seen lots of ptosis surgeons that are doing. That is, aponeurosis lax in ptosis surgery. But here, in orbitopathy, this part is very strong. Now here, the noble filamentous knitted polyester fabric inserted into the created space. Firstly, the LPS is detached from the dorsal plate, central part, and retracted upwards and create a semilunar space where this knitted novel knitted polyester fabrics material is applicable. This is my first surgery. I don't know how to do this application of this spacer material. So immediately after 2 surgery, I changed the protocol. So this is the desired length of spacer material is applied between the redundant parts of the LPS and the upper border of the dorsal plate. And it is reposited and lengths become lengthening. So after that, now this is the material. We change our protocol. This is a semilunar size of the material. The central width is the distance between the dorsal plate to the redundant parts of the LPS. Yeah, now the design of the spacer material has been changed. Our object to induce moderate ptosis. So induce moderate ptosis for the surgical limbus, the distance is 5 millimeter. If the scleral show is 4 millimeter, to add 4 plus 5, 9 millimeter, and extra 2 millimeter, the spacer material, effective spacer material should be 12. That is our protocol that we have studied here, and it may causes a mild ptosis postoperatively. But in thyroid ophthalmopathy, it's most of the literature, most of the surgeons in US and Europe, they did a second surgery. Means they are not adjusting the lid at the right moment. But here, we adjust it. In lower lid, through conjunctival approach, incision made at the lower border of the dorsal plate. Here, the first structure is the conjunctiva, and the second structure is the inferior retractor. Our first speaker says the anatomy. You should know the anatomy, otherwise very difficult. Retractor in the lower leads is the inferior retractor. Retractor in the upper lead is the LPS and the molars muscle. So fibrosis of this component may causes orbitopathy or lead retractor. So inferior retractor is cut from the inferior border of the tarsal plate, create a semilunar space where I did implanted the material, what is called knitted polyester fabrics. Conjunctiva is secured very carefully. If the conjunctiva is deficient, that will be caused as a reposition problem. Carefully, reposition of the conjunctiva should be made, otherwise a pharyngeal defect. Inferior retractor already retracted is cut from the inferior border of the tarsal plate. After that, we use a spacer material here. The spacer material sutured into the inferior border of the tarsal plate. And this is a spacer, novel filamentous knitted polyester fabrics, inserted into a created space as a spacer material, and the length is, our protocol is 6 to 7 millimeters center wide, and create a space between the inferior border of the tarsal plate and redundant part of the inferior retractor, which is detached from the tarsal plate. That may cause lengthening of the lid. All the sutures should be done at the one end, and the distally doesn't require any suture. It creates the space. Here, the distal part here, which is attached to the retracted part of the inferior retractor. Desired length is cut. Previously, I thought that if there is a cone in the fabrics, it may be rejected. No, doesn't require a round shaped area. You can give a conical shape, angular shape, does hardly matter. Here, the conjunctiva again covered over the spacer material to be deposited over the tarsal plate and sutured it. Conjunctiva deposited over the spacer material and fixed to the lower border of the tarsal plate. So, the spacer material entirely covered by the conjunctiva, and from the skin approach, it covered by the skin orbicularis muscle, and that space maintains the, where the retractor is there, it is not there, it is retracted. So, the lengthening procedure, both upper and lower lid done simultaneously once a week. All the surgeries should be done by local anesthesia, doesn't require any anesthetics. So surgery is nothing but your meticulous, all the dissection of the fiber, layer by layer. Upward traction suture kept for 3 to 4 days for maintaining the lengthening of the lower lid. Now, this is the patient. One eye operated here and other is waited. Right eye is operated after 15 days, after 1 month. Another patient, we did operation on the left eye. This is the picture. Now comes to a conclusion that the newly made spacer material, fabrics, polyester, it's one of the best spacer material forever. Doesn't require, the ophthalmologist is always thinking for sclera and fasciculata. More than that, there's lots of material, you can use it and body can accept it. Thank you.
Thank you, Professor Mondal, for your very interesting presentation. Now I request Professor P.N. Biswas to hand over the memento to Professor Mondal. Thank you.
না প্রশ্নগুলো আমি বারণ করে দিয়েছি questions only after the session is over প্রচুর প্রশ্ন আছে
Yes. Thank you, sir. Our next speaker is our own Dr. Raka Chatterjee. She is a senior consultant in Orbit, Oculoplasty and Aesthetics in Shushruta Eye Foundation. She was trained in Oculoplasty in Shankar Nethralaya, Chennai. She has presented in several instruction courses and has received awards for her presentation. She also has several publications to her credit. And apart from oculoplasty, she is a promising cataract surgeon and a good painter.
Good morning, everybody. My topic is a little different from what so far was discussed here. It is a privilege to be a part of a Silver Jubilee celebration, and it's my own hospital. Now, it's a huge audience, and who doesn't want to appreciate the ageless beauties of those personalities whom we see on screen? Sometimes we wonder, what is the secret behind this? Now, many often, and it is to our surprise that the secret behind these ageless beauties lies in a bottle of toxin. Yes, this is the botulinum toxin. In coming 10 minutes, I shall be trying to unravel the mysteries of this toxin, this botulinum toxin, and its different uses in oculoplasty. The advent of Botox has revolutionized the facial aesthetic surgery. Now, as we all know that this facial aesthetic surgery is an upcoming subspecialty. In fact, next Sunday also we have a workshop conducted by WSWB on this, and eminent speakers are coming. Now, this facial aesthetic surgery includes not only Botox, it includes the uses of fillers, uses of chemical peeling, dermabrasion, and laser resurfacing, and many more things. But I shall be restricting myself to the discussion on this toxin only. Now, how does it act? What is the mechanism of action of this botulinum toxin? Now, botulinum toxin inhibits the presynaptic release of acetylcholines. Now, in other way, it prevents the exocytosis. Now, when the botulinum toxin binds with the receptors at the neuromuscular junction with the presynaptic endings and it enters, it binds with the protein called as snare protein, which has got three components: synaptotoxin, synaptobravin, and SNAP. Now, it breaks these components, and as a result of which, there is hindrance or prevention of the fusion of the acetylcholine-filled vesicles to the presynaptic nerve membrane, and the exocytosis is prevented. So, at the neuromuscular junction, is deprived of acetylcholine, and there is muscle paralysis. In fact, in a simple way, the botulinum toxin causes muscle paralysis. Now, our use in oculoplasty is based on the idea that the different facial muscles and the delicate interplay of these muscles of facial expression and our uses of botulinum toxin. For example, if we consider the forehead and the periocular areas, there is one eyebrow elevator, that is a frontalis. And the depressor muscles are four, and that is procerus inferomedially, corrugator superciliary, depressor superciliary, inferomedially, and laterally, the orbicularis oculi. Now, whenever there is an imbalance in these two groups of muscles between the elevators and the depressors, the eyebrow position changes. Now, intelligent use of botulinum toxin in the selective muscles can change the eyebrow position or can reshape the face and obviously, in that way, we can use the botulinum toxin. Now, what are the limitations? The side effects are minimal, but all are reversible with time. And another limitation of botulinum toxin is the repeated dosing. This repeated dosing is required because of the axonal nerve sprouting. This axonal nerve ending, the sprouts, the new sprouts, they do not have those damaged protein, SNAP protein there. And so from there, the acetylcholine again begins to be released or exocytosed. So the duration of action is 3 to 8 months. It varies from patient to patient. In general, in oculoplasty, we have two groups of uses. There's a functional uses and the cosmetic uses. Now there is a big list of the functional uses of botulinum toxin. It starts with our very old tearing. In our outdoor patients, especially the oculoplasty surgeons encounter that jol porche. So it's a tearing. Now if we assess the tearing, and there are many causes. Sometimes it can be following facial nerve palsy, this crocodile tearing, can be a canalicular problem, tearing related to common canalicular block or proximal canalicular block or punctal stenosis. Acquired NLDO patients not willing to undergo surgeries when there is no infection as well. Now other uses includes chemical tarsography, frontalis overactions, status post successful ptosis surgery. The two main indications are hemifacial spasm, essential blepharospasm, apraxia of lid opening. Yes, spastic lower lid entropion. I had a patient who had undergone 3 times entropion correction elsewhere. Now when he came to us, it was a severely spastic eyelids, but with repeated dosing of botulinum toxin, this 84-year-old man is symptomatically much improved. Now lid retraction associated with thyroid orbitopathy, especially the superior one. What happened? Now, if you see very carefully this patient, what is happening? The left eyelid is twitching. In fact, muscles in the left half of face is also twitching. This is a case of hemifacial spasm. Now, whenever we see such a patient, our first intuition that we should go for an MRI to rule out any compressing lesion. It can be a vascular loop over the facial nerve, or it can be a space occupying lesion. We get an MRI done. If you don't find anything, then yes, after a neurologist clearance, we go for injection botulinum toxin. Now, this is the treatment of choice to give the patient a relief of this condition. And these are the sites of injections. And the dose depends on the amount of contraction. And we reconstitute, we have certain formula. We can reconstitute starting from 1 ml of normal saline to 5 ml. And that gives us the dilution. And we decide on how much to be injected and which site. These are the muscle-specific areas. We can inject in procerus. We have to inject in corrugator superciliary depressor. Depressor superciliary often bypasses the injection being deep in position. And if you consider the lateral aspect of the eyebrow, the frontalis and the orbicularis, both to be injected simultaneously. Otherwise, there will be a change in the eyebrow position. This can be an eyebrow ptosis. There can be an eyebrow lift, giving us very surprised look that the patients will not accept. If you see this patient, now this lady is not able to keep her eyes open. Now both the lids are squeezing. So this is a case of essential blepharospasm. In fact, it is very difficult to treat completely. There are certain medicines. To start with, we can give rest to the eyes to relieve the eye strain. Give a dry eye management. That means with lubricants, with vitamins, neurobians like. And the neurologists have a array of medicines like starting from clonazepam, haloperidol, diazepam, etc. But in many cases, the patients are refractory to all these. So in those cases, this botulinum toxin gives a good result. Yes, we inject subcutaneously in 5 sites. Again, the dose depends on the amount of contraction. These are the sites of injections. Now, the third important indication is the spastic lower lid entropion. Now, those patients who are post-surgical candidates are unwilling to undergo surgery, or sometimes in order to top up our surgical procedure, we inject Botox. It is that orbicularis oculis to be paralyzed by Botox. Now, the duration of effect, again, is 3 to 4 months. The side effects are paralytic ectropion. If the injection goes medial to the mid-pupillary line, there is a chance of punctal eversion and watering. And improper technique of injection going to inferior oblique can lead to diplopia also. As I was already telling, in cases of epiphora, where the surgical maneuvers either will not work or not indicated, then the botulinum toxin is useful. Here we, with the help of, yes, it is an OPD procedure, Desmarais retractor and pulling the eyelid down and medially, we can give the injection botulinum toxin in the palpebral lobe of the lacrimal gland. Anesthetic soak tip, cotton tip applicator, it is done under local anesthesia. And this 0.5 ml and the proper concentration we can give. Chemical tarsorrhaphy is another indication where Botox is 7.5 unit of Botox is injected into the levator palpebrae superioris in the mid-pupillary plane. Persistent frontalis overaction following successful ptosis surgery, Botox is given in frontalis muscle. Lid retraction in thyroid-associated orbitopathy. Now, it is a transcutaneous approach between the orbital roof and levator, and with the help of a tuberculin syringe as a routine, we give 3 to 7 units of Botox. Yes, it is also a temporary. This is the procedure. How can give? We can give it transconjunctivally also if we can inject into the levator. Now, if you see the picture of this lady, she is an aging lady who is aging gracefully. But nowadays, to many of us, these ageless faces, as I was discussing in the previous slides, much more wanted. So here we can see many wrinkles and many furrows, and in her entire face, this botulinum toxin can correct this. Now, these periorbital features are the most scrutinized aspects of our face. In the upper face being in the eyes, this is the most prominent part, is the aesthetic center of the face. Now, here, this is looking at the eyes. Yes, eyes can tell us many things. So, this periorbital region is the one of the most important and the first places to show the effects of aging. The ophthalmic plastic surgeons are practicing now to eliminate those wrinkles and the rhytids. These are the repeated actions of facial muscles which lead to these formations. Again, coming to the muscle actions and intelligent use of the injections in different muscles in a planned way can give us relief from these wrinkles and rhytids. Now, there are different sites and different indications.
1 minute left.
Different sites of injections and different numbers, starting from frontalis muscle, starting in the frown lines and the horizontal forehead lines, crow's feet, in the lateral part of the orbicularis muscle, even in the lower lid rhytids, upper brow lift. And nowadays, so when we inject these injections, we always counsel the patients about this recurrent dosing. Sometimes in overdosing, as for example, hemifacial spasm cases have come to us for injected outside. Overdosing, the patient presenting with the features of lower motor neuron type of facial nerve paralysis, with drooling of water, unable to blow, even on clenching the complete facial and the teeth deviation or marked. So careful dosing is and the careful injection technique is required. Thank you.
Thank you, Raka, for your beautiful presentation. A toxin in the hands of expert doing miracles. Now I request Professor Mukhopadhyay sir to please hand over the memento to Dr. Raka. Now we will invite questions from the panelists as well as from the hall. After that, we will have a short tea break of about 10-15 minutes. and then we'll come back for session 2.
So our first talk was by Dr. Shirasi Sarkar, lead margin malposition in tropion and ectropion. So we have any questions for her? Lead margin malpositions in tropion and ectropion. Any comments by the panelists? The next talk was on ptosis management by Dr. Sri Purna Ghosh. So she'll be very happy to answer any to clear your doubts and queries. Any doubts or questions on ptosis management?
There is a particular reason why Dr. Sholil Mondal is there in the panel. If you don't have questions, he has questions. So I would request all residents to either ask questions and get their doubts cleared, or Sholilda is going to grill you. কারো প্রশ্ন না থাকলে আমাকে জানাও, তারপরে সলিলদাকে আমি মাইকটা দিচ্ছি।
Can I ask one question? Is regarding ptosis management. In case of LPS resection and subsequently patient developing lag of thymus, how do you manage those cases?
Hello. You do resection.
Yes, resection.
Which procedure you apply? The resection of the LPS?
Yeah, LPS resection and patient developing lag of thymus subsequently. How do you manage
Then
this?
you have to recess the muscle. You have to recess the muscle and to see the lead height, how much it is. If the patient have a good bells, the patient can be protected. Other, if it's a overcorrection is there, then you have to recess the muscle.
Is there any role of massage or something?
A little bit. Particularly nowadays, resection is almost obsolete. Right now, most of the people they are doing in a silicone rod, and you can adjust it. Suppose it's under correction, over correction, you can adjust it everywhere. So most of the people they are avoiding resection to drop the lead. That is the risk of operation.
Even in case of good LPS function.
Even a good LPS function also. And no, it's a poor LPS function, we can do a resection. Other you can do a plication of the LPS muscle, what I say.
But plication causes a lot of bulge beneath the skin.
Not so much bulge, it's a plication is a much safer technique, but suppose you drop it, then you can recover it. But if it is resection, it's a drop it, then it will be a problem for us.
So just to add to that thing, so lag of thymus in LPS resection, it will gradually improve with time. Of course, in sling, there can be a little bit of lag of thymus lifetime, but in LPS it generally improves. If there is retraction, so 1 to 2 millimeter of retraction, you can correct by lash traction. You can ask the patient, not in the immediate post-op period, after a week, you can ask the patient to just hold the lashes and look in the mirror and bring it down, like this, pull it down.
Okay.
So different sessions, around 5 to 10, per session, and that 1 to 2 mm can get corrected easily. If there is too much of this thing, then yeah, as I told, you have to go for
So we can do a massage, the Putterman's massage, which we ask the patient to pull the lid downwards 5 to 10 times per day, and she holds it for some time, then it reduces the amount of lid retraction.
Okay.
I have one more question to Dr. Shripurna regarding the ptosis surgery in presence of squint without correcting it. Assess the lead height and
The case that we had, initially we thought it's a case of third nerve palsy because he had a restriction of movement. Then we realized it's a case of squint, but his vision in that eye was less. He has already developed amblyopia in that eye. So we'll go for the squint surgery after the ptosis has been corrected.
A lead position changes with squint surgery. So do the squint surgery first, then assess the ptosis, then you correct it. Not first as ptosis, then squint. Horizontal muscle surgery, larger recession can cause lead height changes in many cases. So you have to do first squint, then reassess the amount of ptosis, then do the ptosis correction.
Even for like horizontal surgery, if the squint is horizontal, it becomes more apparent if you correct.
Yes, that's what I'm telling.
That squint becomes more apparent.
Squint becomes
more bothersome. It's always good idea to correct the squint.
Okay.
So next we had management of lag of thalamus by Dr. Joita Das. So any questions regarding that?
One question that will you try the gold plate? What is the weight of this gold plate?
Usually, I already have this gold plate around 1.2 to 1.4 gram. This is
That
the
means
weight.
it's a gravity causes fall down.
Yes.
Is there any other use any spacer material here?
Yeah, I have used bank sclera in some cases.
Why not use this knitted polyester fabrics?
No,
I am
no,
using
this
it.
is no. We don't have
This is the
access
first
to that.
time.
We don't have access to.
But this
certain-
material
okay.
is used by cardiothoracic surgeon.
Yes.
I have learned, and then I applied it.
Yes,
This is not only the use of a VSD repair.
What will be the approximate cost?
Cost is very high, I think. The
Yeah,
cost
that's
is
what
very
I
high
want to
because
know.
it is 10,000. It's
Okay,
10
for
by
one strip.
10 by 10 inch. No, 10 by 10 inch is costing about 9,000, but it is our government supply is free.
That's the
So we
good thing.
actually we cut the 1 inch by strips and taken it. When you apply a patient, then you can apply it one by one, and you have a ETO facility, then you can do it.
Yeah, Dr. Mandal, it is-
Approximately, if you do it, that costing about in each my case is 400 rupees.
Can I ask you one? This is related to the weight of the material. It is not the
Yes.
spacer.
Actually, it's a neurological
You should have an inventory of some weights.
Weights,
and you
weights.
put it on the lid with a sticking plaster, and you see how much lead is coming, and then you order for the patient.
No, why
that
is
this
gold?
much is required for this patient? Because any one weight may not correct everybody.
No, I am.
So that is the surgeons who are
my
placing it.
question is why using gold? Lots of material. Why not steel?
It's the most inert. It's the most inert in the
It's
inside.
very costly, no?
Yeah, it's costly, but it is the most inert.
No, sir, it's not that costly. 1 gram, it's around 3,500. 3,500.
Gold?
Yes.
That's the one we use, sir. Okay. Okay, sir, what sir told that we should have an inventory. Sir, you told no that we have a, yeah. So actually, sir is correct. So we use silver weights. We use silver weights in our OPD to see how much it is getting corrected. And
Most
to that,
important in our society, gold is an investment, so it can be kept, right?
Yeah.
So probably you search for other material which can be worked as an investment.
And
so
sir,
this
to
is,
add
I
to
am
that, sir-
finding it very nice,
Yeah.
because gold is probably in this perspective you cannot compare with any other material.
And sir, you know, patient is very happy when the gold gets exposed. So sir, please remove it and please don't put it back.
Yeah, that was my next question actually. Though gold
Yeah.
is an inert metal,
Yeah.
in a long term, on what frequency or what percentage do you have the extrusion rate?
Yes. Yeah, sir, see, extrusion rate is, if you don't cover it with orbicularis muscle, if you don't make pockets and don't cover it nicely, since the skin is very thin here, eyelid skin is very thin, so there are high chances that over a period of time it will get exposed. So when if it gets exposed, it's a better, like good idea to remove it immediately because gradually there is a loss of skin in that area. So
After putting the gold plate, after a few years or after some time, there is one term called thixopexy. The muscle actually gets some changes. So even if you remove the thing, this muscle still, the lag of thalamus is still corrected to some extent. So this is it's very good and simple technique actually.
And if anybody has any doubt regarding weight, I think you can use 1 gram of gold in every case. That will nicely correct the lag of thalamus, and there won't be much of ptosis because you have to balance correction of lag of thalamus and the amount of ptosis which you are inducing. So if you don't have a silver weight, you can use 1 gram in each and every case.
I would like to ask Dr. Joita about lag of thalamus correction with auricular graft.
Yes.
So what is the long-term outcome in such grafts?
This is very good outcome. After this case, I have seen almost more than 2 years follow-up.
Okay.
So he's doing very well and very good stable lower eyelid, because this patient usually develops some atrophy, and that atrophy of the muscle is really difficult to correct. This gives a very good support for the lower lid.
Because I have done like mullar muscle recession along with tarsal spacer graft in some of my cases, but I happen to see that the tarsal spacer graft, they get reabsorbed after a certain time. So again, patient basically lands
In
up.
my cases, still it's working well. Yeah, I did it for lower lid here. Yes, the lower lid.
Yeah, Joyita, you were showing a brief video on the medial canthal tendon tightening procedure.
Yes, sir.
Caruncular recruitment, I think that is called. So, how many of you are actually performing that procedure apart from Joyita?
Oh. Thermoplasty, that
caruncular
canthal
recruitment.
thermoplasty.
I don't do application.
Okay.
Because like rheumatoid plication is practically impossible. That posterior tendon and plicating it, you cannot do it unless you injure the canal side. It's extremely difficult.
But I did in only 4-5 cases, but not long follow-up.
Canthoplasty is easiest.
Can I make a comment? Yeah, actually, it's definitely one thing that the lateral canthus is far more forgiving for surgery compared to medial canthus. This is the correct point that it's more difficult. But in the rare scenario where you have that laxity of the medial canthal tendon, and that you would see in some people where you actually see the distance between the canthus and the limbus, medial limbus, has shortened, you would have to address the medial canthus. And you can do that, particularly when you are, let's say you use a transcaruncular approach for orbital surgeries. You essentially have to take a suture, preferably braided, or you may also take a non-absorbable suture, and you have to take that bite through the periosteum. It's definitely demanding, but it's possible. And
It's very challenging. Passing the suture in the area, bringing it out.
Now I think.
Yeah, so I think the next talk was on temporalis muscle transfer, the dynamic procedure discussed by Professor P.K. Jaisal. Any question for sir?
I had a question. Excellent talk and very illuminating. The one thing that I noticed was that you mentioned about the Gillies technique in the Johnson. And I'm sure in the Johnson, you actually, the photographs you showed, you used the palmaris longus and you mentioned fascia lata. Now, instead of taking the muscle to the canthus, both the medial and the lateral canthus, versus actually using the muscle and then transmitting that force or the thrust onto a tendon, do you think there is a difference in the lag closure that you would achieve? That means, are you going to lose some action? Because some of the concepts that in this kind of surgery that is talked about is that if you take the muscle, then it hypertrophies over time. But I guess that is not going to happen with tendon. So between muscle and tendon, do you think there is a difference? And your thoughts on that?
No, the power is... No, the power is provided by the temporalis muscle. The tendon is only the connecting unit. So, since we don't have the adequate length of the temporalis tendon, that's why we are lengthening it with a palmaris longus tendon. But the power is being provided by the temporalis muscle itself. So what was your question? That since we are adding it by the palmaris longus, portion of the power will be lost in the transmission. That's what you mean to say?
I just had a thought that while the direction of the muscle is better in the Johnson's technique, are you losing out on some of the power by not taking the muscle but only taking the tendon?
No, we are the posterior third of the temporalis muscle and the tendon are taking in unison. Basically, we are cutting the lower posterior third of the tendon and then we are isolating it for 3 centimeter. We are isolating the tendon for the 3 centimeter. That means the posterior third of the temporalis muscle along with the tendinous part will be contributing to this unit, whereas the rest of the muscle will be for the masticatory.
Sir, how much time does the surgery take, sir? How much time approximately? The Johnson one.
I would say one-sided. If we do for the one-sided, it will take around 30 minutes, 30 to 40 minutes.
That's it.
Dr. Josh, what I can see is a lot of oculoplastic surgeons are going to come knocking at your door. And this is a wonderful thing. I'm so happy to have you here. This is a wonderful. Humagni, thank you for introducing us to the field of plastic surgery. But please carry on with the questions.
Hello? Dr. Josh, is there any temporalis hollowness here?
No, because we are not taking out the temporalis from its bed. The temporalis muscle remains there only.
Oh.
The Gillies approach, you can say that, yes. In the Gillies approach, there will be hollowness in the temporal area and there will be a bulge over the zygomatic area.
Yeah.
That's why it has gone out of popularity because of that.
Yeah.
But not in the Johnson's approach.
Okay, so next I discussed regarding myogenic ptosis. So I'll be happy to take any questions on myogenic ptosis. Or we can discuss it with panel.
Shahid sir, you were telling us about the seesaw between anti-musk and, no, not the balance. The balance is quite clear. Okay. The seesaw between anti-musk and anti-ACH receptors. Why is that? Is there an explanation for it?
No, I don't, like whatever I read, I didn't see any explanation, but yeah, it's clearly written that if ACHR it's positive, then anti-musk will be negative. And if that is negative, then you should look for anti-musk. And if you have a strong suspicion, if anti-musk is positive, it's the oculomycin is of
the problem we as ophthalmologists face is that in isolated ocular myasthenia, often ACH receptors are negative.
Yeah.
Isn't it?
So that's why the
clinical
neurologists, they do the whole panel now. They will do ACHR, they will do musk, and the titan also, the titan antibody, that is actin, myosin, and they will do everything in a panel.
Okay. One last question for you is that if you have bilateral ptosis symmetrical like you have in CPO, would you operate on one eye or both eyes?
Yeah, now I operate one eye, sir.
You would operate only on one eye, and you reserve the second?
Second
just in case there is a
so
complication with the
first.
first.
It resolves completely, then the second eye if the patient wishes. Sometimes the patient says, I am happy with it, like I can use.
Since the residents won't ask questions, we'll ask questions.
Dr. Sahid, I have one.
You know one of the symptoms of so what is the presenting symptom with CPO? How many patients with CPO have diplopia? I mean, the person who answers gets a chocolate, maybe next week. But this is a question I want you to ask yourselves. So they do not develop diplopia.
Dr. Shahid, what your advice to the patient after operation ptosis?
In these cases?
Any unilateral cases? Suppose you do normally. Any attitude advice, any posture advice, any looking advice?
Yeah, so in normal, sir, what sir is asking, like the general post-op advice after doing a ptosis surgery. So what we generally advise is don't sleep directly under fan or AC vent, and we tell them to take care of the frost suture, how to apply the frost, especially in the first 2 days, how it is important. Aggressive lubricants that you have to tell. So, and what I have routinely see, we give Lacrygel to the eye and an antibiotic to the sutures. So patient will be applying antibiotic to the eye and Lacrygel to the sutures. So that, yeah. So these are all the things that we see, and of course preoperatively we tell them about lag of ophthalmos and lid lag, so that can persist.
You should explain about that. In down gauge, it is lid lag.
Yeah.
You should appreciate. So bend down the head like this.
Yeah. So don't
bend down the head like.
Don't bring your eye down. Bend your head. Yeah. So next we had a talk on novel method of managing lid retraction by Professor Salil Mandal. So we have any questions for him?
Mike.
Solin, Joita has corrected the early detection by using wood. But due to mechanical ptosis, it is corrected. But you have used the polyester fabric. What is the difference between the weight?
No.
How does it act?
I am saying the pathology is different, Pathology is different. It is in thyroid ophthalmopathy. It is basically contracture of the retractor muscle. The LPS and the molars muscle in the upper lid and lower lid, it is a inferior retractor. So it is not, it's wide open. It may not be a proptosis, but it looks like a proptosis due to a retraction problem. So this is the nature of the thyroid ophthalmopathy. We have to study about it. So what is our objective? To lengthening of the lid to make a spacer material. Lots of scientists are working over this spacer material here.
How does the material act? What is the mechanism of action?
Mechanism means create a space, maintaining the lengthening of the lid. You understand? Create a space. The main retractor is disinserted from the tarsal plate, and it is thrown back. That area is covered by this fabrics material. Previously, it is used by the fasciolata. It's bulky, scleral, maybe immunogenic reaction. So this is an upper lid. The most important thing is upper lid is the lid height. That patient have a vision. So you have to do the adjustment, plus cosmetic, plus lid flow, lots of things. Then we have to change our incision pattern. When the patient looks upward, because I intentionally induce a moderate ptosis. Why? If you do a severe ptosis, the visual axis may be gone. So moderate ptosis, means you induce, and when you repair it, it is comes to a mild ptosis. Mild ptosis is acceptable. So that is why we are doing the spacer material for this person, but this is only for thyroid ophthalmopathy. And in lower lid, again the retraction problem, again the chief retractor is the inferior retractor. You have to cut from the lower border of the tarsal plate. So it can be an internal approach, it can be external approach. When there is a good proptosis there, you cannot be entered through conjunctival approach. Then you should through external approach. So, but external approach, you have a long way to go to grasp the inferior retractor. Even inferior retractors are intimately adhered to the conjunctiva. So you have to cut from the external approach all the layer. Then you have to separate the conjunctiva. Then conjunctiva should adhere to the tarsal plate and create a space between the retractor and the tarsal plate border. You apply the semilunar set polyester fabrics. The material good, no doubt, because the cardiothoracic surgery repair the VSD. Why I am an ophthalmologist? No doubt it is accepted. And the most important thing, no infection, no reaction. In the first day, patient become fit.
Thanks, sir. Thanks a lot. So last talk was on Botox by Dr. Raka. So any questions for Dr. Raka Chatterjee?
So, and suppose in patient have a means spasm. You know, I have given Botox, a patient complains of ptosis. So what is my technically wrong?
Sir, pardon? I couldn't
Patient
answer.
have a essential blepharospasm unilaterally. I have given, and there is a little drop. Why?
Sir, actually, when
is
we...
that technically wrong? I have.
Sir,
How it is happened?
when we inject Botox for essential blepharospasm, the orbiculis oculi we inject is the pre-tarsal plate. Just the orbiculis oculi over the tarsal plate. There. Now, one thing, if it is given carefully, nothing will happen. Now, the diffusion circle of this Botox injection is about 1 centimeter. By chance, if it diffuses into the levator, there, but it is a reversible, and in Western world, apraclonidine drop is used, and I think here brimonidine eye drop can be used alternatively to correct ptosis. Can be used for 2 weeks.
So technically, I may wrong. That is.
So maybe may not be because it accidentally it seeps into the preceptal.
What happened? It is happened after 7 days.
Sir, can happen, sir.
What is the duration of this action of this Botox?
So depends, varies from patient to patient. Number one, how many times the patient has taken the injection beforehand. Because of disease atrophy, gradually you have seen the interval between the 2 doses are also increasing. Yes, and usually 3 to 6 months, 8 months.
And what is the means one vial? Is the cost is 9,000, no?
Sir, 50 unit vial.
Huh?
MRP is around 12,500.
But in one vial, how many doses you are using?
Sir, 50 units vial, if I reconstitute it, and it can be used within a month if it is kept in proper storage conditions. Yes, can be used for a month.
Dr. Raka, I have a question.
Yes, sir. Yes, sir, I'm here.
In which case, what amount of Botox you will give? What is the percentage? How do you decide? How do you decide?
It's actually given unit-wise, sir, and we can, it's if it is a 50-unit vial, we can reconstitute it with 1 ml normal saline, we can reconstitute it 2 ml, we can reconstitute with 5 ml. Now, if 5 ml in 50 units means 1 ml, 10 units. So the concentration changes depending on the reconstitution. And amount of contraction, it's a clinical experience how much we are going to give. And it's for a newcomer, we can start lower dose. If required, we can top up with more. Yes, sir.
Dr. Akka?
Yes, sir.
Since you said it's a temporary procedure which lasts for a few months.
Yes, sir.
So how many times can you give this injection over a period of a lifetime of a patient?
So though I have a very short career myself, sir.
From the literature, not from, maybe not from your, as many times
as I can, yes.
Okay, because the screen stars you were showing, some of them are very
ageless, sir.
And if they require it frequently, then I don't know how many.
His face have you seen recently? She is around 80, I guess.
I know, that's why I'm saying, is there any limitation? Not only Rekha, Jitendra and others.
Everybody, sir, everybody.
Yes.
I want to ask
apraxia, pilot opening, can
Why do you want to?
So we can use, but orbicularis myectomy is a more specific treatment.
Yeah, and it doesn't work well.
I have seen the clonazepam is also working.
Sir, haloperidol, clonazepam, diazepam, we first send to neurologist. And in these cases, I personally try with dry eye management, give rest to the eyes, and take a neurologist advice. And many often a time patients come ki madam onek din dhore to hocche oshud khacchi ar hocche na, so straight away then I give Botox.
Devabrata, clonazepam and other such drugs, they sedate the patient. It's not very useful in the sense that they become non-functional. So Botox is actually the way to do it.
What I'm saying, it is not good, but means they get reasonably good.
Yes, and they're drowsy through the day. If you don't mind, we have exceeded time by 7 minutes. We are actually due to start the next program. So I will request, thank you all panelists for having given strong support to the program. And I would request the next panelists to come forward. Professor Muhammad Yasin would be chairing this session. Before Professor Pradut Narayan Biswas, my teacher, to present the memento to Dr. Parag Mukhopadhyay. In the meantime, I would request Professor Yasin to step forward. Sir, tea break, you can all take tea in between, but we will start a session on time. Huh? 5 minutes? 5 minutes? No, 5 minutes, sorry. Huh? So you can take turns to take tea. Presenter is ready, we are ready. I will request the panelist, Dr. Saurabh Shannal. Time rakte parlam na. Chalu rakha hi unse. Panelists सब लोग नहीं हैं. Professor Rakhi Banerjee এখানে আছেন? Rakhi di বাইরে গেছেন. Dr. Madhusmita Behra. Sir, madam, please आ जाइए. And Dr. Indranil Pal. Sir, I request you to postpone your tea break. So you can take turns and have tea. Madhusmita, आ जाओ please. Professor Yasin Baira Gachen. In the meantime, Dr. Saurabh Shannal भी बाहर गए हुए हैं. ठीक है सर. And I would request the moderators, Dr. Kumkum Ghosh, to continue with the session, and Dr. Raka Chatterjee will take over from Dr. Shahid. हाँ, ना तो समय शेष करते पारबो ना. দুজন প্যানেলিস্ট বাকি আছে তারা হচ্ছে সেকেন্ড সেশন এন্ড থার্ড সেশন ঠিক আছে তাহলে ওটা খেয়াল রেখে দিই দাদা হল তো ফাঁকা হল ফাঁকা নেই লোক है देखिए we are blessed to have a large hall but interestingly a lot of seats in the front are empty so I would request our delegates to come forwards and join us
सीनियर लोग आते तो माइंड करो चलो लगा स्टार्ट करो फटाफट करो लंच 3 बजे
3 नहीं 4 4:30 के पहले कुछ नहीं मिलने वाला
तुम चलो स्टार्ट करो
Hello. Moving on to session 2. I request Honorable Chairperson Professor Mohammad Yasin. Okay. The panelists for these sessions are Dr. Saurav Sannal, Professor Rakhi Banerjee, Dr. Madhusmita, and Professor Indranil Pal. Okay. Okay. So, first speaker for session 2 is Dr. Devi Kundu. She is the Associate Consultant in Oculoplasty, Shankar Netralaya, Kolkata. She will present on congenital nasolacrimal duct obstruction. Dr. Devi Kundu, please.
Thanks, ma'am, for the kind introduction. Thanks, Shushrut. I'm overwhelmed to be a part of the session today. So, birth of a baby is a joyful moment for a family. We all jump baby. But what if the watery eyes are seen? There may be many causes, but the most common cause is congenital nasolacrimal duct obstruction, that is CNLDO. So I'll discuss a few points over the anatomy, embryology, causes, clinical pictures, differential diagnosis and treatment of CNLDO. For anatomy, in the medial part there is lacrimal apparatus, superior and inferior puncta, vertical canaliculi, horizontal part of canaliculi, joined to form the common canaliculus and opens into the lacrimal sac, which continues as the nasolacrimal duct to open in the anterior part of the inferior meatus. Embryologically, it is the invagination of the surface ectoderm starting as a solid epithelial cord in the naso-optic groove. Its canalization starts at the 3 months of gestation and it ends at 6 months of intrauterine life to several months after birth. But the caudal end of the naso is the last to canalize. Here we can see the nasolacrimal duct hasn't opened in the inferior meatus. There is a membranous obstruction. Here we can see the nasolacrimal duct passes lateral to the nasal mucosa, clear up to the floor of the nose, and here we can see the bony obstruction. So these may be the causes of failed probing in case of first attempted probing. So causes of obstruction are mainly failure of canalization of the cord, retained male, complete obstruction or absence secondary lifting of nasal and maxillary process, tumor and stricture. but the most common cause is a membranous obstruction between NLD and inferior meatus. The child can present as with epiphora discharge. We can see rho plus negative or positive. There may be acute dacrocystitis, dacrocystocele, mucopyocele. So this video showing a proper method of checking rho plus test. We have to palpate the inferior orbital rim, go medially and posteriorly, then press the soft part of the area. The differential diagnosis may be the periocular masses around it, like capillary hemangioma, dermoid cyst, nasofrontal encephalocele, anterior ethmoidal mucocele. Treatment up to which is usually Kriegner massage. The proper method is to feel the inferior orbital rim, go medially and backward, feel the soft part, rotate 3 to 4 times, then go down. After 1 year of age, it is the probing and syringing under endoscopic guidance. In our institution, we do it under general anesthesia. So first we do it through the upper puncta, go vertically upward, then medially, feel the bone, and then pass the probe backward, laterally, and inferiorly. We can see the probe inside the inferior meatus. We do serial dilatation and rotation of the probe to enlarge the ostium. And a sure sign of the probing is the fluorescent dye coming out like with syringing. The risk factors for failure of probing are age more than 3 years, failed earlier probing, false passages, craniofacial abnormalities, or intraoperative form or bony obstruction, as I shown before. Timing of probing after 1 year. Success rate of first probing without intubation in the first year is high, that is 95 to 97%. Less than 2 years, it is 76%. More than 2 years, it is 33%. Indication of early probing are dacrocystocele, recurrent dacrocystitis, need for early intraocular surgery. For intubation is repeated probing in same setting, previous probing failure, after the age of 2 years with long-standing infection and craniofacial abnormalities. So to conclude, we should give a proper conservative management with Kriegler massage in a proper way. We should plan probing after 1 year of age under endoscopic guidance, under general anesthesia, and negative rho plus and patent syringing are the sure signs of successful probing. These are my references. Thank you.
Thank you, Dr. Devikundu, for which is very informative. Now I request Professor Dr. Yasin sir to hand over the memento. He is our ex-president of Ophthalmological Society of.
No, in this regard, I would like to say that we do packing of the gauze in the throat by anesthetist only. So there is no chances of fluid going through the throat. Thank you.
Our next speaker is our own Dr. Navajyoti Goswami. He is a senior consultant of Shushruta Eye Foundation. Apart from Oculoplasty, he is an excellent cataract and refractive surgeon. And this gentle, smiling doctor with a good sense of humor is very, very popular. He will present on external DCR.
Good morning, everybody. My presentation is on external DCR. Actually, external DCR, it's a surgery for the general ophthalmologist. I learned this procedure during my PG life, and I'm doing it since almost 20 years with slight changes and modifications. And I am not an oculoplasty surgeon. So this year it is a bypass procedure that we all know that creates an anastomosis between the lacrimal sac and the nasal mucosa via bony ostium that relieves watering in patients with nasolacrimal duct obstruction. It was first documented by Tote in the year 1904. This surgical procedure, it almost remained unchanged. It remained the gold standard in the outcome of surgical management of primary acquired nasolacrimal duct obstruction. It's almost been 100 years. There are two clear goals of this year procedure: a large bony ostium into the nose that remains so, and to have a mucosal lined anastomosis. And since both these purposes are well served by an external route, it is still one of the preferred approach with high success rate. The main indications, the persistent congenital lacrimal duct obstruction, unresponsive to previous therapies, primary acquired nasolacrimal duct obstruction, and secondary acquired nasolacrimal duct obstructions. Here in Susrut, we do mostly external DCR with a single entry flap in all cases. We do a superior suspension of the anastomosis to the overlying orbicularis muscle to prevent sagging of the mucosal bridge and subsequent closure of the ostium. This is a view of an external DCR. So the block, we use 2% lignocaine with 0.5% bupivacaine. Mostly the infratrochlear and the anterior nerves are being blocked. A proper block is very much important for patient comfort and smooth surgery. The incision we give a 10 to 12 millimeter incision, just 3 to 4 millimeter away from the medial canthus, medial to the medial canthus. Then we split the orbicularis muscle with curved seizure. We avoid cutting the fibers of the orbicularis to prevent bleeding and preserve the action of the orbicularis muscle subsequently. We do blunt dissection to expose the anterolacrimal crest. Once the anterolacrimal crest is exposed, we divide the medial palpebral ligament to expose the fundus of the sac. We separate the lacrimal sac from the lacrimal fossa. After that, we make the flap from the sac. I make a U-shaped single flap with a curved seizure. Try to make it in one go. We can pass a lacrimal probe through the infracanaliculus and tend the lacrimal sac for better visualization, or you can do without it also. Once we make the flap, we cut the posterior part of the sac. After that, we do a probing of the canaliculus to check the patency of the inferior canaliculus and the common canaliculus. We dilate the inferior punctum with a punctum dilator. Pass a probe, lacrimal probe, through the inferior canaliculus to check the patency. Once it is patent, we go for the bony ostium with a punch. The ostium should be of proper size roughly around the size of the thumbnail for a proper successful DCR. After the ostium is made, I place a cotton swab soaked in adrenaline over the nasal mucosa and infiltrate the nasal mucosa with lignocaine. Incise the nasal mucosa with 11 number blade. Then with a curved scissor, make another U-shaped flap from the nasal mucosa. These are the two flaps being made. One is the lacrimal sac flap, other is the nasal mucosal flap. The bigger flap is trimmed carefully so that we can suture the flaps edge to edge. After the flaps are being made, we remove the nasal pack. Check the patency once. Sometimes the nasal mucosa is very much thick that we get a partial flap. So we check the patency of the ostium. Then we suture the flaps with 60 Vicryl. We superiorly suspend the anastomosis to the overlaying orbicularis muscle to prevent sagging of the anastomosis. Close the wound in 2 layers, muscle with Vicryl. And silk with, and skin with silk with interrupted or subcuticular suture. So a successful external DCR depends mainly on 2 factors, the size and position of the bony ostium and the flap anastomosis. The size of the ostium, it should be around 15 by 15 millimeter, roughly the size of the thumbnail, and the extent slightly above the medial palpebral ligament superiorly, posteriorly till lamina papyracea, anteriorly and inferiorly as much as possible. And regarding flap anastomosis, we should oppose the nasal mucosal and the sac flaps edge to edge. Excess mucosal flap should be excised in a controlled manner. Superior suspension of the anastomosis to the overlaying orbicularis or periosteum should be done to prevent sagging. In Susut, we are having a success rate of more than 95% post-external DCR. The main concerns in external DCR are the intraoperative bleeding and the postoperative scar. The intraoperative bleeding, it can be to a great extent if we rule out any bleeding diastasis preoperatively. We control blood pressure. Preoperative use of nasal anesthetics, nasal decongestants. We advise patients 1 week prior to surgery to use nasal decongestant. Preoperative nasal pack soaked with 4% lignocaine and xylometazoline nasal drop. And intraoperative use of adrenaline, I personally use a cotton swab soaked in adrenaline and place it over the nasal mucosa before making the mucosal flap, nasal mucosal flap. And postoperative scar, it is actually very faintly visible, almost invisible scar of 1 month. These are two patients, the first 10 days post-op with subcuticular suture. This is just after removal of the suture. Another patient, again, 10 days post-op with then after removal of sutures. These scars are almost invisible after 1 month. So to conclude, appropriate medical and surgical maneuvers can transform external DCR into an easy and successful procedure with minimal bleeding, invisible scar, and long-lasting results. Thus, external DCR is still the gold standard. Thank you. Thank you very much for your kind presence with us in celebrating 25 years of success of Susut Eye Foundation.
Thank you, Dr. Goswami, for your very nice presentation. It is a very useful one. Request Professor Yasin sir to hand over the memento. Thank you, sir. Our next presenter is Dr. Sajal Shur. He is a prolific ENT surgeon. He will present on endoscopic endonasal DCR today.
Thank you, organizers, for inviting me here. And good morning. I'll briefly narrate on endonasal DCR. So I got serious. Fine. The funny part about endonasal DCR surgery is for an ENT surgeon, the pathophysiology is beyond our scope. The diagnosis is not made by us. We can give permission from ENT point of view for external DCR surgery. And in many instances, we do endonasal surgery for DCR. So why endo-DCR? First of all, the approach is direct. I'll show one diagram later. And why the approach I'm telling direct, I'll tell you. There is the cosmetic value. Basically, we get the female patients to avoid the scar. There is no damage to medial canthal ligament or orbicularis oculi muscle. So that TR pumping mechanism is least hampered, and less handling of the sac because we are cutting the medial wall of the sac. So this lacrimal sac atonia will not be there, and it can be performed in acute stage where external incision is a problem because of healing of the wound. And as far as success is concerned, it largely depends on two factors. First, proper diagnosis. Our ophthalmologist friends, they do this part. And second is expertise hand. More you do any surgery, you can give good result. At present, we are giving more than 90% success in endonasal DCR. I'll not talk much about anatomy. Only one concern is about the bone removal. That is most important. The lacrimal bone and the frontal process of maxilla, if we are not removed properly from the endonasal site, the chances of failure will be more and more. As far as preoperative assessment is concerned, this part again beyond our limitation. We generally look into two parts. One is endonasal examination by means of endoscope. We want to exclude whether there is any gross deviation of nose or not, any polyps, any tumor or growth that can block the stoma. And if the patient is suffering from recurrent cold or there is sign of sinusitis, we ask for CT scan PNS to see what is the problem there, because chronic sinus infection, infection in the stomal side and problem. I would like to mention this DNS part here, because many instances I have seen in my OPD that patients are coming with DNS. Now, if we go for endonasal DCR, gross deviation of nasal septum only needs correction. Mild deviation, I'm sorry. If we go for endonasal DCR, the correction of nasal septum is much more important than getting some deviation of nasal septum and doing external surgery, external DCR, and telling the patients, no, you can't do this procedure, you have to go for the septoplasty and only then you can go for the DCR operation. I have seen many, absolutely septoplasty is not necessary. You can directly approach for DCR from external DCR point of view. But it has been prescribed in prescription that you have to go for septoplasty first or with septoplasty and DCR. I think this is not correct. Now techniques. There are so many techniques. The conventional approach, laser part, radio frequency, powered microdebrider, but most commonly we perform the mucosal flap surgery. What is mucosal flap? We elevate one rectangular flap from that part of the nasal lateral wall which corresponds to the lacrimal sac. We reposition the flap there. Why we reposition the flap? Again, we'll discuss in our videos. So infiltration. There is a small video. So pointer because this is the nasal part, I think I must show. So this is our middle turbinate, this one. This is nasal septum. This is the lateral wall of the nose. This is the axilla of the middle turbinate. So our lacrimal sac is somewhere here. This infiltration we need to make here so that majority of the cases we do under local anesthesia, and this part will be anesthetized. So as far as infiltration is concerned, I would like to share one experience. I do not inject preformed adrenaline and lignocaine, that xylocaine. I always use Loxicard. Loxicard comes without preservative, that is methylparaben. The anaphylactic reaction is given by inadvertent injection of methylparaben into the vein or arteries, whatever it may be. So if I use Loxicard, this is of single use and it is commonly used in cardiology practice. If any intravenous injection is there, nothing will happen. Adrenaline, I add according to my choice. I take insulin syringe, I take 1:1000 diluted adrenaline. As per patient's body weight, maybe 1 unit, 2 units, according to patient's requirement, we inject and make the solution. I have seen this technique there, and with this fear of injection of methylparaben into the venous system and getting some problem, we are not facing all these things. So after infiltration, we are going into incision part. Again, the incision, what we are giving by means of a 15-blade knife. This is the nasal septum, this is the lateral wall. So we are making one horizontal incision few millimeter above the axilla, and it stretches approximately 1 centimeter forward. There is one vertical incision down, and the third incision is parallel to the first incision about 1.5 centimeter below from the starting of first incision, joining the vertical incision. So there is one rectangular flap where the base is attached in this part, and these are the free margins. There is periosteum, and we need to elevate this part of the flap. Now, the next part is exposure. So you can see this is the free margin of the bone, lacrimal bone and frontal process. So we need to take out the bone from here. This is a Carrison punch. We are taking piece by piece this bony segment. We need to take care that so that the sac is not injured. You can see that part of the sac here, and whenever I am taking this punch, you can clearly see after taking this punch, the sac behind this. This is the sac. I think you can see. So during this bone punch, care must be taken so that as high as possible, the bone should be removed. Maybe up to the level of common canaliculus. Inadequate removal of the bone will lead to stenosis, fibrosis, and failure. So this is our sac. This whole part is our sac. We are applying pressure from outside, and we can see the movement of the sac. Now, the next part is making stoma. So many instruments we can use, but I prefer 11-blade knife because of its sharp tip. So we are making one incision. The pressure we use from outside so that the bulge, the sac can get a little bit of bulge. We can clear out from the sac. This is one good sign because we are sure that we are inside the lumen of the sac. Sometimes what happens, this medial margin, we dissect in between margins, or the incision we put in between layers. So that can create some false passage. This is the medial wall of the sac. We are excising in toto so that the whole part, the whole medial wall is dehiscence. After removal of the sac, we can see the inside of the lumen. See, this is the whole wall of the sac. This is the lateral wall of the sac and medial margin of lateral wall, and this part is the common canaliculus. I'll show this part once again. Just to prevent the failure, we need to concentrate on exposure and exposure. And our uppermost exposure is most important in case of endo-DCR. That is the most common cause of failure. And we must reach up to the height of at least up to the level of the upper canaliculus, so that there should not be any the main part of our common canalicular region, and you can clearly see that tear is flowing, coming out. Okay, thank you.
Thank you, Dr. Shur, for this excellent presentation. Now, I would request Dr. Mohammad Yasin, sir, to present a memento to Dr. Shur. Now, we will request Dr. Suryasnatha Ratha. He is the head of Department of Ophthalmic and Plastic Surgery, LV Prasad Eye Institute, Bhubaneswar, to have his talk on non-endoscopic endonasal DCR, a decade's experience.
Thank you. First of all, I happened to be here yesterday evening, and we were talking to a few residents. And it was wonderful to interact, but the most important thing was that I came to know that this particular oculoplasty update is the first CME that is happening in this particular auditorium, and there's a wonderful infrastructure. As we all know in medicine, ultimately, dissemination of knowledge and education has the maximum multiplier effect. If you really want something to have an impact on people, keep doing more of education. With that, I'll come to what I am supposed to be talking about, and I'll try to talk about a technique which I learned about more than 10 years ago. And it's probably thought to be the best of both worlds. My preceding speaker has already talked about the advantages of endonasal DCR, but I'll try to touch upon what are the things that really make the outcomes superior as compared to external DCR. There were decades spent in that discussion with an external versus endonasal, and I think over time the outcomes have really matched up with external. Anatomy is always important, and the only thing I want everybody here to remember that when you go into an endonasal technique, remember what you're doing the surgery points towards the orbit. Compared to an external, all your sharp instruments point away from the orbit. So that's something that you have to keep in mind, because that's the risk of problems that can come. Positioning is definitely critical, and this may sound a little, sort of archaic in the sense that the positioning has to be on the opposite side, and is like using a loop and to look up the nose. Somebody who's been and actually seen this technique can probably relate to this much better, because when you document this technique, this is not an observer-friendly technique, because when you have to document this technique, you use an endoscope. So an oft asked question is that, if you're recording with an endoscope, why aren't you operating with the endoscope? So a very simple set of instruments, that's all that you need, and the important ones here are two. There was a reference to the septum deviation, and what we use is a nasal speculum with a guard, and that keeps your hands, both hands, you're not holding an endoscope, so you keep both your hands free, and the speculum with the guard actually allows you to get the necessary exposure at the distant site. And there is a cold light source, and there is a vitrectomy endoilluminator that we use for transillumination of the sac. The rest of the instruments are pretty similar to what you use in endoscopic DCR. Now that's the key thing. Now compared to what we saw as when you start doing your endonasal procedures in an endonasal DCR, the sac transillumination becomes very, very useful, because it's like light at the end of the tunnel. And these sequential pictures just tend to tell you that actually as you proceed on to going further onto the surgery, you tend to see more of the light coming in, and the dark areas tend to tell you that there is still residual bone. So that helps. The more and more you start opening out and tenting along the sac to prolapse, it actually tells you that that much of the bone you have removed. So it is actually something that helps a lot in the surgery. With that, I'll come to the first video. Now, this is where the arrow points to the point at which the sac transillumination is happening. And we would usually, infiltrate the mucosa just around that site, so that that becomes blanched and becomes less, it bleeds less during surgery. You could use a blunt instrument to medialize the middle turbinate.
But all along the surgery, it's this light which is appearing through the trans-illumination of the sac, which is helping you guide which direction you want to go. This is where actually a little bit of a modification that I've, over a period of time after looking at outcomes. So we do keep the the nasal mucoperiosteal flap these days, and that's the little modification that actually helps and achieves good success because you actually bring the two flaps into apposition with one another. Like I said, the bony ostium, like we saw before, and you can actually see as the light pipe hits a hard stop, that's what you want is the end point. It actually tells you where exactly, and throughout the surgery, you keep removing the bone and looking at what exactly is happening at the light there. I would probably go a little bit forward along this video to show. And this part is usually done with serial rongers. What I would prefer is a 90-degree 3mm ronger. But the key thing here is the body of the sac is much easier, and as we all know, the success really depends upon superior bone. And there's a lot of cancellous bone there. It's not very difficult, but you may need a different set of instruments to do that. And that's exactly what this shows. As you navigate your light pipe, it actually tells you what is the residual bone that is there, the bony spicule that is there. And you could use actually either several set of instruments. Sometimes now what I prefer to use is actually predominantly mechanical, where there's a rotating ronger which has different positions that you can use it to take out the bone. You could also use drill or whatever else is available in your armamentarium. But the key thing is, a lot of time this bone is actually cancellous, and if you've thinned it out, it becomes amenable to removal mechanically with the help of a ronger. I think that's the key thing that is important. But having said that, as you do that, the light pipe becomes more and more prominent. For a good endpoint of this surgery, while the light pipe is in the lower canaliculus, you want a good opening up of the sac because the fundus of the sac has to be opened out. These pictures were only to, just in case the video didn't work. Now in this particular video, what you see is that the light pipe is actually seen, and there is a full thickness opening of the sac that has already happened. Now after that stage you could use various instruments. You could use a crescent, a very fine set of scissors. But there are two things that are important. One is, after you've done that, you could either do what is like a marsupialization of the sac. That means you create a large posterior flap and take it and fix it to the lateral wall posteriorly. That was what I used to do originally and earlier. But based on particularly some particular surgeries, and particularly in the pediatric age groups, I started doing more of flaps. But before we go to the flaps, this is something that I wanted to share. Now in this, what is important is this particular posterior flap has already been, and we try to, it is there as a large posterior flap, and you could actually use glue to fix it posterior like I mentioned. And you could use fibrin glue to do that, and that's the light pipe coming in. Now, this particular thing is very important. Now you know that the light pipe is coming out. But what is critical here, you still have a little bit of a cuff of the anterior sac that is there. And you could use various instruments. It is critical to take out this so that you have a large marsupialized sac, which is at the end point of the surgery. And not the most, I would say, appropriate instrument to do that, but having essentially the end point is more important on how you, what you achieve rather than how you achieve it. Now this, of course, now look at this. After we've achieved that, what is the light pipe is very nicely coming. You still see a little bit of the sac beyond the point at which the light pipe is coming out. So that tells you that, yes, you've done enough. And this is when I'm saying it's a marsupialized sac. You've not created an apposition of flaps. MMC tubes, we'll talk about that later. Tubes is generally a yes in all patients. Now, mucosal flap apposition, we talked about the nasal mucoperiosteal flap that we had kept. So essentially bring them together. You see just underneath the light pipe is what the sac flap is, and what you see a little is actually the nasal mucosal flap. And you try to bring in fibrin glue to bring apposition to this. Over this, after you've put tubes, you can always use some sort of a, ab gel or a neurosurgical cottonite to kind of keep it over so that it stays in place. Suture in this particular area is done by very few people in the world, and it's definitely very technically demanding. So that's the technique. Coming to outcomes, We first published our series in 2015. At that time, we were talking, but this was a combination of all sorts of patients, and about 85%. But from then on, now we have this experience of the prospective randomized controlled trial that we are running for MMC. And based on the data that has come out, this is about 440 patients. And we had follow-up of more than a year for 350 patients. And I can happily say that the success rates on functional outcomes is 94%, and this is 12 months data. So what was the change? I think the big change was the mucosa-periosteal and meticulous bone removal superior. We heard that there are definitely very good outcomes in the acute DAC, and that's the one day after. This is definitely a change in the practice pattern that can help. And the big thing is the acute is the early rehabilitation. Mucoseals, again, are very good results. This was one thing which I'd heard earlier that, what is really the size of the osteum after it is healed in an external versus an endonasal DCR? And we ran this with the help of image processing MATLABs and ImageJ. But what was key is that how do you actually, because you've got magnification on the endoscope, so you needed to have an absolute on the picture which you needed to compare to find what is the size. And the absolute that we had was the lacrimal probe marked at 2 millimeters. Based on this experience, we actually found that between the two, and this was a set about 100 odd patients, more than 50 in each group, it actually matched up exactly with the size of at the perpendicular, the area, and even the position. The only thing that was different between external and endonasal was the position of where the ostium was. So which wall was nearest to the point at which the common canaliculus was entering. And that made a difference. Whether it had a relationship to the tear flow dynamics, we really don't know. But as far as the size is concerned, is absolutely the same. I really like this particular study, which is not yet published, but was a DNB thesis of Dr. Rashmi Dave, who was a resident. We looked at the trends of functional outcomes. That means the fluorescein dye disappearance test, the Monk score, how many times you wipe out your eyes, and also on a QOL score between external and endonasal. The key difference is, everybody talks about scarless surgery, but the key difference was that the main difference of advantage was in the first post-op day extending up to the 2 weeks. That means in the first 2 weeks after an endonasal surgery, the patient was much better in the number of times he was wiping his tears, and also on the fluorescein dye disappearance rates, which is a functional test used in the clinic by us. So telling us that there's possibility definitely that the patient is going to have an early rehabilitation. And the same appeared also on the quality of life scores. Peter actually published on the tubes versus no tubes, and there was a clear indicator that actually tubes were helping. And our own results on the MMC, because the literature seems to suggest that MMC is helpful. Even the Cochrane review 2019 mentions that there's a benefit. We seem to think otherwise, because our own experience of 350 patients, more than 3 minutes application in one arm versus no, actually showed that the functional outcomes at 1 year were pretty favorable, both for with and without MMC. So this was before actually Javed published that you could actually inject the MMC around the ostium. So that came out in 15-16. We were already underway on our RCT by that time. So I think essentially that picture, but these are all patients who were primary acquired nasolacrimal duct obstruction. To summarize, I think possibly based on the experience, this tends to tell you that possibly the technique without an endoscope seems to be the best of both worlds. It is, apart from the fact that early rehabilitation and pretty much compares with external DCR on the outcome, the big thing is the size of the ostium is very much the same, and also at the same time there is definitely a learning curve to the surgery, but the fact that the transillumination of the sac, something that is guiding you all through, seems to suggest that this could be actually a useful technique to learn and also use in your patients. That's all. Thank you.
Thank you, Dr. Rath, for this excellent presentation. So we are during surgery.
Yeah, a spectacle that you use. Yeah.
So, sorry. The loop that I use is the same. I mean, it's like a 3.2x with a 50 centimeter working distance. But the suggestion is you could use works for you based on your position, you know. So that's something.
So our next speaker is Dr. Nandini Botra. She is a consultant in ophthalmic plastic surgery services in Govindram Siksaria Institute of Dacryology, LVPI, Hyderabad. She has completed her post-graduation in Mangalore, pursued a long-term fellowship in LVPI. She is a clinician scientist who has several publications to her credit in peer-reviewed journals. She has almost 75 peer-reviewed publications, and she has done research under the Mahvid Ali sir. So her area of interest is dacryology, and she will be talking about recent advances in dacryology. Over to you, ma'am.
Thank you so much. So at the onset, I'd like to thank Dr. Anirban and Shushrutai Foundation for giving me this opportunity. So before I begin my talk, so far in dacryology, we've seen external endoscopic and non-endoscopic endonasal DCRs. But dacryology goes much, much beyond just DCR. So I'm really sorry, I have a bad throat. So there might be a little bit of disturbance in between. But what I'm going to speak actually is the year 2022 and the work and the research that we have done in the year 2022. So 2022 was a year of understanding and a year of challenging dogmas. So where dacryology is concerned, there are a lot of things that have been practiced so far which are age-old. And we continue to practice them, but we do not question them. So when we start questioning what we are doing is when we understand the system much more and in a much deeper way. So I'm going to be talking about basically these 6 things, that is age-related punctum morphology, the role of 5-uracil and the effect that it has on the lacrimal drainage system, about a surgical technique called POLD, and we will challenge 3 dogmas, that is retrograde intubation, which has been practiced since years immemorial, the incision and drainage that we do in lacrimal abscess, and the practice of punctoplasty, which actually should be abandoned, and why. So the first thing, let us talk about punctum. So punctum is something that is the most proximal part of the lacrimal drainage apparatus, and we should always and always have a look at the punctum, because that will give us a clue to the underlying diagnosis. So whatever little bit we know about the punctal anatomy, we know about it from cadaveric studies or on formalin-fixed specimens. But when we look at the anatomy in cadaveric samples or in formalin-fixed samples, there are problems like changes in the muscle tone and vascularity, and also changes in the tissue hydration. So it doesn't really give us the actual anatomy. So changes in anatomy and physiology is a function of time, and therefore what we did was we took 10 patients in each decade, and we took serial photographs in very specific positions, and we studied the punctal changes in each decade. So now this is let us look at this picture. This is the punctal, these pictures actually show the lower puncta. So in the first decade, if we look at the puncta, it is actually small and round. And as we move along the decade, it becomes horizontally oval. Along the decades, in the 6th and 7th decade, you will see that the size, which is gradually increasing from 1st to 5th decade, in 6th and 7th decade, there is a sort of constriction of the puncta, and in 8th decade, it again reverses. Similarly, this is the upper puncta. In the upper puncta, the puncta is round to start with. It becomes vertically elongated, then horizontally elongated, and in the 8th decade, it is the most dilated. We also looked at the punctal papilla. Now, punctal papilla is this area. So, if we actually look at older individuals, we see that this punctal papilla starts protruding. If we have noticed this in most of the patients. So this punctal papilla is actually an age-related change, which actually starts in the 5th decade of life. So if you see patients with punctal, with functional epiphora, you will see that these punctal orifices are actually more protruded in those patients. So that signifies more age-related changes. So that was in males as compared to females. So as I said, we also took ASOCT scans in all the decades. And as you can see in the pictures, we also see on the ASOCT that in the 6th and the 7th decade, the size of the punctal orifice is actually very, very narrow as compared to the other decades. And in the 8th decade, there is a sudden reversal, which was what we saw. So essentially, what does this imply? That if we are looking at the puncta of a person presenting to us with epiphora, and the patient is say 6th decade or 7th decade, we should not directly jump to the diagnosis of punctal stenosis and go ahead and intervene. Because that is a physiological change that is bound to happen. We have to look at other factors which are causing epiphora in these patients. Again, when we were looking at this, we divided the puncta into five zones. So the inner yellow line is the inner punctal rim, the blue line is the outer punctal rim. This area between the blue and the yellow line is the area of whitish discoloration, and the area between the yellow and this blue line is the area of vascularization. Now, why was this important? Again, as we progress through ages, what we saw was this peripunctal vascularization actually progressed, crossed the area of whitish zone and entered the punctal orifice area. Now that indicates that as we progress through ages, what happens is the vascularity moves closer, and conditions like idiopathic inflammatory disorders, the chances of these appearing over decade increases. Therefore, it was very important to notice that this area of vascularization crosses into the white zone at about 5th or 6th decade of life, which is when we see most of the inflammatory disorders in the punctal area. We did an angiography of the punctal area, and that is exactly what we noticed, that in the 4th and the 5th decades of life, the vascularization actually reached the puncta and the inner punctal margins. So as I said, studying the physiology of any tissue will give us an idea when to treat and when not to treat. So this was published in OPRS and can be referred to. The second is 5-fluorouracil. So a 5-fluorouracil is a drug that we use in most of the eye cancers. Now we know that it causes a lot of lacrimal drainage system abnormalities, but we never had the proof of this. So what we did was, there is a rabbit canalicular injury model which was developed, and it was found to be very similar to the human model. So the rabbit was actually instilled 5-fluorouracil 4 times a day for 4 weeks. And then these rabbits were sacrificed, and histopathological changes on the lacrimal drainage apparatus, on the conjunctiva, on the surface, on the cornea, and on the lacrimal gland was looked at, just to study what is the effect of 5-fluorouracil on these structures. So when we looked at the lacrimal drainage apparatus, we can see that there is severe atrophy of the epithelium with damage to the goblet cells, and a lot of fibrosis and inflammation in the substance of the lacrimal drainage apparatus. However, the cornea, the lacrimal gland, as well as the surface, the cornea, the conjunctiva, and the lacrimal gland were unaffected by 5-fluorouracil. So 5-fluorouracil doesn't really damage the ocular surface structures, but it causes severe fibrosis and inflammation of the lacrimal drainage system. And therefore, the period of washout that has to be given when we use 5-fluorouracil is very important. So we use 5-fluorouracil for a week. We need to give a resting period of 3 weeks with extensive lubrication so as to wash out any residual 5-fluorouracil, and only then repeat another cycle. So if we want to avoid damage to the lacrimal drainage apparatus, avoid 5-fluorouracil, but if we have to use it, give a period of gap between 2 cycles. Now coming to the third one, the next one, that is POLD. So in the morning session, Dr. Raka spoke about botulinum toxin injection to the lacrimal gland, which sort of reduces the epiphora in cases with proximal obstructions. So this is another technique where we do partial orbital lobe debulking. So what happens when we inject botulinum toxin to the lacrimal gland? It was clearly explained in the morning, so I'm not going to get into that. But we went ahead and did DATS. Now what is DATS? So under blue light, we apply fluorescein strip directly onto the lacrimal gland, and these points which you see are actually the points from where the drainage is happening. So this is the picture taken pre-op. This is at 2 weeks, this is at 6 weeks, and this is at 3 months. So what we see after giving botulinum toxin injection, initially the secretions decrease. There is an effect, of course, say 10 to 20%. So you can see the number of active points, which were 3 initially, are still 3, but the amount of secretion coming out from those points actually reduces. Over 6 weeks, it reduces even more, but over 3 months, it reverses back. So the effect that we have with either botulinum toxin or just needling is actually very temporary. It is not really causing a long-term effect. Now we do not know why that happens. Is the lacrimal gland lobules regenerating, or what is happening? We do not know. So we devised another technique where we thought, let us remove a part of the orbital lobe. So initially, we were removing the lateral half of the orbital lobe. And what we saw was, so this is actually a very, very simple surgery. You take a small incision just lateral to the brow. You directly reach the orbital lobe of the lacrimal gland, and you can remove about 40% of the orbital lobe of the lacrimal gland, leaving the proximal lobe intact, because that is where our ductules come out from. So here also what we saw initially, this was the area where the drainage was happening. There were, say, 2 or 3 points of drainage, which reduced to 1, but again, at 3 months, it reversed. So again, is there regeneration happening? We do not know. But then, under cadaveric guidance, we looked at what part of orbital lobe can we excise for maximum effectivity. So what we found was that this is the area where the vessels are present, where the hilum enters the lacrimal gland. And if we remove this area, does it cause any harm? And does it actually reduce the secretions? So this is, we use the endoscope to view the lacrimal gland, because of course with naked eyes it was very difficult to view the vessels and the hilum. And then we removed the lacrimal gland along with these vessels. And again, the result was still similar. Initially, there was a nice reduction in epiphora, say about 40 to 50%, but over 3 to 6 months, it reversed back. So then we further modified it, and now we are looking at removing the medial half of the lacrimal gland to see if we can get more effect on this. So that was what we did new. Now what we challenged was retrograde intubation. So if we read a lot of papers, they say that if you don't have a puncta, in cases of punctal agenesis, you open the sac, find the common canaliculus, and do a retrograde intubation. But does it really work? So we looked at all the cases of punctal agenesis that are presented to our clinic, and we did serial slicing from the punctal area, that is from this area to the medial canthal area. We took long strips of tissue, and we went up till 3 to 4 millimeter depth to find out if there is any residual canalicular tissue or punctal tissue that has developed in these cases. And what we found was it was entirely conjunctiva. There is no residual canaliculus or puncta. So doing a retrograde canalization doesn't work. The other study that we are now presently looking at is looking at the lacrimal sacs in cases of punctal agenesis. And what we find is there is no common canaliculus as well. So if there is no common canaliculus and there is no canalicular or punctal tissue, there is no question of retrograde intubation. So we should not practice that, and it should be seriously avoided. The other dogma that we challenged was lacrimal abscess. Now this is a very common presentation in all of our clinics. Now what do we mean by lacrimal, what do we do when a patient with lacrimal abscess presents to us? We take the patient to the OR, we do an incision drainage. When we do an incision drainage, we are actually cutting through the lacrimal sac, and we do not want to do that. Our primary aim of doing any incision and drainage or removal of the secretion is to reduce the symptomatology of the patient rather than a cure, because a cure is only a DCR surgery. So this is just an interim thing that we do before doing a DCR surgery. So do we really need to incise the sac? Also, when we incise the sac, there is always a chance of a fistula formation. Plus, it is a cumbersome procedure. You have to give local anesthesia. You have to take the patient into the OR. And all these things can be avoided if we just do a simple aspiration of the abscess. So in the OPD, take a 18 gauge needle, a 10 cc syringe, just at the most dependent area, insert the syringe and just aspirate the abscess. So what will happen when you aspirate the abscess? The secretions will reduce, the symptomatology will come down, and we can then take up the patient for DCR surgery as early as possible. Now the main thing that the reason why we used to do drainage rather than aspiration was the belief that there are septa in the abscess, which may be true in the peripheral parts of the body, but in the lacrimal sac that is not true. So what we did was we took ENFAS MRI images of the lacrimal abscess, and we did not see any septa in the lacrimal abscesses. Then during the surgery, we took a very small incision on the lacrimal abscess, put in the endoscope and looked at the internal cavity of the lacrimal abscess, and we did not find any septa within the abscess. So the thing that there are a septa which we need to break by doing an incision and drainage does not hold true where lacrimal abscess is concerned. So just a simple aspiration using a syringe works very well. So these are the similar images and the endoscopic images. Here what you see are mucosal undulations. These are not septa. So there's no connection between the walls. So using a 10 cc syringe and an 18 gauge needle, just aspirate it in the OPD and then schedule for a DCR surgery. And coming to the last part, that is challenging punctoplasty. Now routine punctoplasty is either a 1 snip punctoplasty or a 3 snip punctoplasty. Now most commonly it is done in cases of punctal stenosis and in certain cases of canaliculitis. Now when we compared the outcomes of a regular 3 snip punctoplasty with just dilatation of the puncta and putting in stent, the results were comparable. So do we really need to snip the puncta? No, we do not. And why we don't need to snip the puncta? Because recently, if we actually look at the lacrimal pump functioning, what we saw was the Horner-Duernes muscle. Actually, okay. So this is the upper vertical canaliculus and the horizontal canaliculus. This is the lower lid, this is the vertical canaliculus, and this is the horizontal canaliculus. And this is the muscle. And if you can see, it comes right up to the edge of the puncta and inserts at the rim. Over here also, if we see, the muscle actually inserts into the rim of the puncta. So when we are actually cutting the puncta during a snip punctoplasty, we are actually damaging this Horner-Duernes muscle, which is actually responsible for the lacrimal pump functioning. So we really do not need to do that. We can just go ahead and dilate the puncta and just put in a stent, cause the dilatation, and that itself will help us solve the problem. So these are just electron microscopic images of how the fascicles are inserted till the edge of the puncta. So there are 7 reasons why we should not do punctoplasty. It has a very intricate relationship. There is a very intricate relationship of punctum and canaliculus with the Horner-Duernes muscle. The punctal, now along with, if we saw these images behind, between this there are septae which are the fibrous tissue. So when we cut it, we actually cause more fibrosis. And that can again affect your lacrimal pump functioning. There is a scissoring muscle pattern at the punctum. There is loss of punctocanalicular junction when we cut the puncta during punctoplasty. Also, there are a lot of nerves which insert with the muscle to the punctal edge. And when we cut the puncta, we actually cause neural denervation. There is disruption of natural punctal changes with age that we saw in the first thing that I discussed today. And we have equally effective, minimally invasive modalities like just plain old dilatation, or as I showed over here, we can actually use a balloon which is 1.5 millimeter and cause a nice dilatation of the puncta. Thank you.
Thank you, Dr. Bothra, for your excellent presentation. Now I'll request Professor Dr. Anita Banerjee, Madam, to present the memento to Dr. Bothra.
Next.
Madam Dr. Banerjee, Professor Banerjee, to give the memento to Professor Muhammad Yasin. Yasin, sir.
We came to know today that you were battling.
Junior.
Now the floor is open for discussion. We invite questions to and from the panelists for each of the speakers.
Our first speaker was Dr. Debi Kundu with congenital nasolacrimal duct obstruction. Any question from the audience for Dr. Kundu as well as for the panelists?
My question for Dr. Devi, how often you would advise Kriegler's massage? My question.
Oh, okay.
Kriegler's massage.
Actually, ma'am, up to 4 months of age, I usually.
How frequently in a day?
I usually tell them to do 4 times, 10 times at a time and 4 times a day. After 6 months, it is 15 strokes at a time, 6 times a day.
Actually, the idea behind the massage is what?
To give the positive pressure so that there is rupture of the membrane.
So, in an empty sac, if you keep on massaging, nothing will happen.
Yeah.
The sac should be full whenever you do a massage, because you want to push the material towards nose, not outside. So it is not the number of times of massage, it is basically the technique and the pressure and in a full sac. This is a hydrostatic massage. It is, you keep on pressing over an empty balloon, nothing will come out. So please, whenever you teach parents, tell them that if you push the sac and everything comes out, and then you push, keep on massaging for 100 times, nothing is going to happen. So many cases in our clinic, in the first press, we cured. I think those who practice pediatric ophthalmology, in many cases, in the clinic, the child came, we pushed the sac, and the baby gone home, and next day they came, there's no such discharge and watering. So it happens with the thing. So please remember that. So it is not the number of times. Make it sure that the sac is full and the pressure is pushing the thing towards the nose.
Thank you, sir.
That is, of course, there. Yes, anytime, but whenever you push it, be sure, yes, there should be some content inside the sac.
Yes, and I usually tell them to close the puncta. Like I tell them to press the inferior orbital wall then go medially, with the little finger go medially, press the puncta and go beyond the bone to the soft part, and then rotate 3 to 4 times and then downwards.
That key thing is that don't push the thing towards the eye.
Yeah.
Try to push
towards
it
the
towards the
puncta.
nose.
Yes.
At times there is just watering and you don't have any content. If you press, then nothing will come out.
Sir, the massage will cure only the membranous obstruction.
Yes.
Can only hit the agenesis of the, or if there is a part of this fibrosis, it is not going to cure by your massage. So massage cures only the membranous obstruction. So if it is cured within a month, it is cured. Otherwise, you keep on massaging for years, it is not cured. So I met one surgeon in your AAO, in a pediatric ophthalmology, the subspecialty day. He does probing at 1 month of age in his clinic only. Wrap the child on a towel when the child cannot resist, and he pushes a probe in his clinic without anesthesia. And he says this is mostly it cures, mostly, because keep on massaging by the parents and waiting till 1 year or 1.5 years of age never causes this thing, never cures the problem. So this is his, I have no experience. If anybody has done, the dacrylologist are here, she'll be able to tell you if you have done anything like that, that the small kid of 1 month or 2 months, without anesthesia, you put a probe and it gets cured.
So I would not practice doing anything without anesthesia, just for the reason it's very traumatic for the child. And I believe, I don't know how many people will, I think most of the anesthetists also believe that there is a memory that the child retains. Whether you believe it or not, I wouldn't practice something that is without anesthesia in a child and without an endoscopic guidance, purely for the reason that there are still chances that with the negative pressure in the nose, just when the child is crying, when the child is sucking, sometimes the membranous obstruction can give way and the child may become better even without any intervention. So I would wait. If, of course, the discharge is too much, the sac is very dilated, go ahead and do an early probing. That is, you can do that, but I'll again do it under general anesthesia with endoscopic guidance.
Okay.
Yeah.
Even if you don't have an endoscope, chances of a false passage is much high in a crying child. When you do it in an OPD, chances of false passage are quite high. So it's not at all
What
advisable
is
to do it
you
in-
would advise to go for lacrimal sac massage?
Yes, I would explain, like Sir said, the massage has to be correct technique. You have to press on the sac. Doesn't matter how many times you press. If the technique is incorrect, then it won't work. Yeah.
For 6 to 8 months you will advise.
Normally, if it has to improve, like Sir said, it will improve in 2 to 3 months. If it doesn't have to improve, it will not improve. But we are giving the child an option because we want the negative pressure to be created. What happens is most of the mothers are really scared of actually putting pressure in that area. So they do not end up doing the correct technique. So just wait. If the negative pressure in the nose itself takes care of it, it will improve. If not, let's go ahead and do probing. Even doing an early probing has no harmful effect.
Now, Dr. Navjyoti Goswami, any question from the audience for him or for the panelists? And his topic was an external DCR.
See, Dr. Goswami, in external DCR, you are cutting the medial peripheral ligament and not suturing it. Now, the early rehabilitation that was being talked about by the endoscopic surgeon, is it the reason for which the rehabilitation is little later? What do you think about it?
Actually, sir, during closure, when I put sutures in the muscle, I give a suture at the level of the medial peripheral ligament, and if I can identify the medial peripheral ligament, I put a suture at the medial peripheral ligament so that there is no postoperative taylorism or hypertaylorism.
Why is, as is being told, I do not know personally, because whatever DCR I have doing or have done, there is no delay in the rehabilitation. But the ENT surgeon feels that there is late rehabilitation. Then what is the cause of that?
Dr. Goswami,
Yes, ma'am.
I have one question. In our ophthalmology, in our ophthalmology, we do the this year where we do the anastomosis between the sac wall and the nasal mucosa.
Yes,
but in endonasal, Dr. Sood has told, they just make a nasal ostium, no anastomosis.
Yes,
Do you think there will be any problem afterwards?
I think we have the advantage of suturing the mucosal flaps. We have that advantage. Even the endonasal this year is also, they can suture the flaps also, I think.
Dr. Bothra, do you have any study of closure of the DCR ostium in a long term?
Okay, so what we've observed so far is once the ostium is formed and the mucosal healing has completed, that happens at about 1 month approximately post-surgery. Beyond that, the shrinkage is very, very minimal. So whatever you see at 1 month, beyond that, if you even follow it up for a year, the shrinkage is not going to happen. Unless there are some other factors like say injury or polyps or something else developing and mechanically blocking the ostium.
The bony ostium remains same size?
It remains same size because the mucosa over it has healed already. So whatever the mucosal healing has happened, it's not going to change anymore. Very, very minimal shrinkage has been noted.
USG study
Yes.
of the DCR ostium. They showed that there is a gradual narrowing of the bony ostium also.
So endoscopically when we see them, so I have not done the...
It was very difficult.
Yeah.
I myself and one of my retina surgeon tried to measure the DCR ostium size in USG. So it is very, very difficult. But if a person can do a good USG, he can measure. I don't know, you can tell us in the next conference that whether it is possible to measure the DCR ostium by any imaging system in a serial wise.
So
Like
we've
you have
looked
done
at
so much of
CT
studies.
DCGs. So we've been looking so far with, at all the revision cases.
The
It is
osteophyte
very-
formation and there's a closure of the bony ostium.
Yeah, so it's very difficult to measure any bony landmark on any of the imaging studies that we have.
That external DCR is creating a fistula, basically. And in an endonasal DCR, it is just removing bone and the sac wall. So there is no fistula formation. So I don't know, there's a comparative study, the results are almost similar now, what Dr. Sujasnatha said, and other studies, that both the procedures are having almost equal procedure if it is done by an experienced person.
Yes, true.
Bigger and it remains patent in
So-
endonasal also, in external also.
So the
You have any point
ostium,
to tell?
so the ostium, at least what I would like to say is in external DCR, we create a very big ostium. In endonasal DCR, the advantage that we have is we are removing only the lacrimal sac fossa. So we are removing a part of frontal process of maxilla and we are removing the lacrimal bone. We are not disturbing the surrounding anatomy, whereas in external DCR, we disturb the surrounding anatomy as well. However, the results are going to be same and that is good. The other question which sir was saying that endoscopic DCR has comparatively lesser watering post-op than external, it is mostly symptomatic because in external there is a skin incision, there are sutures that causes pain, that causes reflex watering. So the patient feels that there is watering, but the effectivity of the surgery as such is the same, whether you do endo or external. Just that external reflex watering is there in the initial period, and that is why it is stated that initially there is a lot of epiphora.
Just a few, I think Nandini has already pointed out, but to what sir was asking about the difference on the, the watering after surgery and what exactly, apart from the fact that you anyway in external, your incision is anterior, so there is bound to be manipulation in the muscle at the site of the surgery. So the lacrimal pump, it's very unlikely that will remain normal. It will take some time to come back. Whenever you do surgery in a particular that affects the muscle, we see that in the orbit, in other parts of the body also, it takes a little time for the muscle to come back, and the lacrimal pump function is affected. On the size of the ostium, the biggest challenge is always, whatever technique you use to measure, there will be some degree of subjectivity, and to standardize the technique is very, very challenging.
Sir, I think you were talking about, sir, bone regrowth, sir, right, sir? Regrowth of bone, no? Yeah. So I have done a few cases of revision DCR, so where I did saw that bone has regrown. Yeah, and that bony ostium has closed, and I even tried sending those portions to the histopathologist at our Shankaradala, and he got irritated that why are you sending bones to me? So I just wanted to see that whether this bone has any change other than the normal bone. But yeah, I have seen that bone has regrown in that area. It's thin kind of bone in that bony ostium.
Nandini, I have one question.
Yes, ma'am.
You are dacrylogist. The bony ostium is much bigger than the punctal orifice. Have you studied anything about the dry eye? The flow will be much more after this year.
No, the drainage is going to be that much only. Only thing is so if we look at the law of physics, we are just reducing the distance that it has to travel, and we are causing a bigger opening, so gravity is acting. So whatever pooling was happening, that will not happen. But the amount of water that is produced, only that much will go in. Whatever is spread on the ocular surface will remain on the ocular surface.
Much water is coming out.
No, it won't come out because it has to reach the puncta to come out. It will not reach the puncta to come out. Whatever is on the surface will remain on the surface.
Excuse me, can I take this? Yeah. Actually, in fluid dynamics, if you have fluid passing through a tube, the narrowest part of the tube will determine the amount of fluid flow through that. So the narrowest part of the tube in this case is the punctum. So that is the one which is going to determine the amount of tear which is going to flow down to this DCR.
And one point I like to add, that in our mastoid surgery, when we do cortical mastoidectomy, after surgery, say for example 6 months or 1 year, if we do repeat CT scan or repeat X-ray, there is obviously bone regrowth is there. So that cavity gets a little bit smaller in size. In our case also, whatever the ostium, that bone we are removing, that will definitely get reduced in size. So we remove a little bit more bone. And the most important thing in our mucosal flap surgery, that the nasal mucosal flap we have elevated. We made one cut inside in that rectangular flap, in again one rectangular fashion, and put this flap over the exposed bone, so that there should not be any granulation or any raw bony surface that is exposed. And this flap gets fixed over the lacrimal wall, and so that healing is very good. And surprisingly, our failure rate is very less, although we don't have much, bigger scale surgeries. So we are quite happy.
In fact, that is precisely the reason why it's recommended that you make a large bony window and a large mucosal opening. Because both the bony window as well as the mucosal opening, they are going to shrink.
Personally, I believe the majority in cases, this endonasal DCR I'm talking about, in majority cases, the failure chance is because of surgeon, sorry to say, in my case, from ENT part, that inadequate bone removal, just seeing the sac and puncturing it and then water is coming out and surgery is over. I think this is the main cause of failure.
Dr. Surya, is it ideal to use mitomycin C in all your DCR cases?
I think based on our recent data that I showed, in primary nasolacrimal duct obstruction, you may not use. But if you are doing a revision, if for, let's say anything, if you are doing a traumatic, NLD obstruction, these are conditions which you could possibly still use, because our data only talk, you cannot extrapolate that data to other cases. But in primary, at least application, so there is even the technique. What was the lacuna in the literature? People even in the Cochrane's thing, it is people have used from 0.02 to all the way to 1. That means the concentration. Then they have used a duration which is from 2 minutes to 10 minutes. And everything has been clubbed together as one group of usage of MMC as plus. And that's showing it is working. One of the reasons why we did this study is to take care of this heterogeneity. And, but then, we are only talking about one particular concentration, duration of 3 minutes, and application at the site.
Now, there are 3 scenarios. One is endonasal DCR, where there is no flap that we are suturing. Right. Second is while doing external DCRs, one group of surgeons do a single flap technique. They suture the superior one and cut off the inferior. And the other group suture the both. Now, regarding the bony growth or the growth of the granulation tissue leading to the failure of the DCRs, now which one is the most, the failure rate is highest, and where, how?
Theoretically, if you suture both flaps, that is the ideal. It makes a tube. It covers the most part of the bones with the mucosa. So even if the bone grows, there is a mucosal lining over that, theoretically. But the result-wise, single flap or double flap, almost the same. And with good visibility and experienced ENT surgeons, it has the results of endonasal DCR is also the same.
So for external DCRs, while we are doing external DCRs, many of the time it happens that we have damaged the lacrimal mucosa, we have damaged the sac mucosa, and we have the option of putting a tube there.
Yes, so you can put a monocanaliculaar stenting also.
But from the ENT surgeon's point of view, they are not putting any tube.
No, because you are externally, you are dissecting too much of tissue. If you do not put some things in external DCR especially, you may land up in fibrosis. And if you lose both the flaps, either you have removed the lacrimal sac or the nasal sac, and you have not put anything, so there will be a lot of adhesion there. That's why it is ideal to put a tube in external DCR, not for endonasal DCR, because externally not much of anything, no muscle injury, nothing. Only the two mucosal surface are operated. So this is, I think this is my opinion. What?
Yeah. Shahid?
So I would like to add that if you want to insert a tube, a silicone tube, you have of inserting a silicone tube even while doing an endonasal DCR.
Always there.
Yes. So if the sac is very fibrous, especially in revision cases, at least I routinely prefer to put a silicone tube.
In DCR cases, I routinely put a tube. All my failed DCR cases.
So to actually understand this more simply, the moment you are, like in external, the moment you are doing your anastomosis of anterior, posterior, both, whichever, you are actually bringing into contact mucosa to mucosa, which works elsewhere in many other, let's say, even GI surgeries, because you're actually bringing in two mucosa, which has a contact inhibition. It doesn't allow there's a primary intention healing. That's the biggest advantage. The moment in endonasal, we struggle to do that, to achieve that. You use fibrin glue, suturing is very difficult. It's not impossible, but it is difficult. So because to take care of that disadvantage, actually most surgeons prefer using bicanalicular intubation or whatever sort of intubation to augment success in endonasal. But if you can achieve that by doing endonasal surgery without using a tube and achieve the same objective of bringing in primary intention healing, you may not use a tube.
So just another perspective, using a tube versus not using a tube. Tube gives us mental satisfaction because I do endonasal DCRs on a regular basis. I have mucosa to mucosa anastomosis anteriorly as well as posteriorly, fix it with fibrin glue. Whatever remnant bone is there, sometimes if we have additional mucosa, we can actually go ahead and fix it if there is any exposed bone. Just use glue and just leave it there and it will fix. But what I'm coming to is the stents. So if we have seen cases of rhinosporidiosis, say, we remove the entire sac and we leave only the area of the common canaliculus intact and a very small rim of mucosa around it. Even when we leave it at that, it heals very nicely. So the important takeaway over here is not to damage the mucosa of the common canaliculus. If that is intact, then your surgery will survive with or without a tube. if that has damaged, then even with a tube, the chances of failure is very, very high. So just whenever you're incising, incise the sac away from the common canaliculus initially. That is, you direct your probe inferiorly so that you're not incising at the common canalicular junction. Incise it at a place away from the common canaliculus. Once you're sure it is full thickness, use a scissor to cut it so that you do not damage the common canaliculus. And once you save that, whether or not you use a stent will not have that much bearing compared to other cases. No. Whether stent is used, I give topical steroids for 2 weeks and nasal steroid spray and nasal decongestant spray. That's it. No antibiotics, nothing is actually required.
Regarding what? Nasal spray. We give nasal washes, actually, nasal douches from the first post-op day. Actually, I give it from the first post-op day, but actually the theoretical recommendation is that you can do it after 3 to 4 hours, nasal douches.
And what drops do you use?
Steroid nasal sprays. No drops, steroid nasal spray. Fluticasone furoate or mometasone furoate, we'll use that as nasal spray. Nasal decongestants, drops, I mean oxymetazoline, xylometazoline, they have the associated problem of rhinitis medicamentosa. You should not, they should not be applied more than twice a day, and they should not be applied for more than 5 to 7 days at a stretch. If you do it for more than this, then there is every chance of developing a rebound congestion and even habit formation. The patient gets addicted to the nasal drops, and after that the patient does not get any relief from nasal obstruction unless and until he uses a nasal drop.
Thank you for a wonderful dacrylology program. What we learned here is that there are many ways to skin a cat. You have ENT surgeons operating, you have ophthalmic surgeons operating, both from outside as well as from inside. And the final goal is the same, to give the best possible result to your patients. And there are so many ways of doing it, which is what we learned in this particular session. We'll wind this up, but before we end, I would request Professor Muhammad Yasin to give mementos to each member of the expert panel. Professor Rakhi Banerjee, ma'am. Thank you, ma'am, for joining us. Professor Indranil Pal. Professor Pal is the head of Department of ENT at JN Medical College in Kalyani. Thank you, Indranil. Dr. Madhushmita Behera, ma'am. Dr. Behera is an oculoplastic surgeon. She is in Narayana Netralaya in Salt Lake. It's still Rotary, okay. It is okay. Rotary Techno India. Okay. Okay. It has changed names so many times that I can't remember. And Dr. Saurabh Shanal. Dr. Shanal has served in the armed forces. He was one of the pioneers in modern oculoplasty in West Bengal, and he has been my mentor in the past. Thank you, Dr. Saurabh Shanal, for joining us. That is absolutely true.
First this year done by Anirban under my guidance when he joined Disha. I was there in Disha. So today Anirban is a fantastic oculoplasty surgeon and ocular oncology. Especially I introduced him with Santosh in cutting edge in LV Prasad. Thank you Anirban for calling us.
Welcome, sir. So we'll move on to the next session, which is an oncology, very important. We are not doing anything on tumors today. I mean, it's against my nature, but that is how it is, only oculoplasty. So the next session is on orbit. And Shreyoshi is one of the moderators, she'll take over.
Okay, so this session is the last session of the day before lunch. And I'm going to invite our chairperson, Professor Oshim De sir. He is a senior consultant in ophthalmology and oculoplasty, past president of OSWB. Sir has been associated with multiple medical colleges, starting from NRS, Archik or SSKM, even Shushruth. So for the panelists, we have a committee of panelists from the different disciplines of medicine. So I would request Professor Chandana Chakraborty ma'am to please come and sit in the panel. Ma'am is a professor in RIO. Then I would request Dr. Sandeep Pachisia sir, consultant maxillofacial surgeon. Sir is attached to CMRI Nightingale Hospital. Next, I will request Dr. Swarup Pathak sir to please come and sit in as a panelist. He is an ophthalmologist. He was a former faculty of Shushruth. So next, I will request Dr. Siddhartha Chakraborty sir. He is a consultant maxillofacial surgeon, oral oncology and microvascular surgeon. He is associated with CMRI, Shushruth, Chanak, Manipal Hospital. And I will request Dr. Abro Chandra Chaudhary sir, consultant rheumatologist. Sir is associated with CMRI Hospital. And I will request Dr. Suman Malik sir to come and sit in the panel. Sir is a radiation oncologist and director of Narayan Super Specialty Hospital.
There is a saying that jab Bhagwan deta to chappad phad ke deta hai. We actually have another maxillofacial surgeon among us, Dr. Gautam Dendukurti, who's from Hyderabad. Dr. Gautam, you might as well come and join us in the front. Bhai nahi.
So we will start with our first. So we will start with our first talk on orbital imaging by Dr. Sumita Kundu ma'am. Ma'am is a consultant radiologist at Eco X-ray and Imaging Institute, Kolkata. I mean, we all send our patients to ma'am. So there is a slight change in the schedule. We will take our next talk. Instead of orbital infections, we will take sight-threatening thyroid eye disease by Dr. Rath. Yeah. Yeah. And which will be followed by the infection talk by Dr. Prabrisha Banerjee. Over to you, ma'am.
Thank you. Good afternoon, everyone. It's a pleasure to be here, and I thank the organizers, particularly Dr. Bhaduri, for this kind invitation to speak on CT and MRI in evaluation of orbital diseases. Both CT and MRI are used in routine practice now for various parts of the body. Of course, orbit comes into it very regularly. CT, as we know, is very helpful in evaluation of the bony orbit, for foreign body evaluation, and also for seeing infiltration by tumors, etc. We acquired the CT images in the axial plane, and then we proceed to reconstruction in coronal or sagittal planes as required. On the other hand, MRI can be acquired in the various planes, whatever planes we want, so that we can get the axis of the optic nerves very well. This is a stir image showing the entire length of the canalicular and intraorbital optic nerves. We can see a little bit of bulge of the optic nerve heads because this patient was a patient of IIH. These are the coronal images of a patient showing the orbital structures, the extraocular muscles, optic nerves, periorbital regions, even the brain and the paranasal sinuses. This is a very beautiful depiction of the globe as we can see it in the oblique sagittal plane, where you can see whether there is any tumor infiltration, whether there is any involvement of optic nerves, what the orbital apex looks like. So these are the basic images which are taken in every orbital scan. At this point, I would like to say that very often people do very routine scans for the orbit. That's not correct. What we need to do is take small field of view images with very high resolution in the images so that we can show the intrinsic anatomy of the orbits very well. Unless we demonstrate the orbital anatomy, we cannot diagnose the pathology. Now, various pathologies which are needed for evaluation, we all know, are inflammatory infective conditions, neoplasms, vascular lesions, congenital anomalies, diseases in the pediatric age, intracranial lesions extending to orbits or involving the visual pathway, and trauma. Let us begin with few slides of trauma. CT is, of course, the first investigation which will help in evaluation of orbital fractures, and also in evaluation of foreign bodies, radio-opaque foreign bodies in the orbits. But when it comes to radiolucent foreign bodies, like this was a little girl, 16 or 18 months of age, she ran into a thicket of a bamboo and 2 of the bamboo sticks penetrated into her orbit. See all the inflammatory changes and the beautiful demonstration of the intra-orbital radiolucent foreign bodies. This would not have been shown as well in CT. On the other hand, when you have a radio-opaque foreign body like this metallic implant here, metallic foreign body over here, this will be totally lost in the MRI. For one, we don't usually put in patients with foreign bodies which are metallic into the MRI gantry. That is because there is a chance, the possibility that this may be dislodged and affect the other soft tissue structures of the orbit. But this patient actually had come for evaluation of visual impairment. They didn't give any history of an intraocular foreign body. So when we took the first images, we saw that there was so much of artifact obscuring the globe. So we said definitely has a foreign body which is magnetic susceptible. Put the patient into the CT and we found this. Here we can show the patient's optic nerves very well, but we cannot analyze the patient's globe as well as in the CT. Another condition which CT has a superior evaluation than MRI is optic disc drusen. These tiny calcifications are usually not picked up on the MRI, and CT is the investigation which is necessary. But then there are other conditions like PHPV, showing this microphthalmias, this typical wine glass retrolateral structures. These are all very well depicted on MRI. CT will not be able to show, and see how beautifully the optic nerves are demonstrated. Now, orbital infections, both CT and MRI are good. CT is very good. See, this is a subperiosteal abscess. You can see how well the bony erosion is demonstrated. So if there is any associated bone involvement with the abscess, CT is very good at showing that. But then sometimes when the changes are more subtle, as this patient who had an abscess along the lateral rectus muscle and in the subperiosteal regions posteriorly, these subtle structures are better seen on contrast-enhanced MRI images. Now, orbital cysticercosis, of course, both CT and MRI can show. If we can show this, can you see this cystic structure over here with a small mural nodule? If we get a picture like this, we know that this is a cysticercus. Here again, the CT is showing a calcified nodule within a cystic structure and extensive soft tissue inflammatory change around it. So these are very typical of cysticerci. But the thing is, we always won't get this typical structure. Sometimes we won't be able to pick up the nodule. We will only be able to see a thick rim enhancing lesion if we do a contrast study. In those cases, it becomes a little difficult for us. Now, as far as optic nerves are concerned, MR is the modality of choice. This is a patient with bilateral acute optic neuritis. We can see that there are signal changes in the stir images in both the optic nerves, and there is ill-defined contrast enhancement. Contrast enhanced studies are an absolute must if we think of acute optic neuritis. This is another patient, a 20-year-old female with sudden right-sided visual loss. See, there is very subtle change in the right optic nerve here compared to the normal appearing left side. These stir coronal images also show very subtle signal abnormality here. But once you give contrast, we can see the entire demyelinated area which is picking up the contrast. So it is easier to see it on this and also to assess the exact extent of the involvement of the optic nerve. Now, another condition where a contrast-enhanced MR will be the superior modality is in case of something like a Tolosa-Hunt syndrome, a 47-year male coming with right-sided ptosis. There is subtle increase in soft tissue thickening in the right cavernous sinus. After giving contrast, this is appreciated much better with the pseudotumor involving the right cavernous sinus. This patient was followed up and subsequently his soft tissue lesion disappeared. Another condition where MR is superior to CT, of course in CT we can see the thickened extraocular muscles, we can see any optic nerve compression, but what we cannot see is the signal changes which occur in the acute thyroid orbiopathy with so much of thickening but also associated inflammatory change. Similarly, when it becomes a chronic thyroid orbiopathy, there will be fatty change in these muscles. And also to assess the signal change in the compressed optic nerves, there MR is the modality of choice. In CCF also, both CT and MR are good. In fact, CT will require contrast always. MR can do it even with the plain scans. We can see the dilatation of the superior ophthalmic vein in this patient who had a left-sided CCF. And we can also give contrast and see the extent of the inflammatory change, which can also, of course, be seen on the stir images. So in MR, we don't always require contrast for CCF, but in CT, we do. As far as orbital tumors are concerned, both intrinsic tumors as well as tumors outside the orbit, infiltrating the orbit, can also be demonstrated both on CT and MRI. Of course, the retinoblastomas, the calcification is better seen on CT scans, but since most of these patients are young individuals, we would prefer them not to undergo something which causes radiation. So MR is a very good modality. It will show without radiation the extent of the tumor. Calcification, which is easily seen on CT, can also be picked up on MR. These are gradient echo images showing calcifications which are dark in signal intensity on all sequences. Diffusion weighted images also help us in finding out how much is the tumor if there is any associated retinal hemorrhage, subretinal hemorrhage or retinal detachment, because the tumor will show more diffusion restriction as compared to the hemorrhage. To see the extraocular extension of the tumors, MR is the most superior modality. But to see subtle erosions of the bone, like in this adenoid cystic carcinoma in this patient who is having erosion of the region of the lacrimal gland in the bony wall of the orbit, there CT will show a better depiction of the lesion as compared to MR, but the lesion itself will be seen very well on MRI also. Again, here a metastatic lesion extending both intracranially and into the orbit, causing bony erosion, very well demonstrated on this CT image. There are certain conditions where MR can even give a histopathological kind of diagnosis. This is a very well-defined intraorbital, intracorneal and partly extracorneal tumor which has very well-defined margins and the enhancement pattern. In orbital tumors, it is a must that we give contrast. The enhancement pattern in cavernous hemangiomas of the orbit is from center to periphery. See, as we go, we usually do dynamic scans here. We take initial plane study, then contrast and follow it up, and we can see that from center to the periphery, there is an enhancement. Whereas if it was a schwannoma, it would not have shown this kind of a pattern. It would have shown more of a peripheral enhancement or a more diffuse enhancement right from the beginning.
Ma'am, 1 minute left.
Yes.
1 minute more.
Okay, I'll finish. I'll just finish. This is a patient with bilateral optic nerve gliomas. You can see the thickened optic nerves, very well demonstrated. Even the intracranial part is thickened over here. Other intracranial lesions which can cause compression of the optic pathway and cause visual compression, like this planum sphenoidal meningioma. Here also, contrast-enhanced studies are important. Some other conditions like macroadenomas, craniopharyngiomas, cranial nerve palsies due to cavernous sinus schwannomas, or thrombosed, partially thrombosed intracranial aneurysms from the internal carotid artery. These are all some of the conditions which we can see. So what is the difference between CT and MR? CT has a shorter scan time, MR is longer. CT is comparatively cheaper and it is more widely available, but of course now MR is also available in many places. Better depiction of calcifications, etc. And patients with implants can also be imaged, but you do use a lot of ionizing radiation. MR does not use ionizing radiation, has high resolution of anatomy, and though it has a comparatively longer scan time, it gives much more information. And now, because many patients have MR compatible pacemakers and implants, this is also not that much of a problem except in certain conditions. So with that, I come to the end of my presentation, and I would like to say that high-resolution MRI of brain and orbis is extremely useful in evaluation of orbital and intracranial lesions causing visual symptoms, and CT is, of course, necessary for evaluation of the bony orbit, mass lesions, and calcifications. I thank you for your kind attention.
Thank you, ma'am. That was a very interesting talk. So I would request Ashim Kumar sir, Ashim De sir, to please felicitate Shumita Kundu ma'am with the memento. So by the time I will be calling our next speaker, Dr. Suryasnatha Rath. Sir will be talking about sight-threatening thyroid eye disease, risk factor and management. So, sir is head of ophthalmic and plastic surgery and facial aesthetics, ocular oncology in LV Prasad Eye Institute, Bhubaneswar campus. He is a network director operations and in charge of elderly eye care and home care service. So he served as the former director of LVPI Bhubaneswar. He has done fellowships in comprehensive ophthalmology, ophthalmic plastic surgery and ocular oncology in the LVPI Hyderabad, Oculoplasty fellowship in University of Columbia, Canada. Sir is the editor of Surgery in Thyroid Eye Disease by Springer. He has authored 67 indexed publications in peer-reviewed journals and 5 book chapters till date. He has received the BIRSCB grant for developing device and facilitating minimally invasive surgery in chronic dacrocystitis. So over to you, sir.
Thank you so much. Again, best wishes on 25 years for Sushrut, and thank you for the invitation. I'll try to, this is the financial interest disclosure. I wanted to take this up as talking about something that we've, over a period of about a decade, looked at and tried to understand, and looked at a real-world scenario which is more relevant for us, and I'll touch upon that. And they look at what are the different components of dysthyroid optic neuropathy, what are the risk factors. Again, like I said, India is a region of high prevalence of diabetes. How does it actually change our set of patients and management strategies, and try to summarize. So that's what I'm looking at. This particular patient is a young lady, is sort of a trigger patient for me for my own interest in thyroid eye disease. She came in when she was only 18 years of age and very severe exposure, as you can see, and this was of 2 years of duration. She was barely, perception of light in both eyes. The CT scan is actually very typical of what we describe as the optic nerve stretch type of optic neuropathy. And over a span of, several years, we obviously managed medically, did decompressions, eyelid surgeries,
The right eye underwent a penetrating keratoplasty. But what was very, very reassuring was that he actually managed to have 20/50 vision with the kind of presentation that we're looking at. This was an eye-opener. And quite something that stimulated my interest in thyroid eye disease. Now, the visual, what are the severity types actually? And so one of the concepts is about severity versus activity in thyroid eye disease. And in severity actually, you put it as mild, to moderate to severe and sight-threatening. So I'm only dealing with the last part, but just to see what exactly does it mean. Mild thyroid eye disease is when you have literally, in simple terms, no impact on daily life. So the retraction, the proptosis, and there is no double vision, essentially means that conservatively you can manage them. Now, that's mild. Moderate to severe is where there is a significant impact, and all those soft tissue parameters we talk about is much more severe. The proptosis is more severe, more than 3 millimeter, whatever is the normal for the age and ethnicity. That's there. You have a retraction which is quite severe. But the key thing here is most of these patients in the active stage would need disease-modifying agents. You can no longer just wait and watch. And in the inactive stage, if they come out at the burnt-out stage, you're probably looking at surgery. This is our topic of discussion today, and is sight-threatening, as is affects visual function, is sort of an emergency, and you need to act quickly, and there are multiple challenges to dealing with this. Dysthyroid optic neuropathy, or DON, which has two components. It can be compressive optic neuropathy, or it can be the stretch type of optic neuropathy, which I alluded to in that CT scan earlier. Unilateral, bilateral, both possibilities. You also have corneal breakdown. So very severe exposure leading to corneal breakdown and microbial keratitis with superadded. Now with the kind of microbial infections that we deal with, it's not unusual to think that apart from the exposure, there are other elements, because the tear dynamics are different, the osmolarity is different. So there are multiple factors leading to that, but then you can have microbial keratitis. And even recalcitrant glaucoma is actually now being stated as one of the things where multiple drugs, you are unable to manage glaucoma. That's also a situation where there is a possibility side threat. And these are the ones where you obviously have much more, you have to speed up treatment protocols and all. Now, very oft cited slide in TEDs, but when a lot of people say that this was a very small number of patients on which Rundle described this curve, but it's very relevant. And why is it relevant is that he described that there is always this early stage of spanning between 6 to 1.5, maybe more, depending on what other comorbidities the patient has. But that's the stage when things are changing. And then the patient achieves a particular, the high point when changes have happened, and then it plateaus down. When he plateaus down, there are sequelae that are left. But what is key to understand is at that stage, there is a possibility that if you were to give disease-modifying agents in that early active stage, early progressive stage, then there is a possibility that you may not allow the patient to go to that level where your retraction correction, your proptosis correction, or even the strabismus correction may be necessary, may be fewer than you would expect if you had left it alone, or could be, you could completely avoid those. So that's the concept which is, and this is very, very valid across the world. And that's why it's probably the most oft-cited slide. Several classifications. And here we move on to something which is we need to also understand activity versus severity. So I graded based on the severity on mild, moderate to severe, and sight-threatening. The VISA classification allows you to put them into the severity grade and activity. Vision is for, that means the V stands for vision, I for inflammation, strabismus is S, and A is appearance. And it allows you to classify all of these parameters. The interesting thing, it also gives you subjective inputs in addition to the objective inputs, and you can always ask for ancillary tests like visual fields and others to put the patient into a summary scale, just like you do in visual fields. The key thing, however, is that how do you say that it is activity? And a very simple terms, I think active is when things are changing. There is flux. That's what is activity. So it could be a change in the vision from no optic neuropathy to optic neuropathy. It could be a change in the inflammatory score from going from 2 to 4 or 6. It could be a change in the strabismus, in the deviation that you're measuring. It could also be in the appearance. Any of them, it would be, over a short period of time, would be active. Now, this particular patient presented with actually a vision which had dropped in the right eye over the last 1 month to counting fingers. If you look at the MRI scans, and what is very interesting is that, sorry about that, is, what you actually see in the scan is that the right in the T2 weighted image that is on the right, it actually shows there is a sort of a tenting of the posterior pole. You also look at the bottom left picture, and that tends to show there is a significant hyperintensity and what we call as the posterior spindle of the muscle, which could be, and you look at that scan, you suspect that on a coronal, is it causing apical crowding? And on the right, you actually have a coronal image, which actually shows that there is no effacement of the fat. So it's not really that much of crowding that you would expect. So possibly it is the stretch component which is causing the optic neuropathy. These are the patients who benefit from surgery, because here, you know, the stretch component is not going to be benefited that much from either radiation or from steroids. I'm not sure the slides are not going forward. Okay. In 2016, we did a survey to look at what are the practice patterns. And one of the amongst questions, and this was done in the Oculoplastic Association of India members, OPI members, 400 members, 41% response rate. It was very expected results, and the visual loss was dysthyroid optic neuropathy was more than 50%, and exposure keratopathy was the next one. Now, I'll try to use cases to try to ascertain what are the usual treatment modalities that are used. This particular patient was a smoker. He was about 40 years of age, gross decrease in vision both sides, high intraocular pressures, and esotropia, as you can see. Look at the scans. This is frank. Now, this is what we call as effacement of the fat. And there are scores. You can actually measure the thickness, both horizontally, and how much of the muscle is compared to the width of the orbit. You can do it vertically, and there are scores like Nugent's score and all. But essentially what it shows is there's a significant amount of crowding, and this tells you with what you have is that there is a dysthyroid optic neuropathy. Other findings, now this one is something which is now, it actually shows that apical crowding is not only one. You can have distended optic nerve sheath. You can also have more occasionally fat displaced in the cranium, not so commonly seen, and an optic nerve stretch that we talked about. These are the different CT findings that are there. Keeping this in mind, what we looked at in 2021 was, what are the risk factors? In our cohort of patients, what does the literature already tell you, and what is different in ours? What came out was, this was a cohort of 201 patients. And the key thing was something that we knew and something which became more important after we did this. The smoking part was a lot talked about in the external world, particularly in the West. And about 201 patients, what it showed is the arrows that actually the risk of dysthyroid optic neuropathy doubled in the first year itself if the patient was a smoker or if the patient was diabetic. These two. It's like a binary scale, yes, no. But the key thing other was, in addition to the fact the diabetics also had a higher risk of bilateral sight-threatening disease, they also had recurrent sight-threatening disease, which was quite worrying. Another thing that we did a visual acuity outcome, linear, it was like a predictive model on the statistics, and actually showed the diabetics present with better vision, but despite therapy, the vision actually goes down over time, and that was a cause of concern. So we needed to do something about this. Now, interesting part is, around the same time in 2020 to 2021, there were 3 different series which came out of India, which talked about the risk of diabetes in thyroid eye disease, and that it really increases the risk. It's a major risk factor to think about in India for sight-threatening thyroid eye disease. And the last paper that I'm showing here actually talked about the particular importance of type 2 diabetes in this. So on the risk factors that we already knew, the diabetes thing was becoming more of a thing that we had to think about, and quite expected, because the prevalence of large studies seems to suggest that in adults there's 7.3 prevalence of obvious diabetes in patients who are adults in India, and 11% is the prevalence of pre-diabetics. So you're looking at, in adults, almost 20%. So almost 1 out of 5 adult in India is possibly likely to be diabetic, and that was happening in the clinic. Most of the patients that were coming in were diabetic and had thyroid eye disease, and were making treatment very, very difficult based on protocols. We also had an anecdotal experience that in this kind of a patient, when we did an early surgery, it stabilized the patient, and then we could put the patient on immune modulation. And that struck us, though the numbers were small to really derive much of it, we thought that there was something that we could look at as an alternative strategy. If you look at what is usual strategy, well, obviously the first line of therapy for dysthyroid optic neuropathy in thyroid eye disease remains corticosteroid, IV methylprednisolone, and the pictures actually show after steroid the change in the disc. But the visual function wise, you see even 1 day after the visual field that is done, the pattern deviation plot, which was not there because of the significant dip in the decibel levels on the visual field above, actually start appearing just after 1 dose. So there is a significant, it remains the first line of therapy is IV methylprednisolone. You also have an alternative orbital radiation to be used, and this has been used as a modality. Radiation does in the long term what steroid does in the short term. But there are some contraindications to that. Unfortunately, diabetes is one of them. This particular patient was not diabetic. He was a smoker. We used corticosteroid plus radiotherapy protocol and also followed up with cyclosporin. He stabilized and he actually developed radiation retinopathy, needed intravitreal VEGF injections. So something that we learned that, of course, the key thing was diabetes and less than 35 years were relative contraindications. So that was again becoming, the patients that we're dealing with, unfortunately, one of the major modalities which was helping in managing disease, we could not use, which was radiation. He stabilized over time. This is another patient which was managed on the long sort of online consultations in the beginning, and he had a decrease in vision in the right eye. He had a clear-cut picture of online consultations there which showed that the right eye was not improving beyond 618. And multiple, diabetes, hypothyroidism, hypertension, chronic smoker, though he had quit. By the time we were doing the consultations, he already had received almost 8 grams of methylprednisolone and rituximab 2 doses. He still had the vision of 618. Now this particular patient, when he finally managed to come to us, we did a deep lateral orbital decompression along with a medial wall decompression, because he was already recalcitrant to whatever forms of therapy had been given to him. Now fortunately, usually when the deep lateral, here the idea is you make the bone, you take out the bone in the posterior orbit, because you essentially want to expand that posterior orbit so that the muscle spindles which are posterior get more space. You intend to give more breathing space to the nerve, and that's what we try to do. Now, this is him over a timeline of his pictures, but I'll go to the scan and that's what it showed. If you look at the scan on the left side is actually pre-surgery, and on the right side when the surgery has actually been done on both sides, but we would like to focus on the one where the arrows show, and the lateral actually shows that in the posteriorly we've expanded the bone, and medially we've allowed the medial rectus to prolapse. So if you look at the coronal, what it shows is, in these kind of patients where the therapy of corticosteroid, steroid, and radiation, rituximab was not working, we've actually allowed both the muscles to fall out of the nerve and give that breathing space to the nerve, and had a better vision restoration that was there. If we talk about what kind of surgery, obviously you can do a transcutaneous decompression medial wall for DON versus endoscopic. This was a lady I had done long ago, but an experience which taught me that immediately after the surgery, which was through a lens incision, you can see the scar there, her visions actually dropped right away. And she actually said, "The doctor, I can't see," the very next day. When I later asked, I found out that actually whenever she took up a dependent position, she slept for a few hours, she could not see. Which means that essentially in a thyroid eye disease who had DON, whenever she was taking a dependent position, because of the fluid retention, she was tipping onto the other side. And my surgery just helped her, do that, and despite the medications and all. So that was an experience. But essentially the thing is that one of the reasons in this kind of a hot orbit when you operate is much easier doing it without than doing it within. And over a period of time, we've moved doing endoscopic decompressions primarily from the fact that in these hot orbits it's much easier doing the medial wall with the help of endoscope, and then go on to do the lateral wall if you still need to do it for a large proptosis correction. Now, like I said, the morbidity is definitely an advantage. One key thing that one has to remember to do is to make sure that the ostium of the maxillary antrum is opened out large, so that you allow the fat to prolapse and you don't cause an obstruction of the ostium. Now, the technique that I follow is actually where you could either take out the ethmoid either with a Weil-Blakeslee forceps, or you could actually use a soft tissue debrider. But most often than not, we don't really go for the orbital process of the palatine bone, but even by removing the lamina right up to where the sphenoid is, in most cases, we get a reasonable prolapse of the muscle and get a decompression in the medial orbit. Now that's where the periorbita is opened up. In the kind of patient profiles I am talking about, where sometimes people talk about leaving a strip of the middle periorbita just adjacent to the muscle. What I would usually do is remove the periorbita entirely, and that is also one of the reasons why the prolapse is more. But I definitely make sure that in patients like these, I avoid doing anything to the strut, which defines the medial wall from the floor. Now, this is the changes is quite quick to happen, and this is the patient where the vision was 20/80, 20/60 at the presentation, and this is just one day after the surgery. His vision had improved to 20/30, 20/40, which went on to further improve over 1 week. And so the results are quite good, and whenever you need to. But there is a downside. You operate upon hot orbits, the risk of causing a new onset double vision esotropia is much more. We come to corneal breakdown. That's another thing that has to be dealt with, sight-threatening disease. This particular patient had both corneal breakdown, microbial keratitis, and also a sight-threatening disease. Sequential surgeries to take care of the orbit, the eyelid, and finally even the cataract that had developed over time. Finally, right eye vision was 20/25. Left eye has a dense corneal scar causing this vision to be less. Again, a case where there was a corneal breakdown and needed a right eye decompression, and the microbial and keratitis which had developed after the picture on the top actually settled down after that. Our group actually looked at all the patients of microbial keratitis with TED, about 1.3%, and active disease was one reason, and whenever muscle predominant disease was seen to be, particularly those cases tended to have the microbial keratitis. In our series, however, when we looked at risk factors for corneal breakdown, we did not find any as to risk factors. Management of keratopathy depends upon whether dealing with an active stage or an inactive stage. And in the active stage, of course, you need to have medical therapy and possibly also use IV corticosteroids to stabilize, and later you could possibly think about surgery. Tarsorrhaphy remains a very important tool in buying time, in particularly patients like these who present with very severe microbial keratitis. This is one patient who was a young but had microbial keratitis and essentially underwent surgery in both sides. So the only risk factor that she had, young age, the only major risk factor apart from, there was no other comorbidity, was extremely high thyroid function, which had happened over a short period of time. And that was the major risk factor which led to a profound presentation like this. Last, glaucoma is one of those patients, several times you face this, and the prevalence from the literature is about 3%. If you take ocular hypertension, it is much higher, but frank glaucoma based on disc changes in thyroid eye disease is about 3%. This particular patient had high intraocular pressures despite therapy, needed surgery, and the scans, again on the right side, if you see the benefit because of the prolapse of the muscle, it helped actually decrease the pressure, improved the vision, and he was put on azathioprine. So there was a pattern to it. Whenever you're faced with that difficulty, doing early surgery to give that breathing space and then putting them on medical therapy by turning the whole strategy around was helping in this particular group of patients. There is a role of radiotherapy also in patients where intractable glaucoma. In this one, we actually used radiotherapy. She had multiple comorbidities, and over a period of time, she settled down again after radiotherapy. This is the last set of slides I have, and essentially we needed to do something about this. And what we did is we tried to come together, all the people within India who had published on diabetes. We came together and worked on this review. And what was very, very interesting was that there were several intersection points between thyroid and diabetes. There was likely to be at the genetic level, at the peripheral level, at the hormonal level, at the fact there was obesity, there was vitamin D deficiency, leading to an hyperinsulinemic state and an inflammation reaction, a low-grade inflammation, which was possibly playing a role in both pathogenesis of worsening of the diabetes and also fact that thyroid eye disease was much more severe, particularly in the type 2 types. So there was much to learn there. And based on that, the current treatment strategies that exist, common ones, corticosteroid, radiation, even teprotumumab has its problems of hyperglycemia. So even if the drug is available tomorrow, we will still have our struggles in diabetic patients. This is what we propose, that in situations where you have thyroid plus diabetes, possibly a multidisciplinary care, if you're giving IV corticosteroids, a close glucose monitoring with the help of an endocrinologist is something that is really needed. And in those with poor control, possibly go for an early surgery followed by immune modulation is what seems to be working better, and that needs validation. So to summarize, I think our experience based on what is there in the literature on the sight-threatening disease, there was quite a bit to learn that in our group of patients, probably diabetes is a major risk factor, has to be thought about when we think about our modalities that we use for treatment, and those with poor control, possibly an early surgery from the point of better morbidity, maybe an endoscopic or otherwise early decompression, followed by immune modulation was the way to go. And this particular strategy possibly needs validation. Thank you.
Thanks, Dr. Sureshantara. That was an excellent, exhaustive talk and quite an eye-opener. So I'd like Dr. Ashim Dey to kindly hand over the memento to Dr. Sureshant. And in the meanwhile, I'll request Dr. Prabhisha Banerjee, is an Associate Consultant, Orbit and Oculoplasty, Shankar Netralaya, Kolkata, to present his talk on orbital infection and infestations.
Very good afternoon, everyone. At the outset, I would like to thank Shushrutai Hospital and Dr. Anirban Bhaduri sir for giving me this opportunity. So today we'll be discussing about orbital infections and infestations. I'll try to make it very concise. So we'll be discussing under the following subheadings. So starting with bacterial orbital infections. So why is orbit at risk for all this infection? Because of its location, it is proximal to the paranasal sinuses. The medial wall is very thin, as we all know, and it is adjacent to the ethmoid sinus, so it makes it very favorable for the infections to travel to orbit. Also because of the valveless orbital venous system, and these are the etiological factors that that can cause orbital infection, such as trauma, intraorbital foreign body, chronic dacryocystitis, dental infection, hematogenous spread from endocarditis, and immunosuppression state. So Chandler and Hubert, they gave this classification which shows the orbital complications that can occur from sinusitis. Now they basically said these are the stages, but it not always follow the stages. So starting with preseptal cellulitis, the most commonly we see in our clinic that preseptal cellulitis occurs secondary to a burst external hordeolum, or like acute on chronic dacryocystitis can also present like this. So there is eyelid edema, erythema. So the treatment is with oral antibiotics, anti-inflammatory, and hot fermentation. So this is one 50-year-old patient, uncontrolled diabetic. So the patient presented with left eye proptosis, diplopia, and inability to move eyes. There is a lot of chemosis. So as we can see, there is movement restriction. This is the MRI scan, which shows a lot of edema, and see, as you all can see, there is retrobulbar fat stranding, suggestive of orbital cellulitis. So this is the differentiating features between preseptal and orbital cellulitis. I am not going to go through them. This is another case which presented similarly, and the orbit was very tense. There was chemosis, proptosis. So these cases, they need hospital admission. We have to do a routine blood test, blood culture, and urine culture also, because sometimes UTI also can cause endogenous there can be endogenous infection foci. We have to treat with broad spectrum antibiotics such as augmentin, cefotaxime, and if any associated dental infection is there, better to start IV metronidazole also. Along with that, we can give NSAIDs. Once the infection is little under control, we can start systemic steroid along with nasal decongestant, and if there is associated sinusitis, we have to definitely refer to ENT specialist for clearing the sinuses. So with timely diagnosis and treatment, we can definitely save the vision and the patient. Now these are the complications of orbital cellulitis. Obviously this is a sight-threatening complication and these are all life-threatening complications. So early diagnosis and treatment is recommended. Now there are certain cases which can also masquerade as orbital cellulitis. For example, this patient, he also presented with proptosis, chemosis, but on MRI we can see there is definitely edema and see the muscles, these are all enlarged. So this was a case of thyroid eye disease. Definitely a better, detailed history and imaging will help us differentiate. For example, this patient also presented with congestion, chemosis, proptosis, and on scan what we can see is there is diffuse edema and especially in the subtenon space. This was a case of posterior scleritis. This is a post-op patient. On the very next day, he presented with this fullness, edema, ptosis. See, there is congestion and chemosis. But however, there was no pain. So this is basically a case of hyaluronidase allergy. These are the children. Obviously, this is not orbital cellulitis. So but this patient, it is a granulocytic sarcoma, and this patient was treated at orbital cellulitis initially. Unfortunately, we lost the patient. So it is always better if we have any doubt, we can do a peripheral smear in these cases. So this is another child who presented with dystopia, diplopia, ptosis. So on CT scan, we can see this typical dome-shaped subperiosteal abscess, along with ethmoid sinusitis. So usually children under 9 years, they respond to conservative management with broad spectrum antibiotics. So we don't need any drainage, but these are the indications which needs drainage for subperiosteal abscess. This was again another patient, 60-year-old female with chronic dacrocystitis. So patient ignored that for quite few years, and then once one day she presented with proptosis, chemosis. So this is a very tense orbit, and on imaging we can see there is an ill-defined lesion here, but on the coronal section we can see it is typically it is a peripherally enhanced lesion with multiple septae, and there is central area of necrosis suggestive of orbital abscess. So the treatment in this case will be urgent and adequate drainage of the abscess to treat with broad spectrum antibiotics based on the pus culture result. So cavernous sinus thrombosis is a dreadful and life-threatening infection. So this is the patient who presented with ptosis, bilateral ptosis. Patient was very drowsy. Because of the involvement of the sixth nerve in the cavernous sinus, obviously patient had esotropia and there were movement restricted. So on imaging we can see the cavernous sinus is involved. So these are all treated with broad spectrum antibiotics which have good CNS penetration like cephalosporin group. Use of anticoagulants and corticosteroids is still controversial. However, these patients have poor prognosis. Orbital tuberculosis can present as classical periostitis, which are basically ulcers which fistulas tract, or you can have soft tissue tuberculoma, like in this case. This patient presented with fullness and has a cold abscess here. So, or you can have a bony involvement. For example, this patient has a cyst here with bony erosion, as we can see in the CT scan. There can be spread from the paranasal sinuses, or patient can have tubercular dacroadenitis. This is a patient who presented with bilateral swelling, S-shaped ptosis with fullness, and there was pain. So on CT scan we saw lacrimal gland enlargement with edema. However, the structure was intact. So usually, generally, we treat these cases with oral steroid. But in this case, if we start oral steroids, so they can flare up. So we have to be very careful. We have to monitor them closely if we are starting on oral steroid. So in these cases, obviously, biopsy of the lesion is important. If there is bony involvement, there is fistular tract, we have to excise the whole fistular tract with debridement of the entire involved bone and send for histopathology and microbiology, and also a PCR. So on histopathology, we can see granulomatous inflammation with caseous necrosis, and this is Langerhans giant cells. Also, we have to take help from a pulmonologist who can start the patient on antitubercular treatment. This was another interesting case. The patient has undergone pterygium surgery elsewhere and presented to us, I think, 20 days after the surgery. So this basically happened because of the inoculation of the microorganisms during the peribulbar block. So this is periorbital necrotizing fasciitis. As you can see, the whole area is necrosed. So the organism most commonly responsible is group beta hemolytic streptococcus, which secretes toxins and which causes ischemia, thrombosis, and leads to this liquefactive necrosis. So on T-scan, we can see there is widening of the subtenon space. So it presents like, this is the clinical feature of periorbital necrotizing fasciitis. Unfortunately, this patient came to us quite late. However, the ideal treatment would be to do an early debridement as much as possible, and treat with broad-spectrum antibiotic. Usually, clindamycin is given. For us, the sensitive organism was MRSA, so we treated with cefotaxime, which was sensitive, which came sensitive. And later on, when the patient stabilized, we did a median forehead flap for this patient. So now we are moving to fungal orbital infections. So the most common fungal orbital infection in India is mucormycosis. Obviously, these, as we can see, these are the risk factors, which is quite after COVID, which have become
one more minute to go. 1 more minute.
Acquainted now. So basically, the fungus, the spores, they proliferate and they cause angioinvasion, thrombosis, and necrosis. So we have to do a complete examination. Patient can present with ptosis, proptosis. We have to see the oral cavity. There can be a black HR. Again, the nasal cavity also you have to see. We have to examine the peripheries also. This was a patient who was admitted during COVID. So yeah, as I told you, patient can present with ptosis, proptosis. There can be loss of ocular motility. So here in the MRI, so MRI with contrast, MRI brain and orbit with contrast is the ideal scan for this thing. Because contrast, we can see if the tissue or if the muscle is viable. So if it is viable, and like in this case, it is only involving the medial orbit, we can do a restrictive debridement and we can give transcutaneous retrobulbar amphotericin B and observe. If the patient worsens, then definitely we have to go for exenteration. So similarly, this is one case where there is necrosis. So it is not taking up contrast, it is already, the tissue and all are not viable now. So, and the patient had also lost vision due to CRAO. So in this case, we can easily go for exenteration. That will be little life-saving for this patient. This patient came with severe headache, and on imaging we saw the brain was also involved in this case. Obviously, this case carries very poor prognosis. So, Dr. Honavar et al. Has classified the stages according to the involvement of the structure. So, for our side, yes, we take ENT help, and then we urgent debridement is required for this patient.
No? Time is over, yeah.
Yes, sir. So, for debridement is necessary, and then we have to send the tissues for biopsy. In the meantime, we start the patient on liposomal amphotericin B and posaconazole, and depending on the involvement of the orbit, we can do debulking or exenteration. So similarly, this was a case which presented, it was a chronic case. He was having this for 3 months. And then on imaging, we can see this is so hypo-intense. The typical fungal lesions appear like this. So this was a case of aspergillosis. After biopsy, we came to know. So aspergillosis can be non-invasive and invasive. Usually the incompetent patient, they have the non-invasive form, and it is mainly restricted to the sinus. And invasive form occurs in immunocompromised patient. So the main basic treatment is with IV amphotericin B and voriconazole, and we have to check for the voriconazole trough levels also. So if it is responding well, otherwise we have to go for debulking and exenteration. Now briefly I would like to discuss the orbital cysticercosis. So here this patient presented with proptosis. This patient can present with proptosis, painful ptosis. On imaging we can see this is a hyperintense lesion with a scolex. MRI with brain and orbit is the investigation of choice, and the treatment is oral albendazole. We can follow them up with USG B scan. We can see the scolex is resolving here with the treatment. Similarly, this patient also resolved. This presented at ptosis. There was this cyst in the superior rectus muscle which resolved. So this is a very rare infection which occurs only in the endemic areas. And this is diadophiliasis which occurs, which is endemic to India in Kerala region. This usually presents as subconjunctival worm, and the treatment is excision and followed by with oral albendazole. So my take-home message is detailed history is very important in these cases. So imaging helps in the diagnosis, prompt management is needed, and it is case-based, and monitoring is definitely recommended. Thank you.
Thanks, Prabrisha. That was an excellent talk. I'll request Dr. Ashimde to kindly hand over the memento to Dr. Prabrisha. Next, we have Dr. Nandini Bothra from LVPI Hyderabad. She'll be talking upon non-specific orbital inflammation, otherwise called as pseudotumors.
Right. So hello once again. I know the gastric juices are being stimulated, so I'll try to keep it as short and crisp as possible.
That will be very good.
Okay. So I think my previous speaker has done an amazing job. She summarized all the possible causes where infection or where known causes cause orbital inflammation. So what I am essentially going to talk about is orbital inflammation where there is no elicitable cause. So NSOID, or non-specific orbital inflammatory disease, also called a pseudotumor or idiopathic orbital inflammation, is challenging. These are conditions in the orbit without any identifiable local or systemic causes and is essentially a diagnosis of exclusion. So when I say that it is a diagnosis of exclusion, we have to exclude all possible systemic and local causes before calling it an NSOID. So how do they present? They can have either an acute or an subacute onset of proptosis, periorbital swelling, erythema, pain, diplopia, loss of vision or diminution of vision, and they usually respond very well to corticosteroids. Now, as I said, again, disease of exclusion. So there is an exhaustive list. We have to actually exclude all these conditions before we call it a pseudotumor or an NSOID. So once these kind of patients present to us, what do we do? Do we start systemic steroids directly? Do we investigate first? And what is the role of immunomodulators? This is what we're going to discuss. So before we move on to cases, what are the investigations that have to be done in a case of NSOID in order to rule out all other systemic causes? So this is an exhaustive list. We start with a complete blood count, ESR, CRP, ANA, C-ANCA, P-ANCA, RA factor, MAN2, considering we are endemic for tuberculosis, chest X-ray, MAN2, test and quantiferon TB test form a very important part of this panel and the other tests. And suppose we have a positive test or something that is not responding to steroid, then we have to go ahead with a biopsy before going ahead with further treatment. So when we talk about NSOID, it can either affect only the muscles, where it is called, we call it as myositis. It can affect the lacrimal gland, where we call it dacroadenitis, or it can affect multiple tissues, and we'll proceed ahead accordingly. So this was a lady, around 60-year-old lady, who presented to us with proptosis, ptosis, and restriction of motility. Now she already had a history of NSOID. She was treated with steroids initially, and apparently she was started on Azoran after that, but she was not tolerant to Azoran, and hence she stopped the medications. So 1 year after she stopped the medication, she had a recurrence of this episode, and she presented to us. And she also had a diminution of vision in the left eye, and when we looked at the fundus, there was blurring of the disc margins. So we asked the patient to get a CT scan, and what is typical in a myositis is the involvement, is the involvement of the tendon. So I think Dr. Surya showed us a lot of scans where the muscle was enlarged, but in thyroid, essentially the tendon is not involved, whereas in orbital myositis, the tendon is involved along with enlargement of the entire muscle belly. So here we see characteristically there is crowding at the apex, and that is causing the blurring of the disc margin and the loss of vision. So we started her on IV steroids, that is IV methylprednisolone 500 milligrams BD for 3 days. We completed a course of 3 grams. Her proptosis sort of became better. Motility did not improve, and I will come to that why. But the vision improved to 20/20. So she was doing well. We sent her back and called her back after 2 weeks, which she did not do. But she presented to us again 1 month later with similar symptomatology, and this time the vision was just finger counting close to the face with an RAPD of grade 1. So here again there was reactivation of the disease. We started IV steroids. Before starting IV steroids this time, we asked for the entire panel of systemic investigations, which was which was within normal limits. With IV steroids, she definitely improved. At this stage, we then started her on tapering oral steroids, and along with that, oral methotrexate and chloroquine tablets were started by the rheumatologist in order to continue it long term, since this was her 3rd or 4th recurrence. And presently, we have a 6-month follow-up post that, and she's doing well on these medications. So usually when you have a single muscle involvement, they respond very well to steroids, and they generally do not have a recurrence and may not need further investigations or biopsy. But if there are recurrences, it is best to go ahead with investigation and a biopsy to rule out other causes of myositis. When you have more than one muscle involvement, when the involvement is not very severe, again, we can directly go ahead with steroids, and only in cases of relapse, we can go ahead with a biopsy. So wherever we have an atypical involvement, like this particular patient had involvement of the lateral rectus, where there was gross enlargement of the lateral rectus and a minimal involvement of the lacrimal gland as well. In these kind of situations, it is best to go ahead with biopsy first, because it is not only involving the muscle but is involving the other structures as well. So biopsy investigations find out the cause. If there is none, then can go ahead with steroids and immunomodulatory management. So idiopathic orbital myositis is more common in females and is seen almost in 3rd, 4th or 5th decades of life. The most common is a single muscle disease, and the most commonly affected muscle is the medial rectus. Recurrence is seen in about 15 to 56% of the cases roughly in different case studies, and the clinical features where we see a recurrence is mainly when it's affecting the males, when there is multiple extraocular muscle involvement, and where there is lack of response to corticosteroids. These are the cases where maximum recurrences are noted, and they need a longer duration of treatment, and hence immunomodulators need to be started. In cases of chronic orbital myositis, like our first lady, what happens is because of repeated attacks of inflammation, the muscles undergo fibrosis. And then even after resolution of the inflammation and the patient coming back to normal, the motility really does not improve because there are already fibrotic changes in the muscle. So in cases of chronic ocular orbital myositis, we do not expect the ocular motility to improve. Now coming to the second part, that is idiopathic dacroadenitis. This is by far the most common presentation of orbital inflammations. Up to 46 to 78% of these cases are idiopathic. However, when you see these in children, the most common cause would be viral. So this is a list of systemic associations where we have specific and non-specific dacroadenitis. Again, when you have dacroadenitis, start systemic steroids. Most often than not, they resolve and they do not recur. The other modalities of treatment are intragranular or juxtaglandular steroid injections, where you take 40 milligram triamcinolone injections, inject about say about 0.8 to 0.9 or 1 ml directly into the substance of the gland, and it also tends to work very well. Certain places they do surgical debulking as the primary modality of treatment. So again, the orbital lobe is debulked about 40 to 60%, and that itself acts as a that itself treats the dacroadenitis. Now, where do we have incomplete response? As in myositis, male sex, or where inflammation is extending to an extraocular muscle, or it is painless. Now I'll come to it why in painless cases there is a lesser effect or more chances of recurrence, and weak association with sclerosing histology. Whenever you have bilateral dacroadenitis, now these are the cases where I would say do not start steroids first. These are the cases where first go ahead and investigate, because whenever we have bilateral dacroadenitis, always suspect a systemic cause like sarcoidosis, tuberculosis, IgA-related disease, Sjogren's syndrome, Shrug-Strauss syndrome, or previously Wegener's and now granulomatosis with polyangiitis. So whenever you see a bilateral dacroadenitis, suspect systemic causes, investigate, do a biopsy, and then go ahead with treatment. Unilateral dacroadenitis, start steroids, and then based on response, you can modulate the treatment. Now, when I said painless cases have more amount of recurrence was because typically when a dacroadenitis is painless, it is usually IgA-related disease or a sclerotic disease. And when we have sclerotic or an IgA-associated disease, they have very poor response to steroids. And they do need immunomodulatory treatment. So just initially, the steroids will act wonderfully, it will resolve, and then it will relapse back. So if it is relapsing back, think on the lines of an IgA-related disease, get an entire full-body systemic workup done, especially the pancreas, because it is known to cause pancreatitis, and then go ahead with the immunomodulatory treatment. Now coming to the last part, that is generalized NSOID or intraocular or those involving various structures. Now in these situations, at least my practice would be to take a biopsy first, investigate, and then go ahead with treatment, because the high probability of these being sclerosing NSOIDs or IgA-related disease is very, very high. That therefore, I would suggest in any generalized NSOID, before labeling it as NSOID, go ahead, do a biopsy, do the entire investigation panel, and then start treatment. So thank you.
Thanks. That was an excellent talk, Nandini. And just like to emphasize that we should have a low threshold for biopsy in NSOID, especially in when the lacrimal gland is involved. So having said that, last but not the least, we have amongst us the host himself, Dr. Anirban Bhaduri, the consultant, oculoplasty and ocular oncologist at Sushruta Eye Hospital, and he'll be talking upon orbital fractures and its management.
Good afternoon, ladies and gentlemen, and thank you for your patience. It's lunchtime, but you're still here with us. Thank you very much for that very warm gesture. So I'll just quickly talk about orbital fractures. If I exceed time, please stop me. The first question, of course, is always for residents. Have you heard this old proverb, if you forget your history, you are condemned to repeat it. So if you forget your anatomy, you're condemned to have a bad time in the operation theater. Nothing beats anatomy when it comes to surgical fields. So we'll quickly look at the orbit. The orbit is pyramidal in shape, it has 4 walls, and the thinnest wall is no response. The thinnest wall is medial wall. And which is the wall which is fractured most often? Sorry? Low wall. Can you explain why? Why is there this dichotomy? We'll take it up at lunchtime then. Please don't leave. Okay. 2 things about orbital anatomy. Pictures look nice. These are pictures from Dr. Dutton's atlas. Dr. Dutton happened to be an anthropologist before he became an ophthalmologist, and he actually spent time in Calcutta Museum. Dr. Jonathan Dutton has a very famous treatise on orbital fractures, which I hope you take time out to read. But look at the shape of the floor. Now the floor is not a flat surface. The floor is concave upwards anteriorly, and it is convex upwards posteriorly, as well as it rises up to meet the medial wall as it progresses posteriorly. So that's one complexity of shape. This, of course, is the infraorbital canal through which the infraorbital nerve passes. It is not a part of the orbit. We do encounter it in fractures. What we need to do is just dissect carefully and let it fall back. The next complexity, so this is what the floor looks like. This is fat, and this is entrapped muscle here, and a tiny fracture. Okay? What view is this? This is the sagittal section. Okay. The second complexity is the medial wall. So diagrams would make it look straight. Now this is decided by the ethmoidal air cells. So you see that sinusoid appearance, slight bulge posteriorly. This again varies from patient to patient. So here is a large bulge posteriorly, and this is again something you have to take into account when you're doing surgery which involves the medial wall. Look at this. This is a patient who had been kicked in the eye by a cow, and his eyeball, half his eyeball is actually in the nasal cavity. Okay. The other problem is the anatomy is not the same in children. Children have softer bones, elastic bones, unlike adults who have brittle bones. The second is, the other issue is that the sinuses don't develop at the same time. So children below the age of 7 are more likely to have roof fractures. Around the age of 7 is when they start developing a significant maxillary sinus, is when you start seeing floor fractures in children. Okay, different kinds of fractures. So the fractures that we as ophthalmologists usually have to deal with are the blowout fractures, which are otherwise known as the pure orbital fractures, because the rim is not involved. The first thing you do when you're examining a patient of fracture is, of course, vision. You look for eye injuries, but you look for motility. Very important. And you palpate the orbital rim all around. Okay. Sometimes you encounter in very recent injuries, that is the same day or the next day, you will also encounter a crackling feeling of surgical emphysema. Okay, now we know there are 2 possible ways that blowout fractures can happen. One is the hydrostatic theory, where the orbital pressure increases over the soft tissue, and that allows the bone to break away, and that might be a safety mechanism created by the great designer above. The other is a direct impact on the bone which causes buckling, which also could be the possible cause of a fracture. The debate is not settled, and it is not important. Okay, look at what is there in this patient. So you see this deep superior sulcus. You see the eyeball which is actually lower down. This is what you often see in adults, a hypoglobus, and this is what shows that you have enophthalmos. And look at the large orbital floor fracture that you have here. Okay. Another situation where you have a smaller fracture, and you can see that a part of the fat as well as the part of the inferior rectus muscle has descended. Okay. But you can also have subtle fractures like this patient, very recent injury, She has full motility, and this is one situation where you do not need to subject this patient to surgery, which is absolutely not indicated. What about other situations? You can also have pure medial wall blowout fractures, like you have in this patient, and you can see the incarcerated medial rectus muscle. Or you can have, as I showed you in that patient who got hurt by an animal that he was trying to milk. So a large blowout fracture of the eye where the eyeball is impacted into the nasal cavity. And you can also have a situation like this, where you have a combined floor and a medial wall fracture. These are all blowout fractures. This patient had an incarcerated medial rectus, which had to be released when the surgery was done. Okay. So how is it different in children? Now in children, as we were saying, they have soft elastic bones. When the intraorbital pressure increases, the bone slides down, there's a fracture, the soft tissues get entrapped because the bone snaps back into place. Okay, and they present differently from adults. So look at this boy. So this boy was in a karate class. It was, I think this was one of his championship test. And when he looks up, you see his eyeball doesn't go up, but his eye is white. These patients are often misdiagnosed and mistreated as acute appendicitis or acute abdomen or even a head injury, when actually the problem is an oculocardiac reflex, which is operating in this situation. And they have white eyes, which is why these are known as white-eyed blowout fractures. Why we are highlighting this is that this is often missed by our ophthalmology colleagues. As compared to an adult patient who has a large orbital fracture, the inferior rectus is practically in the maxillary sinus, but there is no restriction of eye movement. Okay, he has severe inophtalmos. So this is the same child looking down, there is no abnormality, looking up, his eyeball just doesn't go up. And you can do a force duction test, and you're supposed to do a force duction test for all these patients. And that would confirm that you have a entrapment. So this is the scan, a small fracture here, a hairline fracture. Okay. Another recent child, this boy, 6 years old, fell off his bicycle. And look at him, he cannot look down. Without diplopia, he cannot look up. And this is more often seen with posterior floor fractures. Okay, other fractures. You have what was known as the tripod fracture, which is better described as a pyramidal fracture. The ZMC fracture, or the zygomatico-maxillary complex fractures. And here you will see there is a difference. The inferior canthus has come down because there is displacement of the zygomatic bone and the attached lateral canthal tendon. So this boy also presented with severe inophtalmos. This happened to be the first surgery that I participated in once I returned to Calcutta, and I wouldn't have done it but for the invitation from the maxillofacial surgeons. So please understand that there are ophthalmologists who do fractures, they're known as oculoplastic surgeons. There are dentists who do facial trauma, and they are called maxillofacial surgeons, and we are honored to have 3 of them with us today. So please direct your questions to them. Okay, you have another set of fractures which involve the naso-orbito-ethmoidal group of bones, and they can be classified by the maxillofacial surgeons as Markowitz 1, 2, and 3, depending on whether you have one fragment with the medial canthal tendon attached, or multiple fragments but the medial canthal tendon is still attached to bone, or the medial canthal tendon is detached from the bone. These are the 2 situations where you would actually get a medial canthal dystopia. It's important to recognize and repair. Okay. Why is this important to the ophthalmologist? Look at the area of involvement. This is where the lacrimal drainage system is. Now, the third, which is the most famous. You know the story, this gentleman used to go rob graves and then go and hit the skull with a hammer and find out which are the lines along which fractures happen. So you have the Lafort 1, which is not important to the ophthalmologist, but 2 and 3, they again run through the nasolacrimal drainage system. 3 is bad. In 3, the entire mid-face and the lower face is detached from the cranial bone. And these patients are at high risk of airway obstruction. So the first thing that needs to be done is stabilize their airway before they can be taken up for surgery. Maxillofacial surgeons are under pressure because they need to operate much earlier than ophthalmologists because the bones may fuse in the wrong position and develop in a malocclusion. So Lafort 2 and 3 are important to us, and this is the patient which shows a Lafort 1 fracture, He's also got a mandible fracture, he's got a LaFort 2 fracture on this side, and a LaFort 3 on the other side. So you can have a mix of fractures. Okay. You can also have fractures which involve cranial bones. So this is a patient who had an injury. Again, he was riding a scooter for the first time on Saraswati Puja, class 10 board exams. Pujana Dila Havana. And this is what happened to him. But he survived. We'll come to his story later. Now, what are the indications for surgery? Very simple. Number one is if there is a motility restriction where you can show that there is an entrapment of the muscle or because of dragging of the orbital tissues into the maxillary sinus. And enophthalmos. So enophthalmos is a situation where a patient may or may not choose to undergo surgery. That's a choice you can give them. Some patients choose not to. We recently had a surgeon who had a fracture, one of the professors in a medical college in West Bengal, who did not undergo surgery because he was operating from the next day onwards. He's on follow-up and he's doing well. Okay, how do we go about doing the fracture repair? The purpose of the fracture repair is to restore the orbital structure and function, and of course the volume. Sorry, for the misspelling. And how do we go about it? The first thing, of course, is the incision. We go through a hidden incision, the transconjunctival incision, which is known as the swinging eyelid incision. You release the tissues that have prolapsed, and then you reduce them back into the orbit, and then you have to place some material on the orbital floor and bridge that gap so that the tissues do not prolapse again. So it's that easy. And you have a choice of implants. So you can have implants which are either biological, like iliac bone or cranial graft, bone graft that is usually taken by maxillofacial surgeons, but then there are other options also, like these sheets like silicone and Teflon. We still use silicone in children with hairline fractures. You also have other material like porous polyethylene. So people like me, we used to operate with porous polyethylene or silicone until porous polyethylene went out of the market in India. And that is when our maxillofacial friends taught us how titanium implants are used. You can also have integrated implants which have both titanium along with the porous polyethylene. You can have modern implants which are reabsorbable, like the osteomesh, which uses the same material that is used in Vicryl. So it's polyglycolate. And these are various polymers, and these implants gradually go away with time. So it usually lasts for about 9 months, and the implant is absorbed by the time bone is laid into the mesh. This is porous polyethylene. This is a titanium implant, these are the two materials that we generally use. What is important is that you have to expose the entire fracture. Okay? And very important is to identify this particular structure, which is known as the posterior ledge. So this posterior ledge is important. See, this is one of the patients where we had operated where after surgery his enophthalmos did not go. Why? You'll see very soon. So this is the posterior ledge here, is because the implant had slipped. So when we were tightening the screws, at some point in time the implant had slipped, and there was no correction because you did not restore volume. So his function is there, right? Your structure is not there, your volume is not restored. So it's important to identify this posterior ledge. There are several ways of doing it, but what you can do is simply pass a spatula. If it goes directly in, it actually goes and hits the back of the maxillary sinus. So come along the maxillary sinus, identify the posterior ledge, and that is where your implant has to sit. So this is a very recent surgery that we've done. This patient had both floor and medial wall fracture. And once you have properly positioned implants, this is the result that you get. Perfect placement of the implant. So this is the implant, the higher density structure that you see here. Okay, this is a child who's undergone, this is the Karate Kid. And see what happens when his movement is restored because you've released the... So this patient presented 3 weeks late. Again, why? Because it was not identified on time. So he still has a little residual diplopia in upgaze. This is a silicone sheet implant. This is the patient we were describing. The first patient where I got involved is where we learned how to work with a maxillofacial surgeon. So the maxillofacial surgeon does the facial repair, puts everything back in place, and This is the mini plate and screw system that they use to put the zygoma back. And that is when you get a nice stable frame on which you can put your floor implant. So this was a porous polyethylene implant.
Sir, kindly conclude.
Yeah. Do I have any time left? We'll forget about buttresses. This is something we need to learn from the maxillofacial surgeon. And these are surgeries that they would be. So this is a very interesting patient. The boy who was riding a scooter and he rammed into a truck. Do you know what is this material? This is his injuries. That is brain. He had brain matter spilling out of his node. He had brain matter in his trachea. When the anesthetist was intubating, they actually had to aspirate brain from the trachea, from the airway, to be able to put a tube in. And this is the boy. He's alive. And this is a situation where another member of the team comes in. So you have the maxillofacial surgeon, you have the neurosurgeon, and you have an orbital surgeon operating together. So teams are extremely important when you're managing complex injuries, and that is what gives best results to your patient. You cannot have the cranial surgeon do one surgery, maxillofacial surgeon come on, do a second surgery, orbital surgeon coming in last. So if you can work together, you give the best possible results. We'll skip this. Okay, I'm done. Yeah,
okay.
It's very important that you identify fractures, number one, and more important that you identify children with fractures, because if you don't give early surgery there, the child is going to be maimed for life. Thank you very much.
Thanks a lot, sir, for your excellent talk. So I'll request Dr. Ashim to hand over the memento to Dr. Anirban. I'll request the audience to kindly stay back for a few minutes more for the discussion. So the first session was on orbital imaging. I guess Dr. Sumita Kundu has left, so but we can still have questions for the panelists regarding orbital imaging if we have any from the audience. Do we have any questions on orbital imaging? Okay, I think we have a lot of questions for Dr. Suryashant Rath, who talked on extensively on thyroid eye disease, side-threatening thyroid eye disease. So Dr. Suryashant will be happy to take questions.
Shahid, you also have the opportunity to talk to a radiation oncologist who's here with us and a rheumatologist who's there with us who would jointly help us in managing thyroid eye disease patients.
Sure. So we can take up the questions. Any questions regarding thyroid eye disease, side-threatening thyroid eye disease?
Hello. You have shared IV methyl prednisolone, cumulative dose 4 gram.
The usual protocol is to give within 8 grams, and the European group talks about a cumulative of 4.5 in one cycle. But there is also, in patients who don't respond to the initial, then the new guidelines actually talk about 750 milligrams each one, and 12 cycles would make 7.5 milligrams.
How many cycles?
12 cycles, so
12
6
cycles.
plus 6, yeah. Total, over one cycle.
What is the gap?
The European group that I follow is a weekly protocol, but to be honest, actually multiple different regimens have been talked about. You don't want to do a few things. You don't want to put the patient on a high-dose steroid every day. Some people give 3 days, alternate days, and then give a larger span of time. But I think the idea is to give pulse steroids. That means you give the patient a pulse of high-dose steroid and let the immune system respond. The interval between 2 injections on the European group protocol is 1 week. Is 1 week.
1 week.
But you have other regimens also.
Thank you.
Yeah, I'm a rheumatologist, so I'm very new to this thyroid eye disease. So what I read from the, I'm going to speak on basis of immunosuppressives. So we deal with life-threatening diseases like lupus and vasculitis. So where we give up to like 3 days of IV methylpred, 1.5 to 3 grams. So the world is talking of, so steroids are a killer, not only a diabetes. Steroids are the killer. Steroids are the biggest cause of infection. So we are now talking of all steroid-sparing regimens. So in diseases, say like a mild disease like a rheumatoid arthritis, where we expect that we can taper, we give maximum so like 10-15 mg of plain prednisolone. We start with methotrexate. But where we give so much of solumedrol, we need intense immunosuppression, and that too upfront immunosuppression. That means the first day of solumedrol, you start immunosuppressive. And what is the exact choice of immunosuppressive, and we need to know at what time point we expect this immunosuppressive to act. For example, whatever I read, that the usual drugs that have been used is mycophenolate. So the dose of mycophenolate that is prescribed is 720 mg, but 720 mg for a disease like say lupus and all is way too low. So we started say 10 days of 1 gram, then straight away go to 2 grams. And that 2 grams continue, you can, this 2 grams is going to act in 8 to 12 weeks time. It will not act immediately. So till that time you can give solumedrol, but we need to give 2 grams of mycophenolate. Again, I don't know why they have recommended mycophenolate sodium, because we commonly use mycophenolate mofetil. So patients who have GI intolerance, we use mycophenolate sodium. The second thing, when you are using mycophenolate, any group of mycophenolate, what we need to know that food or any drug impairs mycophenolate absorption. So if you are prescribing mycophenolate, we need to tell the patient that please do not take any food or medicines within 1 hour before or after taking mycophenolate. For example, say the patient wakes up at 6 a.m. in the morning, takes mycophenolate as the first drug, and till 7 o'clock, do not take anything, no thyroid, no other medicines. The next dose is to be taken at 6 p.m. From 5 to 7, they should be totally empty stomach. The third thing that needs to be mentioned, that PPIs, which are very commonly used for these patients because they are on a high dose steroids. So PPI is one drug that is going to stop mycophenolate action. It will totally impair mycophenolate action. So avoid using PPIs as much as you can, or schedule the dosage to other times, or you go for ranitidine or say plain Digene, because such an important drug, when we are using, we want this drug to be absorbed totally fully. The second thing is about the ensuring compliance. So mycophenolate is a costly drug. An average 2 grams mycophenolate in a month brought from a shop costs about 6,000 rupees. So as we use these drugs right and left for our patients, so if directly brought from companies, it costs around 2,500 to even the costliest comes to 4,000 rupees. So directly brought from shops, most patients end up stopping mycophenolate after certain times, and that is the cause that relapse. So at every visit, we need to ensure compliance. The second choice of drugs, like in vasculitis, what we are doing now is give upfront rituximab. So 2 doses of rituximab, and we can taper the steroids. There has been some of the trials in lupus nephritis or even in ANCA-associated vasculitis to give upfront rituximab. So we can taper steroids further. We don't even dream of giving so much of solumedrol, because it's going to have like osteoporosis and even increase the intraocular pressure. Helicizumab, we don't use very commonly. We have very few limited indications, but there are, I asked the entire rheumatology fraternity. So some of them have used, it's 8 gram per kg every month for 6 months, but again, it's a costly drug. And again, the companies manufacturing have different kinds of patient support programs which ophthalmologists may not be aware of. The other drug is cyclosporine. So cyclosporine again has side effects like increase the blood pressure and all these things. So I think mycophenolate and rituximab should be the drug of choice, and they should be used upfront rather than late.
Yeah. No. So I think absolutely very good points, and particularly related to the the fact that mycophenolate has to be taken, particularly the around no other drug and PPIs. But I think the message is 2 things is very clear. Number one is that
there is an increased, I would say, tendency, and it's pointing towards going out of a over-reliance on corticosteroids.
Yeah.
That's the message.
Yeah.
And the choice of the disease-modifying agent of which immunomodulator is where, as far as we are concerned, we definitely leave it to the choice to the rheumatologist or somebody who knows how to choose which one. In our practice, it is predominantly mycophenolate, azathioprine, methotrexate in that order. And I think I absolutely agree that actually the idea is to start mycophenolate right from the beginning while you give your 6 cycles, because you want the response to come at the same time the immune modulation to take effect.
And even like increased intraocular pressure, that is a huge concern regarding use of any dose of steroids. So what is told in our literature, even 5 mg of prednisolone taken for 3 months is toxic. It's a toxic dose.
But then, you know, it's like it works
we
both
cannot,
ways.
Yeah, we cannot totally avoid
Sometimes the intraocular pressure is
Yeah.
because of the muscle thickening,
Yeah,
and that
yeah,
would come down when the pressure comes down.
I just want to add a small point. I recently had a very bitter experience regarding rituximab. Though we know that rituximab is a very, very safe drug, last week we had a patient while we started that medicine, and the patient went to developed an anaphylactic shock. So this is an information to the audience that whenever you will start this type of medication, so it is better to start it in the ICU, and your gadgets will be ready to if there is any problem, so that you can save the patient. So that is just add to.
Okay. Actually for us, rituximab is not at all a very safe drug. We have seen, we routinely give like methylprednisolone. Most of our cases where we give rituximab, we admit patients in rheumatology, we admit patients in ICU, HD, or where monitoring facilities are available. Rituximab can cause, of the biologics used, rituximab can cause anaphylactic reaction. The second comment is regarding this inflammation of the orbit. So the rheumatologic diseases are very frequently causes this kind of orbital inflammation. So of these, it is not that all rheumatologic diseases will cause involvement of the orbit. So input of the rheumatologist will help you in many ways. So first thing is curtailing the investigations. So that list of investigations, every disease does not cause, rheumatoid arthritis doesn't cause the involvement of the orbit. So it's hardly 3 or 4 diseases. So we can curtail the investigations. Secondly, all these investigations need to be done by particular techniques. So until and unless we mention the techniques, so like in a profile needs to be done by a particular technique. So until and unless we mention the technique, the patient will end up getting a wrong report and doubling the charges. They may have to redo the investigations again. Thirdly, the other thing is this rheumatologic disease may have, some of them may not be test positive. So ANCA-associated vasculitis may be a phenotypic. We know that this is a phenotype of vasculitis. This is going to be ANCA-associated vasculitis where even PR3 or MPO may be negative. GPA is famous for orbit involvement. So their patient might give some history, which patient might not give to the ophthalmologist. They might not consider that it is something to do with eye. So it might have happened, patient might have got his past history of say scleritis or something. So that history, careful history taking can be done by a rheumatologist. And regarding the choice of drugs also, a rheumatologist might be of a huge help. So curtailing the investigation, curtailing the drugs, the cost of therapy, all these things, the rheumatologist's input is greatly helpful in this regard.
Yes, sir. Thanks for your comments. I think we can further discuss it over lunch. Thanks, sir. Sir, do you have any experience with rituximab?
I just wanted to quickly add to those. Between the two, actually, rituximab, in my experience, has not worked well. Most of the literature tends to say it can only be used as an adjuvant. Even if you look at the literature, there is a divided house where one study says it is good, others no. In a case where it is recalcitrant, I want to use a biologic, the one I would probably think of using is tocilizumab today.
Okay, thanks a lot. Sir, please.
So my question to Dr. Rath. So being a radiation oncologist, I feel that probably the best time for offering radiotherapy is the acute inflammatory phase. So when do you send your patients for radiotherapy?
Yeah, so radiotherapy in our experience and also what is predominantly seen in the literature works best when you do it in the early progressive phase. For most patients, unless the patient is a very chronic smoker and things like that, it comes to usually the first 6 months of age. 6 months of onset of disease. Now, if 6 months is you take, then usually it is seen that if you are picking up that disease early where the patient has not developed a diplopia in primary gaze, then the muscle type disease responds very well, and you could actually end up with a situation where you will have the entire double vision in extreme cases disappear, the muscle settling down over the next 6 months. So that's the period, and the protocol, the most commonly followed is that 10 fractions and 2000 is the total that is given. So, but there are multiple other protocols which you can, make it weekly 1 to 2 gray, and that kind of thing is also described.
Okay, thanks for those comments. So we are running extremely short of time. So I think rest of the questions can be taken up at lunch. I'll request Dr. Anirban to kindly felicitate the panelists, please.
So, Professor Dey, I would request Professor Dey to give token mementos to all the panelists who are there with us. This has been the most powerful panel discussion I've ever seen, with the entire spectrum of luminaries. Professor Chandra Chakraborty, ma'am. Dr. Sandeep Pachisia. The discussion is not over. We'll carry on over lunch. Huh? খিদেটা বাড়লে ভালো না? Dr. Sharup Pathak. Dr. Sharup Pathak is one of the pioneering oculoplastic surgeons from this very institute. Dr. Shuman Mallik. Dr. Siddhartha Chakraborty. We haven't discussed fractures at all. Please, I request everyone to catch them as soon as we break for lunch. And Dr. Abro Chandra Chaudhary. Thank you so much for a very illuminating discussion. We need to have more of these sessions where, people from across specialties sit together, because that would give the best results to all our patients. Thank you very much. It is not over yet. I would request Dr. Yasin sir, please, to give a memento to Dr. Ashim there. Sir. And Dr. Kumkum Ghosh. Madam had moderated the first 2 sessions. Thank you very much, ma'am. So she is the only one who is not an oculoplastic surgeon, but she selflessly gave her Sunday to us. Please, ma'am, please come down. Kumkum, samne chole ashun. Before we break, I want to invite Mr. Bishwajit Bhomik. He is from Indico Excel, the company that made this program possible today at very short notice. Mr. Bhomik, please come forward and speak a few words. And they also have a small presentation for us before we break for the vote of thanks.
Just one moment. I'm sir's student from Arjikar. He's one of the best teachers I've ever seen, and his knowledge is beyond comparison. Thank you, sir.
Dr. Pal is here. Sir, please come forward. We have Dr. Humagni Ghosh with us, who made the presentation that Dr. Josh gave to us, and who actually initiated this partnership between ophthalmology and plastic surgery. Dr. Ghosh, are you here? Please come forward. And lunch is served on the 8th floor, which is the floor above us. As soon as we are done, please join us upstairs for lunch.
First.
एक हंसी मैं तुझको दे दूं, एक हंसी तू मुझको दे, एक हंसी शुरुआत दे और एक हंसी जो साथ दे, खुशियों की इस लेन देन में आओ सजाए उम्मीदें, ओ खुशियों की इस लेन देन में आओ सजाए उम्मीदें। एक हंसी है मान की और एक हंसी अरमान की, ओ, एक हंसी है उड़ान की और एक हंसी पहचान की, एक हंसी सपनों की है और एक हंसी अपनों की भी, एक हंसी मैं तुझको दे दूं, एक हंसी तू मुझको दे, खुशियों की इस लेन देन में आओ सजाए उम्मीदें।
Indoco Remedies.
So, good afternoon, respected doctors. I would not take much time because I understand the situation. First of all, it gives me an immense pleasure and privilege to, as a Indoco people, to address like a vibrant, respected doctor, sir. I would like to thank Shushrut Eye Foundation to have the opportunity to be a part of this prestigious game or presentation. And I would specially like to thank Dr. Paul, Dr. R.C. Paul, all associated doctors attached to Shushrut, and very, very specially Dr. Bhaduri, Dr. Anirban Bhaduri, for giving us the opportunity to be a part in this special program, sir. Thank you very much, sir. Thank you very much. Please encourage us or indulge us in this way so that we can get associated with such academic and oriented programs like this way only, with all corporate hospitals as well as under OSWB banner, sir. So, thank you, sir. And last but not the least, I request all of you, sirs and madams, to give a great round of, applause to Dr. Bhaduri, all doctors presented here to make the program successful, and all other people who have worked from behind, also they have made the program successful. So a great round of applause to all of them, sir. Thank you, sir. Thank you.
Good afternoon. We've come to the end of the session. It's time to thank everybody for the wonderful audience that we have here today. A special thank to all the heads of departments from various medical colleges across Calcutta and West Bengal who made this possible. Thank you, sirs and madams. Thank you very much. Another vote of thanks for the audience or the young people who have come here. We hope you like oculoplasty and some of you at least would take up this as a career, because there is more to ophthalmology than just, that little bit of area between the anterior and the posterior capsule. So there's more to ophthalmology. And as you've seen, we had a fantastic faculty of specialists beyond ophthalmology who also remind us that ophthalmology is not confined to the eye. The eye is only a small part of your entire body. And diseases which you see manifest in the eye actually have correlations beyond. And without their help, we are not able to do the best that we should for our patients. Thank you, faculty, honored faculty, for having come and joined us today on a Sunday. But yeah, you've been wonderful. Thank you very much. To our students who worked behind the scenes, I will not name individuals, but thank all of you for the work that you've done. The smoothness that this program has been there because of the work of our students and of our staff. Among our staff, I would specially mention Amit Pal for having done a lot. A lot, and Mr. Pradeep Ghosh, who has worked tirelessly to get this entire audiovisual system into place for this first of programs that will be following. Thank you very much. And to all our staff, thank you so much for having spent your Sunday with us and ensured a very smooth program. This is what I normally do on Sundays, but with such a brilliant audience, this is something I'm willing to give up as well. And last but not the least, today's program may have come to an end, but just to remind you, we have another major program on ocular oncology that we are planning for the 1st of October. The date is defined, the time is defined. We hope to have a similar wonderful audience the next time too. Thank you very much for all having been here. And Dr. R.C. Pal, most of all, when he asked me, how many people do you expect? I said 40. He said, no, I'm sure it's going to be a little more than that. He believed in us, and then when the registration started